स्लीप तक, लिवर से लेकर हार्ट तक,
बाल रोगों की कहानी दिल से जाए दिमाग तक।
जीन से लेकर स्लीप तक, लिवर से लेकर हार्ट तक,
बाल रोगों की कहानी दिल से जाए दिमाग तक।
नागपुर से न्यूयॉर्क तक फूलों को बातें चले, सारे के सारे साथियों को लेकर NAPCON चले। विज्ञान के बल पर स्क्रीन से जुड़कर चलते ही चलते चले, सारे के सारे साथियों को लेकर NAPCON चले। सारे के सारे साथियों को लेकर NAPCON चले,
सारे के सारे साथियों।
Thank you. Yeah. Good morning.
Good morning, sir.
We are really honored here, madam, that we have got both the patient, Dr. Bakul Parekh sir, patient, national patient, Dr. Piyush Gupta, national patient elect, and we have got patient candidate, Dr. Vasant Katkar, and we have got even Jayan Pandikar, patient Maharashtra. So we are honored, and the chief guest, no less than most respected pediatrician and lady of the India, Lieutenant General, Dr. Madhuri Kanetkar, who is the heart of India and heart of all pediatricians. Thank you, madam. And we have got Shubhada Kirwadkar, Pandikar, and Mustafa Ali, and definitely we have got the best orator of the India, Dr. Uma Ali, madam. We welcome you, madam. Yeah.
And sir, we welcome our patron of AOP.
No. No. Thank you, madam. Thank you. We are really honored that Dr. Piyush Gupta, Dr. Bakul Parekh, they both, and Dr. Jayan Pandikar, and also we will be having soon Dr. Jayan Upadhyay, who got elected as National Vice President. He will also
Dr. Sadachar, Secretary Maharashtra IIP is also there.
Achha, he is also there.
Our NAPCON booklet editor, Dr. Chetan Shende is there. Dr. Piyush Gupta, good morning, sir. He is joining from Goa.
Achha, Bakul Parekh sir also joining from Goa. Madam,
yes.
They have got ABM, Executive Board meeting in Goa, and we are really honored. Dr. Basaraj also might join, Secretary General. So
sir, we are going to start.
Yeah, start it now. Jayan Upadhyay join. Welcome, Jayan.
Sir, good morning. Good morning, Madhuri madam. Kasha आहात तुम्ही?
Start it now.
Hello, Shubda madam.
Yeah.
Hello, good morning. Congratulations.
Thank you so much. Thank you.
Jayan, congratulations.
Thank you.
Congratulations, Jayan sir.
Thank you, Chetan.
Jayan sir, congratulations, sir.
Thank you, Sadachar. Good morning, everybody.
Yeah, Sadachar, good morning. Now start, Shobhada. We are going to
Yeah. Shilpa, please start.
Yes, ma'am.
We have to follow military rules with madam.
Piyush sir, good morning.
Dr. Jayant, we are about to start.
Yes.
Right, madam.
Please, everyone mute yourself.
Good morning, everyone. I request everyone to mute themselves. We are starting now. Good morning and warm greetings to one and all. I, Dr. Shilpa Bhoyer, take great honor and immense pleasure in welcoming everyone for the inaugural function of the 16th Annual Conference of Academy of Pediatrics, Nagpur, NAPCON 2020. Jnanam evam prakasham asti, jnanam evam alokam asti. Knowledge is light. Let us open this festival of knowledge and wisdom, which is NAPCON 2020. As always, it is the most awaited annual conference of Central India. With the aspiration of sharing and increasing our knowledge, the seed of first NAPCON was sown in the year 2004 by then President Dr. Vinod Gandhi and Honorable Secretary Dr. Mohib Haq. In no time, this sapling got its roots and wings, and the popularity increased, and this has turned out to be a great academic feast. NAPCON's vision has been to help our pediatricians with showcasing their talent on global platform and get chance to learn and interact with various national and international faculties. Theme of NAPCON 2020 is Building Bridges, Breaking Barriers. It has been our endeavor throughout the year to build multi-level academic interaction to empower every pediatrician with updated knowledge. I'm thankful to all the dignitaries today for making a morning special with their presence. I recognize the presence of our chief guest for today's inauguration, Lieutenant General Dr. Madhuri Kanetkar, ma'am, Deputy Chief, Integrated Defense Staff, Member, Ministry of Defense. I welcome you, ma'am, on behalf of AOP Nagpur. I also recognize the presence of guest of honor, Dr. Uma Ali, ma'am, noted consultant pediatric nephrologist at leading hospitals in Mumbai. Our patron and guiding light of Nagpur Academy of Pediatrics, Dr. Uday Bodhankar, sir. Our distinctive guests who are present today are Dr. Bakul Parikh, sir, National President, Central IAP 2020. I'm not sure if Dr. G.V. Basavraj, Honorable Secretary, Central IAP has joined yet. Dr. Piyush Gupta, sir, President-elect, Central IAP. Today we have dignitaries, Dr. Chandrasekhar Dabharkar, sir, who is Vice President, West Zone, Central IAP. Dr. Jayant Pandrikar, sir, welcome you, sir, President, Maharashtra IAP. Dr. Sadachar Uzarambakar, sir, Secretary, Maharashtra IAP. We also have Dr. Jayant Upadhyay, sir, Vice President-elect, Central IAP. Dr. Vasant Kharatkar, sir, as well, our guiding light and the lead of Central and of Nagpur IAP. The other members who are going to join as dignitaries is Dr. Vinky Rughwani, sir, Vice Chairman, MMC, Dr. Ravi Bhelunde, sir, Executive Board Member, Maharashtra IAP, Dr. Avinash Gawande, Medical Superintendent, GMC Nagpur. I now request all the dignitaries to attend the lighting of Samay ceremony, which will be done virtually. I request to play the audio for us. Asitoma Satgamaya, Tamosoma Jyotirgamaya, Mrityurma Amritam Gamaya, Om Shanti Shanti Shanti. Flame symbolizes wisdom and knowledge. Hence, we bow down to knowledge as the greatest forms of wealth. Thank you very much. Thank you, everyone, for doing it virtually. I now request our President, Dr. Shubha Khirwarkar, Madam, to welcome the gathering.
Good morning, everyone. शुभ प्रभात, शुभ रविवार, सबका हार्दिक स्वागत। नागपुर की तरफ से आप सभी का बहुत बहुत अभिनंदन। I am Dr. Shubhada Khirwadkar, President, Academy of Pediatrics, Nagpur. On behalf of Academy of Pediatrics, Nagpur and entire organizing team of NAPCON 2020, I welcome you all to this inaugural function of our conference today. It is the 16th annual pediatric conference of Academy of Pediatrics, Nagpur. It was started 16 years back as a novel venture, an endeavor to promote our local talent and also nurture them by stalwarts in the field of pediatrics. This year, our theme is Building Bridges, Breaking Barriers, Local to Global. We are extremely fortunate to have a galaxy of stalwarts from pediatrics today for this function. We have our chief guest, Dr. Lieutenant General Dr. Madhuri Kanetkar, AVSM, VSM, and Dr. Uma Ali, the noted pediatric nephrologist, as our guest of honor, who is going to deliver the PR Dange oration for us. We also have presiding officer for this function, our beloved President, Dr. Bakul Parikh, and Secretary, Dr. Basavraj. We have our patron, Dr. Uday Bodhankar, who is the guiding light for all of us, always ready to help us in everything that Nagpur does. We have Dr. V. Chandrasekhar Dabhadkar, West Zone Vice President. I hope he's there. He'll be joining shortly. And President-elect Dr. Piyush Gupta, who both of them, Dr. Parekh and Dr. Gupta, have joined from their destination Goa, where they are attending the executive board meeting. Thank you so much, sir, for making it for us. We also have Maharashtra IAP President Dr. Jayant Pandrikar, Secretary Dr. Sadachar Uchalamkar, EB member from Maharashtra Dr. Anil Raut, newly elected VP of West Zone Dr. Jayant Upadhyay, and we are also fortunate to have the Dange family who are members who would be who are present here in memory of Dr. P.R. Dange. This oration has been started, and thank you Dange family for being with us. Since it's a virtual conference, it was a huge challenge for us when we started to think about this conference, but the excellent conduction of all the West Zone and other Pedi weeks gave us confidence that we can do it for Nagpur too. And with all the support from the entire team, we could culminate with this. NAPCON conference we consider as culmination of a journey in science throughout the year. And so I welcome you all once again, and thank you for being with us. Over to Shilpa.
Thank you so much, ma'am. I now request our patron, Dr. Uday Bodhankar, sir, to bless the gathering.
Good morning to all of you. It's a really honor to have galaxy of people in the inauguration, virtual inauguration today on the 16th NAPCON Nagpur. We are really fortunate to have. We are really fortunate to have Honorable Dr. Madhuri Kanetkar, Lieutenant General, AVSM, VSM, and she is the Chief of Defense Force. We are really honored, Madam. Really salute you. Yeah, we are really excited to have you, and we salute you all from Butterworth. Yeah, and we are only honored to have all galaxy of IIP stalwart, like National President of IIP, our beloved visionary President, Dr. Bakul Parekh sir. Then we have got National President-elect Dr. Piyush Gupta sir. We have got National Vice President Dr. Dabhadkar sir. We have got National President-elect and yesterday Dr. Jayant Upadhyay. We have got Executive Board Member Dr. Anil Raut, who got elected yesterday for the second time. We have got Dr. Jayant Pandrikar, who is the President of Maharashtra, Dr. Sadachar, President Secretary Maharashtra IIP, and we have got presidential candidate, but who are going to a good fighter, my friend, beloved friend, Dr. Vasant Khatkar, and we have got almost all the luminaries here. I will not take name, but and we have got the great orator today and our chief of today's oration, respected Dr. Umali Madam, and all the delegates who are attending this virtual conference. It's a great pleasure for all of us to have here, and I'm really grateful to Bakul Parekh sir, Piyush Gupta, Dr. Basarat to come in spite of their busy schedule in Goa. EBM is going on Goa, Madam Kanetkar, and still they could find time. Really, sir, thank you, sir, Parekh sir. I will not take much time. I welcome you all. I would like to say a few words about our chief guest today. After that, I will hand over to our presiding officer, Dr. Parekh sir. All of you know Dr. Kanetkar, Madam. Recall me 1 minute. I will take. It reminds me of my nostalgic memory of visiting when you were the Dean and HOD of Pediatric AFMC Pune, and there are 4 of us. She has been the first Dean Pediatrician of Armed Forces Medical College Pune. She has been the first to be the Lieutenant General, the highest position in India. She has been the first to a 3-star rank, and she has been they are the first couple in the India Asia. Both of them, Honorable Lieutenant General Rajiv Kanitkar and Honorable Lieutenant General, to have 3-star rank. Both of them are the highest position lieutenant. So, Madam, we are salute you for both. I will invite Rajiv Kanitkar also while giving the bouquet and the flag of honor to you. In short, I will tell you about Madhuri. I think somebody will give, but some of the things which nobody knows. She has got one son, Nikhil, and her daughter-in-law, Tejal. Her daughter's name is Vibhuti. She was born on 15 October 1960 at Dharwad. Madam, we are really honored. In addition to that, I think she was awarded the Vishishta Seva Medal 2014 and Ati Vishishta Seva Medal 2018. And she is the Kalinga Trophy and almost all. I think we are Dr. Shubhada and this thing will definitely read her biodata in the play. She is the Deputy Chief of Integrated Defense Staff Medical under the Chief Defense Staff. See, also we are honored, Bakul sir. She is one of the 4 people who are in the on the Prime Minister Science, Technology and Innovation Advisory Council. Yeah, I think we are really honored, madam, that you came here and you accepted. I welcome you all to this August gathering of stalwarts of India. Give big hand to Kanitkar, Gupta and Parekh sir. Thank you, madam.
Thank you, Bodhankar sir. Now I request Dr. Bakul Parekh sir to say a few words.
Yeah, thank you, Dr. Bodhankar and the organizers of NAPCON and so many other of my luminaries and teachers. I'm happy to be here on this platform. And I know that NAPCON has been a very popular annual conference every year being done by Nagpur IAP. And topmost faculties are always invited to talk on some of the practical problems which we face in our day-to-day practice. So I'm sure the deliberations in this particular NAPCON also will be very useful to all the practicing pediatricians who are attending this conference and who are viewing this conference. So I declare this conference open, and I also wish all the best and happy academics. Thank you very much for inviting me again, and I'm always there with you whenever required. Thank you very much.
Thank you so much for your kind words, Dr. Parekh sir. Now I request Dr. Piyush Gupta sir to say a few words, please. Dr. Piyush Gupta sir.
वो ज्वाइन हुए थे ना, कहाँ गए?
सर हुए थे ज्वाइन, अभी शायद नहीं है.
देखना उनको मीटिंग में, तो नहीं देख लेना. After that you take, we'll again.
Yes sir. Okay, so we proceed further. I can see Dr. Chandrasekhar Dabharkar sir is here. Sir, I request you to say a few words. Welcome.
Yes, I will not take more than 2 minutes. So thank you very much, Bodhankar sir, everybody. I hope you will excuse me if I don't take all the names. But Bodhankar sir, Madam Uma Ali, Lieutenant General Madhuri Kanitkar, I was very eager to meet you, and everybody, our beloved President Dr. Bakul Parekh, and everybody. I all the time see that I attend Nagpur activities because they are really very good, and I'm so much impressed by their all annual activities, especially Adolescent and Nagpur activities. I congratulate you all. I wish you best luck. Only thing I would like to end my speech with only one sentence. I don't know, it is in Marathi. Good ala pan sinha gela. So with this, I wish you best luck. Thank you very much. Thank you very much.
Thank you so much, sir. Thank you. I now request Dr. Jayant Pandrikar sir to give his blessings for this gathering.
Thank you, organizers. Respected chief guest, Dr. Madhuri Madam, then the patron of AOP Nagpur, Dr. Bodhankar sir, then today's guest of honor, Dr. Bakul Parekh sir, and Dr. Uma Ali Madam, and all the stalwarts on the dais. President Dr. Shubhada Khirwadkar. At the outset, I congratulate Nagpur branch of IAP, who always comes with something new ideas. And this is the NAPCON 2020. They are presenting and coming with this theme that is local to global. Definitely, this is going to give all the participants all the scientific fees they are going to give. And once again, I wish Nagpur conference always a success. And Nagpur conference is a very vibrant batch, I know. So I wish all the success for this NAPCON 2020, and I wish happy learning to all the delegates. Thank you very much.
Thank you so much, sir. Thank you very much. We recognize the presence of Dr. Anil Raut sir as well. Initially, I could not see him. Sir, congratulations to you. I think we can proceed further after all the blessings for this gathering. We are ready to proceed further. I now request our guest of honor, Dr. Uma Ali ma'am, who is a consultant pediatric nephrologist from leading hospitals in Mumbai, to say a few words, please.
It's a great honor for me to have been invited here to deliver this oration, and a pleasure to be amongst Nagpurians, which have visited Nagpur many a times before and have had the most warm welcome over there always. And I wish all of you a great success for this conference.
Thank you.
Ma'am, thank you so much. We proceed further with speech from our chief guest. And to introduce our chief guest today, we have got Dr. Anju Kadu madam, who will take further from me.
Thank you, Shilpa. Thank you, Shubda ma'am. It's a great honor to present to you, ladies and gentlemen, Lieutenant General Madhuri Kanitkar ma'am. She's AVS. She has achieved so many awards and has assumed prestigious appointment by Deputy Chief Integrated Defense Staff on 29th of February 2020. A medical graduate from Armed Forces, Pune, and she has achieved her postgraduate degree from Mumbai in 1990. She has also attained training in pediatric nephrology from All India Institute of Medical Sciences, Delhi. She has done many fellowships from NUH Singapore and US London. She has also achieved fellowship in medical education. And she has to her credit so many awards, one of them being President's Gold Medal Award and Kalinga Trophy for the Best Outgoing Student of Graduate Wing in Academics and Extracurricular Activities in 1982. For her distinguished services, General Kanitkar has been awarded Ati Vishisht Seva Medal in 2018, Vishisht Seva Medal in 2014, Commendation by Chief of Army Staff 2000, 2003, 2004, and 2012 for 2 times. Commendation by General Officer Commanding in Chief in 2008. General Officer has been nominated to the PM Science Technology Innovations Advisory Committee and Board of Governors of Medical Council of India in the year October 2018 and July 2019. She intends to align and work for medical education and research to public health needs. And she is the academician par excellence. Lieutenant General has been instrumental in setting up first pediatric nephrology services in the Army Medical Corps. She has held post of President of Indian Society of Pediatric Nephrology. She's also a member of PRESIDE, Pediatric Research
I guess we have lost.
Yeah, I think we have lost her.
We are lost.
Ma'am, on Dr. Madhuri Kanitkar ma'am, on behalf of AOP Nagpur. Oh, she is back. Anju ma'am, do you want to take over?
Yeah, please, please.
Anju ma'am, आप कर दो finish आपका, please. We had lost you in middle.
Okay, she's the academician par excellence. She has been instrumental in setting up the first pediatric nephrology services in the Army Medical Corporate Corps. She's held post of President of Indian Society of Pediatric Nephrology. She's also a member of PRESIDE, Pediatric Research and Education Society of India, defining excellence. She has special interest in bladder disorders in children. She has been a guest speaker at various national and international conferences. She has a large number of publications to her name in national and international journals. And the list is never ending, and I can go on and on. Please, ma'am, over to you. I'd like to hear it from you. Welcome, ma'am.
Thank you so much, Anju. And before I proceed, I would like to say a very happy birthday to you. I think it's your birthday today. Yeah, so I think that's a great one. Dr. Uday Bodhankar, sir, the epitome of a pediatrician, the childlike energy, enthusiasm we all want to emulate. Dr. Uma Ali, who's been a long-standing friend and associate in pediatric nephrology, Dr. Bakul Parekh, the president, Dr. Basavraj, Dr. Piyush Gupta, Dr. Jayant Upadhyay, Jayant Pandharikar, Shubhada Kirwadkar, organizing chairperson, and Dr. Mustafa Ali, the organizing secretary of NAPCON. At the outset, I must thank you all and feel so honored to be part of this whole event. I think most important aspect which I'd like to is that I've been bestowed with so much and love and affection for the Indian Academy of Pediatrics. And for me, that is more important, or rather most important. Agar फौज मेरा ससुराल है, तो Academy of Pediatrics मेरा मायका है. So I think that is what is most important, and the passion lies with the children, as all of us pediatricians. I think this is where we come from, and I must compliment the organizing team for such a beautiful song that you all made and put together for this occasion. It just shows the Nagpur has taken quite a lead in building bridges and breaking barriers. I think this COVID that we've all been battling, and we have so much to be proud of, because it's only this, exactly this vision of building bridges and breaking barriers that has seen India come up so well and doing extremely well in spite of our infrastructure, poor healthcare services. We still have one of the lowest case fatality rates. Our patient people have done well. The healthcare workers have all been hailed as the corona warriors. Not all the doctors have become soldiers. So this is where we have shown the world. So it is local showing global, and we will soon bring out the experience we have learned. Now, why did this happen? Why did the country where everyone said will be a doomsday thing do so well? It was because all the institutions, organizations, the doctors, all of them came together, building bridges and breaking all barriers. We became Atmanirbhar. We created our own PPEs. We created our protocols. People listened. People respected the doctors, they listened, and they stayed indoors. The lockdown was so effective. We have just published it in the Indian Journal of Medical Research that there would have been a few tens of thousand lakh cases more had there not been this lockdown. Instead of 2 lakhs, we would have probably gone to about 100 plus lakhs of cases. So the evidence is now showing in India. Think local, go global. I think India led the way with the face mask. Just to highlight that we talked because we felt N95 was way forward. So what did we do? The Principal Scientific Advisor's Office way back in early April brought out the brochure for the cloth mask which can be used, because it said this was our global idea. And today the world has, local thought of the mask. The evidence came in later. So from local, we showed the global that yes, the face mask is here to stay. Our namaste has become the standard of this thing for greeting everyone. So we are already taking our local to global, and I'm now just waiting for the Nagpur oranges to get the GI tag, because there's nothing like the Nagpur oranges. So I think that is one more place where we need to go global. We have seen that nothing stopped us. Look at this NAPCON. We've all come together on a virtual field and have been able to continue, whether it was the lamp lighting, all the dignitaries are here, and we didn't let something like COVID or a social distancing stop us from. So social is a wrong, it's a physical distance. That distance is all in the mind. We've broken all the barriers, we've created the bridges. But now for the future, I think we have a huge challenge. And in the country, pediatricians have always shown the way forward in a lot of activities, whether it is bringing in OSCE into examinations, whether it is coming together and showing how a simple this thing of ORS, the breastfeeding, the neonatology forum, helping with the Lakshya quality initiative at the government level. I mean, pediatricians have shown a way, and this has translated into the morbidity mortality data. If you look at the daily of 1996 and 2020 years, 25 years, we've come a long way in our primary reasons not being maternal and child and common infectious diseases, but to more of the non-communicable diseases. So again, we pediatricians would have to take the lead, because the future is in that. And I think while we are battling this corona, let us not forget that the children have been the silent sufferers. We've kept them away, we've kept them out of schools. The Anganwadis are not functional. There'll be so many children who do not had their immunization, whose nutrition has suffered. And as pediatricians, we know it is the first 2 years where brain development, it'll probably the effects of this lockdown and this hardship that the people and the less privileged have gone will show maybe a generation later. In that also, I really compliment Nagpur for recently having launched the breast milk bank initiative and taking the nectar to the small premature babies and the breast milk to there. So therefore, I think people like you will, and all of us will have to get together to find solutions, to find ways in our local way where the world will look up and say, we cared for our children. And some of the ideas that strike me is that, you know, we have pediatrics is our profession, pediatrics is our vocation, pediatrics is our passion. But all this combined together brings me the idea of the Japanese concept of ikigai. Ikigai is when 4 parts of you join together, whereas your vocation, your profession, your passion, if they are aligned, and if it makes a difference to someone, if it makes a difference to society, if your vocation, profession, and passion is going to change something for the less privileged, that is when we have found our ikigai. So I think we all need to do that. And maybe we can start with small initiatives. Like I was once talking to the president, can we start a thing of give me 5? Just start an Andolan, which is give me 5, that every pediatrician, I mean, yes, who is in a private practice will reach out to at least 5 people who are underprivileged and give them a free this thing service every day. Those who are running hospitals, in a month, can we look after 5 who are the needy? I'm sure most pediatricians are in pediatrics because they're already doing it. But can we take this as a movement and reach out so that we will break further barriers, build our bridges, and show the world that we pediatricians in India make a difference and we care. Thank you so much, and Jai Hind.
Thank you, madam. Thank you so much. It was a wonderful listening to you, and it has been a privilege for all of us, an honor to present this citation 16th NAPCON, on 16th NAPCON session. Lieutenant General Dr. Madhuri Kanetkar, AVSM, VSM, Deputy Chief Integrated Defense Staff, Medical, Ministry of Defense, Delhi. Madam, as a blessed daughter of Mother India, you are an inspiration and a role model to we, the proud Indians. You are a rare gem with amalgamation of academic brilliance, exemplary valor, undying commitment to the service of our nation, and unflinching patriotism and a fantastic sportsmanship. After completing your graduation in pediatrics and master's in pediatric nephrology, you founded the first pediatric nephrology services unit in Army Medical Corps. With your special interest in bladder dysfunctions in children, you have been an acclaimed speaker in many national and international academic forums and published research papers on the topic in many index journals. For your distinguished services, you have been widely decorated with Seva medals and service awards. It's a matter of pride for the entire fraternity of pediatrics that you have been appointed to the Prime Minister Advisory Committee on Science and Technology Innovation. As a member of PRESIDE, you are passionately trying to align medical education and research to public health needs. Academy of Pediatrics Nagpur is deeply humbled and honored to confer upon you this plaque of honor for your extraordinary achievements and your distinguished services to the nation. This citation is conferred in the 16th Annual Conference of Academy of Pediatrics Nagpur on 1st November 2020. Thank you so much, madam. Now we request Dr. Kanetkar to be conferred upon this award by
Lieutenant General.
Yes.
Lieutenant General Rajiv Kanetkar.
Rajiv Kanetkar, sir.
Salute you, sir. Salute.
So everyone, please salute.
Please salute them and give a big hand. Unmute yourself and give a big hand.
Thank you so much.
Yeah. Shubhada, can you request Honorable Lieutenant General Rajiv Kanetkar to say a few words, sir, please?
Yes, sir. Please, sir.
Please, sir. Our nature, unmute yourself. Unmute.
Sir, unmute.
Okay, unmuted.
Madam, unmute him.
Acha.
We are not able to hear him.
Not able to hear.
Yes, sir. Please come to madam's side a little bit. Yes.
थोडं जवळ या दोघे. मिल्टी मध्ये अलाउड आहे की नाही माहित नाही, पण आमच्याकडे अलाउड आहे. सर प्लीज.
So it is my privilege on behalf of NAPCON to hand over this parchment to Dr. Kanetkar.
Thank you.
Thank you so much.
Yeah. Sir, we are honored, sir, that you both having the highest position, the only couple in India having 3 ranks and through having same position. I don't think anywhere we can have such a respected, wonderful couple, and that too belonging to our fraternity. Sir, we are honored, sir. Please. And we are blessed today to have both of you.
IAP is my Maika. He
I
is
know.
Lucky son-in-law.
Thank you. And this is a great show by Dr. Shubhada Kirwadkar, AAB Vasen, and Secretary Dr. Mustafa, and we have got Madam Dr. Jayan Upadhyay who got elected, and Dr. Anil Gaur. We'll bless all of them. Patient, both of you need to bless all of us, sir.
Thank
Please,
you
sir.
so much.
Thank you. Yeah, thank
So
you.
honored.
Sorry, I didn't understand.
Thank you so much. Thank you, Kanetkar ma'am, and thank you, Shubda ma'am. We recognize the presence of Dr. Vinky Rughwani sir, Vice Chairman, Maharashtra Medical Council and President of Thalassemia Society of India, who has been greatly working as a social worker and doing making immense difference to the children of thalassemia and sickle cell anemia. We proceed further.
Thank you so much.
Thank you, sir. Thank you. Okay. Every year, we release souvenir at the time of NAPCON. This year, we are coming out with an innovative digital platform in the form of NAPTalk. This is an e-journal with academic and non-academic articles by our very own team members. The hard work put in this is by our respected senior pediatricians, Dr. Praveen Page sir and Dr. Sanjay Marathe sir. I request Dr. Bakul Parekh sir.
Is he there?
Yeah. Hello. Yeah.
Yes, sir.
Okay.
So please.
Sir, I request you to present this and what do I say?
Release the booklet.
Release the e-journal for us.
Yeah, so I first of all congratulate Dr. Sanjay Marathe and others those who are involved in declaring this journal. And I declare this journal as open, and I'm sure this particular journal will be useful to every pediatrician in the city as well as in the country. to get themselves connected with each other as well as to get some scientific knowledge. Thank you very much.
Thank you, sir.
Thank you, Sanjay and the team.
This year also, for the first time, we are coming out with the booklet, which I'm sure in the coming years will expand and become integral part of every pediatrician's practice here. This booklet is an easy to handle, ready reckoner, which has compilation of thematic-based messages from pediatric subspecialty. We are extremely thankful to the contributors for their exemplary efforts, and a special thanks to Dr. Chetan Shende, who painstakingly worked and is still doing it every single day. I request Dr. Chandrasekhar Dabharkar sir to release this booklet for us. Dabharkar sir?
Is he there?
Ahit sir, madam.
Yes, I'm there. I'm there.
Yes,
Yeah, he's here.
I didn't heard you.
Sir, you have to release the booklet for us. This is an academic booklet. We have, our pediatricians have been posting messages daily on our academic group. We have compiled from different fields of pediatrics, nephrology, cardiology, vaccinology, pulmonology, and we have compiled all these messages into a ready reckoner booklet, which would be handy and useful for our pediatric members of Academy of Pediatrics Nagpur for their in their day-to-day practice. So please release this booklet for us.
I declare that this book is released, and I really appreciate the very innovative activities by all of you, especially Madam Shubda Khirwadkar, Mustafa Ali, and everybody. I know this is happening under able guidance of Dr. Bodhankar sir. I really congratulate you for all these activities, and please accept my compliments and best wishes. Thank you very much.
It's not me, it is their own creation.
Thank you.
Thank you so much, sir. IIP Nagpur, in association with Nucleus Mother and Child Super Specialty Hospital, has started first human milk bank of Nagpur, Elixir. Human milk bank, which will largely benefit preterm and term neonates across the city and peripheral areas for children or babies for whom it is difficult to get their mother's elixir. We are releasing a short video for same, and this is another feather in the cap of AOP Nagpur.
Good morning, dear friends. It is indeed an honor for me to convey my compliments to the Nagpur branch of the IAP for this yeoman service and adding another feather in their cap in the form of Elixir, the breast milk bank. I think as pediatricians, we all realize the importance of the nectar of life, that is mother's milk. Nothing can ever replace it, especially for our very small premature babies. And this bank is a step ahead in ensuring this elixir of life reaches every little baby. Congratulations, well done, keep it up.
Good morning. It gives me great pleasure to inaugurate the first human milk bank of Central India in the Orange city of Nagpur, which is a joint project ventured by Nucleus Mother and Child Super Specialty Hospital. As you all know, the WHO UNICEF also emphasizes that human milk is the best milk in the world. And if you don't get human milk, then there is a faltering in the growth, and there is also increase in the malnutrition in the babies. So I think the opening of this human milk bank, Elixir, is one of its best kind in the Orange city of Nagpur, and I congratulate Dr. Pankaj Agrawal and all the team members.
नमस्कार मित्रों, 5 वर्ष पूर्व मध्य भारत की पहली ह्यूमन मिल्क बैंक शुरू करते समय जितनी हमें खुशी हुई थी, यकीन मानो उतनी ही खुशी नागपुर का प्रथम ह्यूमन मिल्क बैंक शुरू होने पर मुझे हो रही है। न्यूक्लियस हॉस्पिटल को बहुत बहुत बधाई और ये प्रोजेक्ट ऐसे ही लंबे समय तक चलता रहे और इससे नवजात शिशुओं को बेनिफिट मिलता रहे, मानवता की सेवा हो और एक सुदृढ़ नागरिक, सुदृढ़ भारत का निर्माण हो, इसके लिए शुभकामनाएं। धन्यवाद।
Elixir, the Human Milk Bank, deserves heartiest congratulations from Academy of Pediatrics Nagpur. This venture by Nucleus Hospital is one of the best for humanity in its kindness and empathy. This endeavor of Nucleus Hospital will definitely benefit lots of young children and babies who are not fortunate enough to get breast milk from their own mothers. This is the best donation a lactating mother can give to other children. And I congratulate all the team members of Nucleus Hospital and my colleague, Dr. Pankaj Agrawal, for this best venture that one can think of for humanity and kindness towards society. Thank you.
I really want to congratulate Indian Academy of Pediatrics Nagpur along with Nucleus Mother and Child Hospital for the innovative project of opening of Elixir Milk Bank. This is really a novel project. This is going to help to nurture preterm babies, not only in Nagpur, but surrounding area of Nagpur. I wish all the best for this novel project. Thank you. Jai IIP.
It's my honor and privilege to be invited as the guest of honor for the inauguration of the Human Milk Bank at Nucleus Hospital. I must congratulate the entire team of Nucleus Hospital for taking up this very noble initiative, which is the need of the hour. Nucleus Hospital took up this project to start the first Human Milk Bank of Nagpur. I must also appreciate the fact here that they are going to provide the human milk almost free of cost to all the needy infants, neonates. For them, this is the elixir of life. And I'm sure you all will be blessed and showered with countless blessings from these mothers whose neonates need this human milk the most. So I congratulate you once again and my very best wishes for this noble venture. I wish you all the very best and I assure you of all our support from our side.
Hello, Shilpa.
Thank you. Yes, ma'am. Okay, so after the release of this video, we are coming to end of the ceremony. I request Dr. Mustafa Ali sir to give vote of thanks now. Uday Bodhankar sir wants to say something. Yes, sir.
Yeah, Shubhada, sorry. Before we say vote of thanks, can we request our elected Vice President, Dr. J.N. Upadhyay, to say a few words, and Dr. Anil Rao, Executive Board Member, second time, if you allow him.
Yes,
yeah.
sir.
Yeah, J.N. Upadhyay, please.
Thank you, Dr. Bodhankar, sir. Respected Dr. Bakul Parekh, sir, President of Central IIP, Dr. Piyush Gupta, President-elect, Dr. Dabhadkar, Vice President 2020, Dr. Jayan Pandrikar and Dr. Sadachar Ujambarkar, President and Secretary, Maha-IIP, Dr. Shubhada and Dr. Mustafa Ali, President and Dr. Shubhada and Mustafa, President and Secretary of Nagpur IIP, Dr. Uma Ali, Madam, Dr. Kanitkar, Madam. It is a proud moment for me, and I am privileged to be a member of Nagpur IIP. Yesterday only, with blessings and support and help from all of you, I got elected as Vice President for year 2021. The credit and the whole credit goes to Nagpur IIP, Vidarbha, Maharashtra, and all the pediatricians who have voted for me and those also who have not voted for me. I am for IAP. I will be working sincerely for IAP, IAP Nagpur, Vidarbha, Maharashtra, and all India. I am very, very thankful to each and every member of IAP, and I assure that I'll be working very sincerely for the cause of the child health and for child health advocacy. Once again, I am thankful to be a part of this prestigious conference, NAPCON, and thankful to the organizer. Thanks everybody. Thank you very much.
Anil Raut is there?
Yeah.
Yeah, please. He is second time elected ABM with, I think, second position. And Jayant Upadhyay got highest vote more than the national president. So give big hand to both of them. He got 9,500 votes, all India. Jayant. And yes, Anil, please. And after that, I think Jayant Pandekar patient might speak. Anil,
Yes, spoken, sir.
please
Good
come.
morning.
Open.
Good morning, all the dignitaries on the stalwarts on the dais. Respected Madhuri Kanitkar madam, respected Uma Ali ma'am, Dr. Bakul Parekh sir, Dr. Gupta sir, Dr. Piyush sir, Dr. Pandrikar sir, Dr. Dabadkar sir, Dr. Sadachar, and all my colleagues of Nagpur and Maharashtra. First of all, I am very much thankful for your support, blessing, love, and everything which had showered on me during this elections, which had made me second time to represent you at central level in central IIP. I am very much indebted and thanks to all of Maha IPS for electing me, and I assure that I will work hard to make your all responsibility to be fulfilled for the coming year. I congratulate Dr. Subda madam and Dr. Mustafa for what was our initially a thought that we should have a NAPCON on a virtual platform, which has become true now. And with all this, best of luck to all Nagpur IAPS. Thank you very much.
Thank you, Anil. We have got 5 minutes because we are going to be strict with Shubhada and Honorable Kandikar madam.
Yes, sir.
If Shubhada, because we have heard Vasan Katkar in Human Will Bank, would have got. Can we ask Jayan बोलले ना?
हो पांढरेकर सर बोलले सुरुवातीला.
अच्छा बोलले मग मी ठीक आहे. सदाचारला बोला नाही बाकी सगळे झाले.
Very nice arrangements, NAPCON, and congratulations for your this venture and all the best. Thank you.
Thank you, Sadaja. Now over to Shubhada. Anybody left? I don't know. As per the protocol, we have finished most other people. Winky or any MMC observer कोण आहे? I think
झाले त्यांचं बोलणं. So Dr. Shilpa, you can continue.
Yeah.
I must compliment की आर्मीची हे बोलवल्यावर बिफोर टाइम संपतंय. डॉट सुरू केलं डॉट ऑन टाइम. Real hats off to Nagpur.
Thank you, ma'am.
Thank you.
Yes, Shilpa. Shilpa, you are muted. Shilpa.
Shubhada, किती मिनिटं राहिले? 5 मिनिटं आहे का? 2 मिनिटं?
सर मॅडमचं ओरेशन आहे याच्यानंतर.
हो लगेच 10 ला आहे. ठीक आहे. याच्यानंतर आपलं हे काय अँथम आहे? नाही ना?
हो.
हा मग ठीक आहे. शिल्पा कुठे आहे?
शिल्पा, you are muted. Shilpa.
Hello. Thank you, everyone. I request Dr. Mustafa sir to present vote of thanks now.
Hello. On behalf of Academy of Pediatrics, I would like to thank our chief guest, Dr. General
मुस्तफा तुम्हारा आवाज गया.
So Dr. Bodhankar, I am Dr. Bakul. I'll take your leave. Thank you very much for inviting me.
Thank you, Dr. Bakul sir.
Yeah,
we are honored to have you in NAPCON, and it is always our pleasure to see you on Nagpur platform. So kind of you. Thank you, Dr. Bakul sir.
Thank you, Bakul.
Congratulations, Jayant and Anil.
Thank
And
you,
all
sir.
the best
Thank
to
you very
Vasan
much.
for the future endeavor. And I
Yeah.
am really thankful to Dr. Bodankar, the patron of Nagpur, the Bhisma Pitama of Nagpur,
No, sir.
for inviting me here.
Thank
And all
you.
the best. And I am very happy to see that Human Milk Bank has been started by Nagpur city.
Yeah.
Actually, it is my desire that every district should have one Human Milk Bank for the preemies and the newborns. Thank you very much.
Thank you.
I'll take your leave. Thank you very much.
Thank you, sir.
On behalf of Academy of Pediatrics, I would like to thank our chief guest, Lieutenant General Madhuri Kandkar, Madam, ASVM, VSM, our guest of honor, Dr. Uma Ali, Madam. I would also like to thank our President, Dr. Bakul Parekh, sir, for gracing this occasion, taking out his time and gracing this occasion. I would like to thank our patron, Dr. Uday Bodankar, sir, for his guiding, for the guiding force behind our Academy of Pediatrics. I would like to thank Vice President, West Zone, Dr. Chandrasekhar Dhabadkar, sir, and Dr. Jayant Upadhyay, sir, Vice President-elect. I would also like to thank Maharashtra President, Dr. Jayant Pandikar, sir, Dr. Sajaja Ujalamkar, sir, Maharashtra Executive Board member, Ali Rao, sir, who has been elected for the second time. I would also like to thank Dr. Vinky Gwani, Vice President, Maharashtra Medical Council, for gracing this occasion. And I would like to thank Dr. Praveen Page, sir, Sanjay Mate, sir, Dr. Chetan Shende for bringing out a very nice magazine. I would also like to thank our senior pediatrician, Dr. Vasant Khalatkar, sir, and our President-elect, Dr. Vijay Dhote, sir. Last, I would also like to thank Mr. Animesh Chaduvedi for coordinating our chief guest, for the presence of our chief guest. And I would also like to recognize the presence of Dr. P.R. Dange, Surbi Vadalwar. So we close the inauguration and rise for the national anthem. Thank you.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
भारत माता की
Jai.
Thank you very much, Dr. Shita, Madam.
Coming to an end of this inauguration ceremony, we proceed further, and a busy Sunday has got next coming is oration. I hand over to Dr. Amit Nemare, sir, for B.R. Dange oration and further proceedings. I'm thankful to everyone for giving us this time today. Thank you.
Very good morning. Very good morning to
Dr. Amit, please
Yeah.
start your video.
yeah.
Yes. Yes, carry on.
Yeah. A very good morning to all of you. And thank you, Dr. Shilpa Boyer, Madam, for sailing us smoothly through this inaugural session. May I please welcome President AOP, Dr. Shubha Khirwadkar, Madam, and Honorable Secretary, Dr. Mustafa Ali, sir, for the next prestigious session of the NAPCON 16, that is late Dr. P.R. Dange oration. I, Dr. Amit Nemade, pediatric orthopedic surgeon, welcome you all to this prestigious session by Dr. Uma Ali, Madam, who is a senior pediatric nephrologist. May I please take a few moments to speak about this oration. Dr. Dange, a graduate from GMC Nagpur and postgraduate from GMC Nagpur as well as from Wadia. He has done multiple fellowships in prestigious institutes like Glasgow, Liverpool, Manchester, etc. He started his practice way back in 1965. He was honorable consultant at Muir Memorial Hospital, Mayo Hospital, and many other private hospitals in Nagpur. This oration was started way back in 1991 at IIP Nagpur. So we are almost 30 years since the oration has started. So may I please request the madam to continue with the session, please.
Hello, everyone. Please mute your mic.
Obviously चांगले आहे, but हा खूपच जास्त
Hello. Hello, Dr. Pandrekar, please mute your mic. Yes, thank you. Go ahead. Yes, I welcome everyone who I am seeing on the screen. All of you, thank you to all of you for being there throughout this session, and hope you would be with us throughout the entire day, because we have a gamut of stalwarts who would be speaking on different subjects. This oration is one of the most prestigious events that IIP Nagpur conducts every year, and we are extremely fortunate and blessed, privileged to have Dr. Uma Ali for this oration this year. Madam needs absolutely no introduction to all of us. She is a consultant pediatric nephrologist, presently working at Lilavati Hospital and Research Center, has been head of nephrology division of SRCC NH Children Hospital, founder of Kidney Foundation for Children. Madam has given her distinguished services as Dean of Wadia Hospital for Children and has also served as head of pediatric nephrology there. She has pioneered the establishment of acute and chronic dialysis center and pediatric transplant services both at Lilavati and Wadia Hospital for Children. She has also been counselor, International Pediatric Nephrology Association and Asian Pediatric Nephrology Association. She has been awarded P.A. Mudani Oration and multiple other orations. She has also received Lifetime Achievement Award of IAP Pediatric Critical Care Chapter. She has contributed to research with more than 60 publications. Ladies and gentlemen, please welcome Dr. Uma Ali Madam. Madam, over to you for the oration. The topic of oration this year is Rhinoprotective Pediatricians, the need of the hour. Over to you, ma'am. Madam, please unmute yourself.
Thank you so much for the kind introduction. Just give me a moment to share my screen.
Yes, ma'am. Madam, could you make it full screen?
I'm just doing that. Yeah. 1 second.
Madam, slideshow.
Yeah.
Slideshow.
Is that fine?
Yeah.
No,
Yeah. It's good.
Yeah.
Yeah.
Yes.
Can you hear me? Okay. Yeah. I first must express that I'm very honored to be invited to present this oration, the PR Dange oration at the 16th NAPCON. I was also very surprised and pleased to know that the Honorable Dr. Dange was an alumni of Wadia Children's Hospital, where I spent the best parts of my life. And I'm today what I am because of what the hospital gave me the privilege to develop and see the light of the day. I'm wish to pay my respects and gratitude to the organizing committee and the scientific committee of the 16th NAPCON, Dr. Shubhada, Dr. Mustafa, the patron, Dr. Uday Bodhankar, and all the dignitaries who are present today and all the delegates who are attending this. And my special pleasure at having Dr. Lieutenant General Madhuri Kanetkar as chief guest, which doubles my joy as I know her from her young days as a friend and colleague in pediatric nephrology, that this almost makes me feel that this is a pediatric nephrology conference today. Thank you all for inviting me. I think we are in an era, with COVID as a predominant thought. And IAP has taken always a leading role in the control and fight against infectious diseases. But we do have in all our fight against infectious disease, a lot of non-communicable diseases in children which are present and which deserve attention because they will not remain static if unattended. They will slide downhill and deteriorate if unattended. And to my mind, leading amongst these are the kidney diseases in children because they are like the submerged part of the iceberg. They're not easily visible. You have to anticipate, know it is there, and have a plan of action for them. So I think it's an important area which I hope IAP and pediatricians will take forward. Now, why pediatricians? What can pediatricians do and how can they do? I will come to in a few moments. Now, why are we worried about kids' kidneys? 1 in 10 adults have chronic kidney disease. This is a global data. Some of these begin in childhood, especially when you see chronic kidney disease in young adults. Lack of awareness leads to kidney diseases going unrecognized in children, and hence they are not investigated adequately, and investigations are not interpreted rightly. And progression of renal damage is not prevented. Now, we know the extent of the global problem. There's the reported prevalence of chronic kidney disease. I'm not talking of all kidney disease, but the one which go into chronicity is about 35 to 85 per million. And India has the world's largest child population, almost 400 million children below 18 years of age. So this extent in absolute terms will be larger in India. In addition, we feel that the prevalence of CKD may be even higher in Indian children for the following reasons. One, because all of us know that many kidney diseases present late. They are not recognized in the early stages, and this delays the treatment that can be offered and takes away the window of opportunity for preventing damages to the kidney. We also have an unrestricted use of nephrotoxic medications. This is both in allopathy, where we use nephrotoxic medications for trivial conditions like fever, and a lot of non-allopathic medications which are used for non-specific causes like better growth, better appetite, etc., which many of which have turned out to be toxic to the kidney. We also probably have a higher incidence of acute kidney injury because we have so many infections like dengue, malaria, so much sepsis, many of which have also an accompaniment of acute kidney injury during this process. And now we've come to know that survivors of acute kidney injury, almost a significant 30% of them may progress to chronic kidney disease. We also have a higher preterm birth rate of 22%, high IUGR rates due to maternal malnutrition, and probably still significant vitamin A deficiency. All of these may lead to no endowment of low nephron numbers to the babies, or disordered development in the case of vitamin A deficiency, leading to dysplastic kidneys. So the question comes, the pediatrician saying, why me? Okay, we understand all this, but why me? And here are our data. We have only 150 pediatric nephrologists for 400 million children. And although we produce about 10 or 12 pediatric nephrologists annually through our fellowship programs, and now DM in pediatric nephrology, FNB, etc., we are a far cry away from meeting the needs of the country. And most of the pediatric nephrologists are in the bigger cities and bigger towns. So the large number of our citizens who are in the peripheries, 80% of our population, do not have access to a pediatric nephrologist. As opposed to that, we have 35,000 pediatricians spread over 712 districts, and of which IAP has 341 branches in 341 districts. So pediatricians are present everywhere. And even at a taluka level, you will find pediatricians. And so accessibility to pediatricians is very high, as opposed to a very difficult access to pediatric nephrologists. So if we have to look at that, every child with kidney disease should receive the right care at the right time and in the right manner, so that we give equitable health care to all, then we are looking at 3 A's: availability, accessibility, and affordability. Luckily, as you will see further, that except for the small segment who go into chronic renal failure, where the costs are skyrocketing, the rest of renal diseases in children, which form 80% of the kidney diseases in children, are eminently affordable. The few drugs that we pediatric nephrologists use are prednisolone, maybe some kind of cephalosporins for UTI, Septran and nitrofurantoin for prophylaxis, and maybe sodamine tablets, all of which are very cheap. The availability of nephrology services will be very limited if it is restricted to only pediatric nephrologists. And that is the reason for involving pediatricians, because these services will become available if pediatricians are empowered to deliver them. And they're also very easily accessible. Okay. The pediatrician also has the unique position of handling a child from birth, sometimes even before birth, up to maturity, and sometimes often seeing the second and third generation of children from that family. So they have a good idea of the family patterns and can easily detect the subtle changes that are the manifestation of kidney diseases, because when they see one child differing from the rest of the sibling, it will definitely ring a bell. So they've been looking after so many organs, neuroprotection, respiratory, cardiac, etc. And now the kidney is asking, what about me? So if we look at kidney diseases, we see a large yellow central quadrilateral in this pyramid, which are the common diseases we encounter in our day-to-day practice. Most of them are easily recognizable. We've learned about them in our pediatric training. We have repeated CMEs and seminars and conferences where these conditions are discussed. And there are excellent guidelines by Indian Society of Pediatric Nephrologists. So I would consider the yellow zone as a safe zone, which very comfortably pediatricians can treat the common problems. What I'm concerned about is the gray zone of children at high risk for kidney dysfunction and the red zone when they move into CKD. So what are the challenges for the pediatrician in primary care? I look at it as 5 challenges. One is early diagnosis of not so obvious kidney diseases, not in the yellow zone. Identifying and monitoring patients at high risk for renal dysfunction, that's the children in the gray zone. Prevent renal damage. Use resources optimally to investigate and treat patients, especially when you're working in resource-limited situations. And lastly, facilitate transfer to advanced care if needed. Now let's look at early diagnosis. Now, glomerular diseases with which we are all familiar comprise only 20% of all kidney diseases, and they are easy to recognize because they have edema, hypertension, hematuria, proteinuria, all of which we are very familiar with, and we find it easy to detect by simple urine examination. And as physicians, we tend to be glomerulocentric and recognize signs of glomerular disease. From our undergraduate date, the majority of us have been tubulophobic because tubules are not easy to understand. We just mug it up just to pass the exam and are happy to do away with it. So physicians are less familiar with tubular problems. And these symptoms and signs of tubules are also more subtle and are not identified as renal because they don't have puffiness, they don't have hematuria, proteinuria. And 80% of pediatric renal problems are tubulointerstitial, and that is why a lot of them go unrecognized. Polyuria is the hallmark of tubular disease disorders, and in children, one has to be more vigilant in recognizing. If it presents in fetal life, it will manifest as polyhydramnios, but not all polyuric condition manifest in fetal life. During infancy, in this diaper age, parents often don't know much about the urine output. So often we suspect polyuria when they present with life-threatening illness, recurrent dehydration, irritability, constipation, and failure to thrive. So these are kind of non-specific, but one needs to have alertness for this. In little older children, what may be easily diagnosed or bring to attention is nocturia. Most children by 4 to 5 years of age do not pass urine at night. And so if a child gets up at night to pass urine once, twice, or thrice, and this persists even during summer times, then there's something abnormal because the child probably has a poor concentrating capacity and is unable to concentrate his urine. And this also accompanied by getting up at night to drink water. So kind of a leading question on nocturia and getting up at night to drink water in a child who's not thriving too well may give us the clue to the presence of a possible kidney disease as a cause of failure to thrive. Speaking of failure to thrive, 60% of Indian children are either stunted, wasted, or undernourished. That is our data. So it's difficult to say what will be the red flag for a child with kidney disease who has failure to thrive. It's not going to be easy to pick up that. So when you have failure to thrive in association with one of these findings, that is recurrent dehydration, vomiting off and on, acidosis that's disproportionate to the GI losses, failure to thrive along with rickets and bony deformities, failure to thrive along with short stature, often shorter than sibling or just as tall as the younger sibling, or the shortest 3 or 5 in the class when the parents' heights are not so short. These all should raise a red flag that could this be due to renal disease. These children look apparently well. So a 9-year-old may look like a very well 6-year-old. And unless we make a habit of plotting the height and weight on a growth charts, that they are below 2 standard deviation may go undetected. Now, this is a 7-year-old girl with anemia, unresponsive to hematinics, was investigated extensively and no cause found. Took second opinions from various hematologists and well-reputed pediatricians in different cities. No diagnosis. Ultimately, a bone marrow biopsy was done, which showed myelofibrosis. And this child needed transfusion once in 3 months and was advised for a bone marrow transplantation. Went to a different city to attend a wedding and became acutely breathless and found to have pulmonary edema with a creatinine of 5 milligrams per dl, needed emergency dialysis, and was found to have bilateral small shrunken kidneys with end-stage kidney disease and was advised kidney transplant. The aunt in desperation wanted an opinion from me that whether this child would need a kidney transplant or a bone marrow transplant. They were so confused. And would he need both and which should be done first? So this child just had chronic kidney disease, which got missed. The anemia was due to the chronic kidney disease. The myelofibrosis occurs due to long-standing untreated secondary hyperparathyroidism, which you see in CKD. The only person who had hit the nail on the head was a pathologist who saw myelofibrosis. And there was a small line beneath in the report where he recommended doing serum creatinine and parathormone after seeing the myelofibrosis. Unfortunately, either nobody saw that line or they thought he's a pathologist. What does he know of clinical medicine? And it was not done. And so this child needs kidney transplantation and not bone marrow transplantation. So when should we suspect that anemia could be due to CKD? When it's not responding adequately to iron therapy, which you've given for 3 months, then a simple BUN creatinine before advanced hematological tests is very important to go forward. Another presentation, which we saw 2 years ago, this was an 8-year-old boy. He had been under investigation for last 2 years for difficulty in running and climbing stairs. So he could not keep pace and could not play with his friends, and that was the concern. He first was referred to orthopedic, who detected no abnormalities. So he was referred to neurologist, who clinically did not find anything abnormal on examination. Then EM I think there's some disturbance, which was normal, but found that the hemoglobin was 7, so went to a hematologist who worked up for deficiency, hemolysis, and a lot of other advanced tests with which I don't claim to have much knowledge about. And at last did BUN creatinine, which showed a creatinine of 3.5 milligrams, and that's how he got referred to me as a nephrologist. And when I evaluated him, he had severe metabolic acidosis, high phosphorus, low calcium, high PTH. So my message would be check BUN creatinine before referring to hematologist for refractory anemia, by an orthopedic surgeon for deformities before correcting them or before referring to orthopedic surgeon, endocrinologist before investigating hormonally for short stature or parathyroid resistant rickets, and neurologist for unexplained difficulty in climbing stairs. Because kidney does not have its own manifestation, it manifests through its effect on other systems. It's important to keep in mind that any of this which does not fall into a clear explanation needs a BUN creatinine, which is a very simple test and cheap test before going into advanced test and missing the diagnosis. Two important opportunities which we should not miss for detecting and monitoring kidney disease. The most important one is congenital anomalies of the kidney and urinary tract, which is used, the mnemonic is CACUT. It's the commonest anomaly detected on antenatal sonography, and it accounts for 1/3 of all anomalies. And its prevalence is very high, almost 1 in 500. It's an important cause of urinary tract infection, hypertension, growth failure, and in some cases, end-stage kidney disease. And if you see the pediatric end-stage kidney disease, almost 50% would be due to CACUT. Okay. And we all know the different presentations as posterior urethral valves, as duplex kidneys, as vesico-ureteric reflux, as ureteroceles, or sometimes cystic, multicystic dysplastic kidneys. There are varied forms of presentation, which we all put under the umbrella of congenital anomalies of kidney and urinary tract. Now, to illustrate that despite this being an open on-the-face diagnosis, they do get mismanaged. Now, this is a 28-year-old primee who had an antenatal ultrasound in 3rd trimester and found pelvic ischal dilatation 8 millimeters on one side, 10 on the other. She had a male child, and after birth, the child was voiding well. So the parents were reassured that nothing to worry as the child was voiding well and this could be done some other time. Despite the parents requesting a postnatal ultrasound, surprisingly, it was not done. The child was growing very well, but at 8 months, he had fever with severe UTI. An ultrasound showed a mild increase in dilatation. And this time he was diagnosed as posterior urethral valves, was fulgurated, and currently has normal creatinine. So everything looks good on surface, but he has a small scarred left kidney with 23% function and a right kidney which shows peripheral cortical defects. So we do not know in the long term whether this is going to impact his renal function. So something which was on the face, which could have been diagnosed, and all this additional complications prevented, went undetected. So a male child with bilateral PCS dilatation, always do MCU to rule out PUB. Normal voiding does not exclude posterior urethral valves. This is another child who was antenatally detected to have kidneys which were bright in appearance. So just hyperechoic kidneys, nothing abnormal in size, no PCS dilatation. And so he was reassured that there's no dilatation, nothing, the child is okay and this will become all right. No further investigations were done. At 11 months, the child had seizures, and on admission to ICU, he was found to have a blood pressure of 180 by 120, anemia, and a creatinine of 8 milligrams per DL. So he required acute care and then went on to CAPD for last 4 years, and recently has undergone a cadaveric donor transplantation. So absence of pelvic calycial dilatation does not rule out a serious kidney disease. So what are the main things to remember when we see a child with CACUT, which most pediatricians will be the first ones to see? That we look at them as those with pelvic calycial dilatation and those without. In those with pelvic calycial dilatation, we need to keep a lookout for whether they need surgical intervention. This is almost invariable if we are looking at lower urinary tract obstructions like PU valves, but upper tract obstructions may require or may not require, and we have very good guidelines for these. We need to monitor all the patients who had renal anomalies on antenatal ultrasound. We need to evaluate and monitor. This includes children who have undergone surgical correction. The commonest mistake made of surgical correction is to believe that the child is cured. So the anatomical abnormality has been corrected, but the effect of this obstructive uropathy on the kidney in utero may often lead to a nephropathy which remains uncorrected and needs to be followed up. So follow-up is also needed for children who have no pelvic calycial dilatation. This should not be dismissed as something unimportant. In fact, they may have more serious diseases underlying. Most patients will maintain normal renal function, so we need not alarm the parents in all cases, but we should emphasize that they would need a long-term follow-up, frequency of which may not be very high. Because we do know that late deterioration does occur due to CACUT and can occur at all ages, including adulthood. And all these children should have the benefit of a pediatric nephrology consultation because it's a very heterogeneous group and the guidelines do not address the heterogeneous nature because that is a little difficult to put across in a guideline. And so there could be small subtle differences which may entail a different management. And now during COVID, we've learned that pediatric nephrologist or any specialist does not need to be physically present and can be consulted online. Another often missed finding is hypertension because we do not routinely measure blood pressure. And we know that hypertension is not uncommon in children. It's often asymptomatic, unlike adults where they may have clinical effects. It will be missed unless BP is routinely checked. And so we need to use the right size cuff for different ages. And we need to use the tables which have the norms according to age, gender, and height. Why is hypertension important? Because it has the highest contribution to mortality in adults globally. 50% of all strokes and coronary disease in adults is due to hypertension. In children, clinical adverse effects are uncommon, but 40% of hypertensive children may have cardiovascular abnormalities if you do 2-day echo. And adolescents are at particular risk of developing hypertension because due to change in lifestyle factors and lessening or liberation from parental control as they go to high school and early college. And hypertension in childhood tracks into adulthood. So we are putting these children at risk for hypertensive complication as young adults. and resolution in childhood may prevent this progression. When I was a resident and during my younger days, I was taught that all hypertension in children is secondary hypertension due to an underlying cause, most common renal. But now we know that primary hypertension is a big player in children as well. And this is a Kidney Foundation screening program where we screen 2,600 adolescents in 10 schools, urban and rural, in standard 8 and 9. And we found a prevalence of 7.4% and elevated BP of 2.9%. This means 1 in 10 adolescents may have hypertension. It's 1 in 5 if they are overweight, and 1 in 3 if they are obese. So the obese Indian adolescent actually has a higher risk of hypertension than their global counterparts. So this is a well-known increased cardiovascular susceptibility in Indians for the same risk factors compared to others globally. We also need to remember that not all hypertension is both systolic and diastolic. And you may have isolated systolic hypertension with diastolic normal and the reverse isolated diastolic hypertension, which also need to be monitored and tracked. And we have these classifications. So once we identify and confirm with 3 different readings, we need to classify to see whether they need immediate treatment or lifestyle management. So my message would be check blood pressure in all adolescent children at clinic visits, all obese children at clinic visits, all children who were born preterm or IUGR, and all children with renal or heart disease. Now, which are the children at high risk for renal dysfunction who are lying in the gray bottom zone? I think what we need to see is this gray zone are your preterm babies, your IUGR babies, NICU graduates. We already spoke of CACUT, children who have recovered from acute kidney injury, and children who have received chemotherapy, the numbers of whom are increasing. Now, why are they at risk? Now, preterm babies, the nephron formation occurs up to 36 weeks of gestation. And so premature babies are born with lesser number of nephrons. Nephrogenesis can continue postnatally up to 36 weeks of post-conceptional age, but adverse postnatal events may alter this course, so new nephrons may not form, or when they are formed, they've altered structures and they are afunctional nephrons. So a sobering thought is new nephrons do not form after 40 days of postnatal life. So when a 24-week preemie survives, he or she can have a maximum total nephron complement of 30-week baby, and hence is always vulnerable to renal damage. And we should have extra precautions that we don't provide them a second hit by using nephrotoxic drugs and other preventable injuries. Similarly, IUGR children have low nephron number due to growth restriction. And NICU graduates, they have a lot of insults because of which they're in NICU, sepsis, asphyxia. The drugs we use, aminoglycosides, vancomycin, NSAIDs for PDA. And the AKI which occurs may be missed because many are non-oliguric and small changes in creatinine gets overlooked. And unless you're using a sensitive methodology for creatinine estimation, it becomes not detectable. And as I said earlier, now we know that survivors of AKI up to 30% could progress to CKD, not necessarily end-stage disease, but to chronic problems. And the reason why IUGR babies are at future risk is the low nephron number leads the remaining nephrons to hypertrophy, hyperfilter. This leads to proteinuria, which in long time leads to glomerulosclerosis, which will further lower the nephron number and lead to a vicious cycle. And obesity does something similar. It causes glomerular hypertrophy and then goes to the same pathway. So obese children are also at risk. So what do we monitor? It's very simple, inexpensive: blood pressure, growth, proteinuria, urine protein creatinine ratio more than 0.2 is abnormal. Increasing trend suggests worsening damage. Serum creatinine maybe annually, preferably by a better method like enzymatic or kinetic, especially if it's a small child. Calculate eGFR, and if possible, do blood gases. Prevention of renal damage has 4 important things. Avoid use of NSAIDs for fever. Use only paracetamol. World over, paracetamol is used. So Indian children do not suffer from fever-induced problems more than other children. Use aminoglycosides only if necessary, and single daily dose may be superior to divided doses with lessening toxicity. Avoid empirical use of vancomycin for non-life-threatening disorders, because our most prevalent organisms are gram-negative. And use contrast CT only if necessary. And see if you can get the same information by another modality which does not use contrast. And importantly, hydrate well before contrast and monitor creatinine after. An important thing which pediatricians face is they often have to work with resource limitations. And resources are limited, one has to be more resourceful. The limitations may be financial or expertise. And I'll take 2 examples, one of UTI and one of AKI. Now UTI, this is a story of 2 children, Tanya and Tukaram. Tanya is a 4-year-old girl living in Mumbai. Her father works for a multinational company. She presented with the second attack of febrile UTI. She was treated with antibiotics, put on prophylaxis. Ultrasound showed mild PCS dilatation, bilateral grade 2 to 3 VUR on MCU. DMSA showed no scar. She's now on prophylaxis and no further UTIs. Now, Tukaram, same age, lives in a village 30 kilometers from Bede. His father is a farmer. He has had 3 attacks of UTI. He has to go to Bede every time for his fever, and the father religiously takes him. And he has been treated with antibiotics each time. The pediatrician advised culture, but father has done culture only once. And he said, he tells the pediatrician, this is the same thing he had last time. Why are you asking me to do the test? I can't afford it. The pathologist does not do colony count over there. He has not had an MCU because the radiologist refused and said it is too dangerous to do in such a small child. And the DMSA is at Aurangabad, 150 kilometers away, and the father refused to go there. So we have these guidelines which are almost by all societies, including Indian Society of Pediatric Nephrology, where we say culture is a must, MCU in selected cases, and DMSA to rule for scars if you've had a severe febrile UTI. And the question is it applicable to all in India? Yes, if you're living in a big city, you can get access to all this. But when we surveyed 34 districts in Maharashtra, and we gave the survey in 23 districts where we had CME. And of the 1,500 pediatricians who have collectively attended, 366 answered the survey. And we did not ask whether they used these facilities, but whether they just had these facilities. And urine culture was present in many places, so was colony count. MCU facilities were available, but high number of problems following MCU, which was usually done by a radiologist. And only at that time, 5 cities where DMSA scanned. Now there are 2 more. So what is doable in this? Can we follow these guidelines everywhere? Urine culture, yes. It's a very simple test, and urine, the bacteria in urine grow abundantly, unlike blood culture, and you just need a simple agar plate. Colony count automated is expensive, can be done manually, but is time consuming. But now there are free apps available which can be downloaded. And if you just upload the picture of the colonies, it will give you the count. And a disc diffusion method using selected 5 or 6 antibiotics used for UTI and not the whole gamut may not turn out very expensive. MCU, we need to wait for the new guidelines because MCU is being re-looked at with the idea that we should do it less frequently. But when required, X-rays are available in most places. The issues of safe catheterization and technique. So usually a pediatric surgeon, if available, would be a good person to do it. Where not available, I think some pediatrician should train to do safe catheterization and technique. I think feasibility of DMSA scan is really not there in peripheral places because the cost of DMSA is 3,400 to 4,500 is what we found out in most centers. It involves travel for the family because father, mother, child will go at the minimum, loss of wages, sometimes they have to stay a day. And so this cost goes to at least 5,000 to 6,000. Whereas the average monthly income of Indian farmers is rupees 6,000 something, where they support parents, themselves and their children. And probably now as 10,000, but it's not something where one can spend 6,000 on a DMSA scan. So can we manage UTI in resource limited without DMSA? Yes, we can monitor for proteinuria. We can monitor annually serum creatinine, check the blood pressure, which doesn't cost money. And once in a couple of years, do an ultrasound to monitor kidney sizes and appearance, that it's growing well and not looking hyperechoic. Similarly, acute kidney injury, we have a resource limitation because we do not have pediatric nephrologists everywhere. And it's a common condition. Secondary to other illnesses, it occurs in 22 to 20% of children. So we have dengue, malaria, leptospira, sepsis, snake bite, many of which may get complicated with acute kidney injury, which complicates the management of your primary disease and is also associated with high mortality. And we already mentioned that 30% of survivors may progress to CKD. So ability to do peritoneal dialysis may save many lives. Before peritoneal dialysis, diagnosis is in the hands of pediatricians, and urine output, rise in creatinine. And the minimum criteria is urine output less than 0.5 ml per kg per hour for more than 6 hours, or a rise in creatinine more than 0.3 milligram from baseline or 1.5 times the baseline. Tells you this child is at risk for AKI, and the higher it goes, the higher the stage. In our survey, we found that 79% of those pediatricians who answered the survey said they saw AKI in their practice. Half of them said less than 5 per year. A remaining half said more than 5 to 10 per year. And 60% of these needed PD. That means we are doing a late diagnosis. And we are seeing this only when it is fairly advanced because the data from other countries is hardly about 5% would need PD because they're diagnosing early. So the pool is different. And more than half had to send patients to a different city for PD. So if you do not have a pediatric nephrologist in your city or close vicinity where your patients can go, then at least a few pediatricians, those who are running ICU, should become competent in doing PD. And we've been doing it all over Maharashtra to train pediatricians interested into doing simple bedside PD for acute kidney injury. And lastly, facilitate advanced care. Now, this is a small segment, but this is the labor and finance intensive segment, and often gets missed and comes in late stages. So the red is the CKD, the purple is the end stage, and the small little green, I couldn't make it smaller than this, is the number who actually receive some kind of renal replacement therapy. And this renal replacement therapy should go to the full purple segment in end stage. Most of you know that we can estimate GFR at the bedside with just height and serum creatinine using simple GFR formulae. And the importance of this is that when you identify which zone the child falls in, that if it's a green zone, and then your main focus is treating the primary disease well and preventing progression. If it's in the amber zone, treating primary disorder will still help to prevent progression. But in this amber zone, there is also already present derangements like acidosis, osteodystrophy, etc., which would also need treatment and dietary changes. And the red zone is where they need care at advanced center. but it may be too late if we wait for a 15 ml GFR. So we should start preparing when the GFR drops to 30 ml. So when you monitor renal patients, do the creatinine periodically, once in 6 months or once a year, depending on the nature of the disease, and calculate eGFR. And dialysis need not be a dreaded treatment. With increasing pediatric nephrologists, it is actually children come in quite happily demanding what they want for entertainment and what they want to eat during dialysis, which is provided to them. And you can see the child and father both relax reading papers during dialysis. And end-stage kidney disease is not the end of life. Even children diagnosed as early as in infancy can be tided over with good conservative management and go on to receive a transplant. And so this child has had a journey from the early infancy, went through a brief period of dialysis, and then the father gave his kidney, and she received a transplant at 6 years of age, and today she's 14 years with a good functioning graft, leading a normal life. So the challenges for the pediatrician, to summarize, is to follow guidelines for easily recognized renal problems, follow up children with antenatally detected renal anomalies, identify high-risk children and monitor for renal dysfunction, that is all your neonatal survivors, preterm IUGR babies, facilitate advanced care, and very important, learn PD if you do not have a nearby pediatric nephrologist. And guidelines are freely available on ISPN guidelines, but for those pediatricians who have a very busy practice, you can access the Kidney Foundation website, where we have a doctor's desk, and with just question answers, in a brief one-page way, you can get all the answers you want for your particular disease you're concerned with. I just put in the slide yesterday at night because your theme is building bridges to overcome barriers. And I had this slide before when we started Kidney Foundation. So I thought I must put in that this child standing on that feels he's standing at the edge of a cliff because he seems to be the only one suffering from kidney disease, whereas all the other children are happy. There is a bridge, but it is too risky for him to cross. So we need to build a stronger bridge so he gets encouraged to go across. And also other children like him can cross over easily without fear. So this is a bridge from hope to reality, which we hope to bridge. And the person who can help to bridge is definitely the pediatrician, because of reasons I already said of their presence and their commitment. So where there is a pediatrician, I feel there is always a way. And so thank you for listening patiently, and do think of the kidney when you're seeing your patient.
Thank you so much, ma'am, for such wonderful insights. Your oration was absolutely, everyone I'm sure must be riveted and must have listened to you so intently. There were so many new learnings for all of us, how we can be renoprotective pediatricians in the real sense of the word, and how nicely you ended it with the bridge. That's what we all should build from now on, so that our children are protected from various renal diseases. Thank you so much, ma'am. And we now move on to the presentation of this citation to you. So may I request you to please, is Mr. Ali there?
Yeah, he's there. Yeah.
So, sir, please present the citation on our behalf to Madam Uma Ali.
Yeah. Madam Uma Ali, it is a great pleasure and honor.
Great honor and privilege for all of us.
Yeah, please give a big hand to Uma Ali, madam. We are honored that you delivered the prestigious Pira Dange oration, which was started during my secretaryship and Honorable Dr. Rawat sir was the president, 91-92.
So now I read the citation.
Yeah, please.
Madam Dr. Uma Ali, as a brilliant academician with extraordinary clinical skills, You have been relentlessly working for over 40 years as a socially sensitive pediatric nephrologist for a better life for children sick with renal diseases. After receiving an extensive training in pediatric nephrology from prestigious universities and children's hospitals abroad, you have been putting all your knowledge, wisdom, and skills into developing a robust healthcare system for pediatric dialysis, transplantation services, and training fellows in pediatric nephrology. As a passionate torchbearer, your social contribution as the founder member and president of Kidney Foundation for Children has helped facilitate the right health care at the right time in the right manner. Your mission to serve children has been truly exemplary. Academy of Pediatrics Nagpur is deeply humbled and honored to confer this citation upon an able clinician, an academician par excellence, a brilliant researcher, and a passionate social worker. The citation is conferred in the 16th Annual Conference of Academy of Pediatrics Nagpur on 1st November 2020. Thank you so much, ma'am.
Thank you very much, IAP Nagpur, and my humble respects to the Dange family for being present.
So there are some members of the Dange family present with us. Our technical support team, can you pin them? Madam Vazalwar is there. She is the daughter of Dr. Dange. Dr. Mustafa, can you have Mrs. Dange?
She has left, ma'am. She is not.
Okay, sorry. Yeah, so she was here throughout the function, and we express our deep respectful gratitude to the Dange family. Now move on. This is the end of this oration session. Thank you all for being with us. We'll now continue our scientific deliberations throughout the day. Thank you, Dr. Umali. Thank you, Dr. Madhuri Kanetkar, for staying throughout, and all the dignitaries and stalwarts of pediatrics who have been supporting us throughout. Thank you so much.
Yeah, thank you very much, ma'am, and thank you, Secretary Sir, Dr. Mustafa Ali sir.
Amit, start your video.
Okay, ma'am. Yeah, thank you, one and all. Now we close this session and move on to the next session. May I request Dr. Jyoti Chauhan, ma'am, to join in and carry on the next session. Dr. Jyoti, ma'am. Yeah. Jyoti, ma'am, you can carry on with the next session, please.
Can you hear me, please?
Yes, ma'am.
No. Please make your audio louder, Jyoti.
Okay, madam.
Hello.
Hello. Now you can hear me?
Yes, Dr. Jyoti. Carry on.
Good morning, everyone, and warm welcome. After an excellent talk by Uma Madam, we will start now academic feast. In this session, we will be gathering knowledge on interesting topics. Our first speaker will be respected Dr. Zubair Aghai sir, and for this, chairperson will be Dr. Hadi sir and Dr. Mahesh Turale. Dr. Hadi sir is well-known senior pediatrician working since last 30 years in Nagpur. He is director of Hadi Children Hospital. Dr. Mahesh Turale is immediate past secretary of IAP Nagpur branch. He is consultant neonatologist, director of Colors Children Hospital, Nagpur. I request Dr. Hadi sir and Dr. Mahesh to start the session.
Good morning, everybody. Am I audible to all please?
Yes.
Yeah, I'm Dr. Hadi from Nagpur. I'm very much thankful to the office bearers of NAPCON to give me opportunity to chair this session. It's a real pleasure and pride to introduce again my college days friend, Dr. Zubair Aghai, who started his career from Kamptee and reached United States of America, a place where many of us dream to reach on this planet Earth. It is really a a moment of pride for all pediatricians of Nagpur city to have someone from our place at that place of the earth. Zubair is at present professor of pediatrics at Philadelphia. He is also director of neonatal perinatal medicine fellowship training program. And he also holds the post of director of neonatology research at Jefferson University and is affiliated with many hospitals in that area. With about 30 years of experience and more than 50 publications to his credit, mostly in neonatal respiratory system, we are fortunate to have him to listen on the subject of placental transfusion. I request Dr. Zubair Agai to proceed with his talk, please.
Thank you, Dr. Hadi, for kind introduction. And I am looking to see, and thank you, Shubha, for inviting me for this talk. It's a true honor to be sharing this platform with so many legends from Nagpur. So I'm going to talk about placental transfusion. Can everybody hear me?
Yes, you are audible and clearly visible.
Okay. So the topic of my talk today is a placental transfusion. And the reason I choose this topic, or there are two reasons why I choose topic. One of them is placental transfusion with delayed cord clamping is a no-cost, low-tech intervention that can have a huge impact on short and long-term outcomes in preterm and term infants. And despite strong recommendation, clinicians are reluctant to adopt delayed cord clamping. So the goal for my talk today is to discuss placental transfusion in vigorous infant and placental transfusion in a depressed infant. And then briefly, I will talk about clinical trial we are planning on umbilical cord milking in depressed infant. Before I start my talk, I will ask few questions. The first one is, you have preterm or term baby who was vigorous at birth. How long do you wait before clamping cord? You will immediately clamp cord, or you will wait for 30 to 60 seconds, 1 to 3 minutes, more than 3 minutes, or you will do umbilical cord milking. I know many of you, and I can read your mind, so I know your answer is 1 to 3 minutes. That's what the WHO and the Helping Baby Breathe recommend. You should delay cord clamping for 1 to 3 minutes. But if your answer is 30 to 60 seconds, that's also correct, because ACOG, the American Academy of Pediatrics, and NRP recommends delayed cord clamping for 30 to 60 seconds. So where do you place your baby while performing delayed cord clamping? At or below the level of placenta, or over mother's abdomen or chest? So your both answer is correct, but if you are placing a baby over mother's abdomen or chest, 30 to 60 seconds of delayed cord clamping may not be enough, and I will explain to you later why. So this is a second baby who's depressed at birth. How long do you wait before clamping cord? Will you immediately clamp the cord, or wait for 30 to 60 seconds, 1 to 3 minutes, or you start bag and mass ventilation with cord clamping after 1 minute, or perform umbilical cord milking? So your answer should be immediate cord clamping, because that's what recommended by most of the organization. But if you selected bag and mass ventilation, that's also correct, because Helping Baby Breathe recommends bag and mass ventilation with intact cord in a babies who are depressed at birth. So at birth, in term baby, 67% of blood is in baby and 33% in placenta. In preterm baby, 50% of the blood is in baby and 50% in placenta. So in delayed cord clamping or deferred cord clamping, umbilical cord is left unclamped for a short period of time after birth, and the blood from placenta passes to infant. WHO and 35 other organizations recommend delayed cord clamping for 30 seconds to 30 minutes in vigorous preterm and term infant. With the delayed cord clamping, about 24 ml per kilo of blood is transferred from placenta to neonate. More blood is transferred with vaginal delivery than with C-section, and I will explain this in this slide. So there are 4 factors that determine the transfer of blood from placenta to baby: the uterine contraction, timing of cord clamping, gravity, and spontaneous respiration. With each uterine contraction, placenta is squeezed and the blood from placenta goes to the baby. But if the babies are born by C-section, there's no uterine contraction, so they get less blood. Keeping the baby at the level of placenta or below placenta facilitate blood transfer by gravity. But if you are keeping a baby over mother's abdomen or chest, you are not getting a benefit of gravity. So these babies, 30 to 60 seconds of delayed cord clamping may not be enough. Some expert recommends 2 to 5 minutes of delayed cord clamping if you are placing the baby on abdomen. And the longer you keep the cord unclamped, more the blood goes to the baby. The negative intrathoracic pressure generated by spontaneous respiration pulls the blood from placenta to the baby. But if the baby is not breathing, there's not enough blood is going from placenta to the baby. The studies have shown if you clamp the cord before the baby starts breathing, that increases the risk for mortality and NICU admission. So the delayed cord clamping increases the infant's blood volume and perfusion to important organs and help in transition from fetal to neonatal circulation without minimal alteration in cerebral blood flow. Delayed cord clamping also supplies extra immunoglobulin that may reduce infection. Supplies extra red blood cells that may reduce blood transfusion and improve iron store. Fetal blood is also a rich source of stem cells that may help in organ repair, especially in premature baby or in full-term baby with birth asphyxia. A meta-analysis of 18 randomized controlled trial comparing delayed cord clamping with the immediate cord clamping has shown that with a delayed cord clamping, there is a 32% reduction in mortality in premature baby. This reduction in mortality is similar to the use of antenatal steroid and much better than use of surfactant. Delayed cord clamping in preterm baby also decreases need for medication for hypotension, decreases need for blood transfusion for anemia. It reduces intraventricular hemorrhage, necrotizing enterocolitis, and late onset sepsis. It also improves iron store at 3 to 6 months and neurodevelopmental outcome at 2 years. In term baby, delayed cord clamping improves hemoglobin and iron store. A meta-analysis of 5 randomized controlled trials has shown that delayed cord clamping decreases iron deficiency at 3 to 6 months. As you all know, iron deficiency is common during early infancy. There is a nice review article by Grish and Meenakshi in Indian Journal of Pediatrics in 2015 on anemia in childhood. We have been taught that fetus is a perfect parasite, and even if mother is iron deficient, the newborn babies are not iron deficient. But I think that's wrong. Recently, we published a paper and we shown that 20% of the baby admitted to NICU have low MCV suggestive of iron deficiency. In a study from China, 45% of infants born to mother with iron deficiency were iron deficient at birth. Iron deficiency is very common during pregnancy. About 40 to 80% of pregnant mother, they are iron deficient. Iron is important during critical period of brain development, and iron deficiency at birth or during early infancy is associated with long-term neurodevelopmental impairment. In a term baby, delayed cord clamping increases myelin content at 4 months of age in brain region associated with motor, sensory, visual processing and function. Delayed cord clamping also improves neurodevelopmental outcomes at 4 years of age in full-term babies. This is an unexpected benefit of delayed cord clamping. A recent study from Kenya has shown anemia and iron deficiency at the time of vaccination decreases response to diphtheria, pertussis, and pneumococcal vaccine, and iron supplementation increase vaccine response. So delayed cord clamping by preventing iron deficiency can improve vaccination response. So there are certain risks for delayed cord clamping. Polycythemia is one of them, but the studies have shown there was no difference in symptomatic polycythemia in term babies. Jaundice is another complication of delayed cord clamping, but in term babies, the risk of the risk of receiving phototherapy was increased by only 2%. And in preterm babies, delayed cord clamping increased peak bilirubin, but there was no significant difference in phototherapy. Delayed cord clamping may also jeopardize timely resuscitation. That's why a delayed cord clamping is not recommended in a babies who are depressed at birth. But placenta continue to perform gas exchange, so we can ventilate this baby with a intact cord. This going to the last mile, this terminology or this concept comes from a telecommunication industry and the cable industry. It's very easy to bring a cable in a city, but the hardest part is to distribute this cable in each home or every home. So the distribution of this cable to every home is called going to the last mile. Despite strong recommendation and proven benefit, delayed cord clamping is not routinely performed in neonate. And I think this is due to we are not going to the last mile. In California, 42% of infants admitted to an ICU did not receive delayed cord clamping. And in Canada, 40% of preterm infants admitted to an ICU did not receive delayed cord clamping. And in China, only 30% of hospitals included delayed cord clamping in early newborn care practice. I'm sure this is the same problem in India. So we have to go to that last mile, and that's why I'm talking to you. The delayed cord clamping is the easiest and the cheapest way of decreasing mortality in premature baby and making our babies smarter. Increasing a few IQ points makes a big difference in life. I wish Trump had a delayed cord clamping, but I am not sure increasing few IQ points in him will make any difference. I'm going to switch to umbilical cord milking. Umbilical cord milking is a milking of umbilical cord towards baby immediately after birth. And it can be done with the intact cord milking, where the cord is connected to the placenta, or cord cord milking. The advantage of an umbilical cord milking is you can perform this in a depressed baby who requires immediate resuscitation. So the neonates who are depressed at birth, they are the one who needs those extra blood. And they are the one who are going to benefit most from the placental transfusion, because placental transfusion corrects hypovolemia, and many of the baby who has a birth asphyxia, they are hypovolemic at birth. It will increase perfusion to brain And it also provides stem cells and growth factors that helps in regeneration of brain. And it also prevents iron deficiency. But WHO, American College of Obstetrics and Gynecology, AAPN, and RP, they do not recommend delayed cord clamping in babies who are depressed at birth and require immediate resuscitation. Only helping baby breathe recommends bag and mask ventilation with intact cord. So the baby who are depressed at birth, there are two options: umbilical cord milking or ventilation with intact cord. And we were the first who published a paper on umbilical cord milking for neonates who are depressed at birth. This was a randomized trial of feasibility and safety, and this study was done in India and Nagpur. I'm sure you recognize many of those authors here. Meenakshi Giri, she was the one who was very active in performing this study. So what we did is we compare umbilical cord milking in 50 depressed baby and compare them with a control group of 51 infants who received immediate cord clamping. So there was no significant difference in APGAR score at 1 minute, 5 minutes, and 2 minutes between the two groups. And the resuscitation effort was also similar in both groups. So we concluded that umbilical cord milking was feasible and safe in depressed infant. So the other option for the baby who are depressed at birth is a ventilation with intact cord, and the helping babies breathe. They do recommend, they say, if possible, ventilate baby with intact cord and delay cord clamping for 1 to 3 minutes in depressed infant. And this is the only publication on resuscitation with intact cord. This is a pilot study from Nepal, and they look at outcome only in the first 10 minutes. But ventilation with intact cord was associated with increased oxygen saturation in first 10 minutes, increased heart rate, and increased APGAR score in the first 10 minutes. They don't have data outside of the delivery room. And there is no data on umbilical cord milking or ventilation with intact cord in babies who are depressed at birth. So we are planning a randomized clinical trial comparing short and long-term outcomes of umbilical cord milking in neonates who are depressed at birth. And our PICO question is infant who are depressed at birth, umbilical cord milking compared to immediate cord clamping will improve survival without neurodevelopmental impairment at 2 years. So this will be a cluster crossover randomized clinical trial, 7 centers in India, including 3 centers in Nagpur. Center will be randomized to umbilical cord milking or immediate cord clamping, and it will be crossover in 6 months. We are expecting more than 65,000 deliveries in 7 centers in 1 year, 4,000 depressed babies, and about 1,000 babies with moderate to severe HIE. And we follow them at 1 and 2 years for neurodevelopmental outcome. And we are expecting that umbilical cord milking will improve survival without neurodevelopmental impairment in infant with moderate to severe HIE. So these are my take-home message. If you can just take away these 2 messages. Delayed cord clamping saves life. It decreases mortality by 32% in premature baby. So if you start using a delayed cord clamping and stop using surfactant, still your mortality is going to be better. So this simple measure has more advantages and more benefit than giving a surfactant to the baby. Delayed cord clamping improves iron store and prevents iron deficiency during the critical period of brain development. Delayed cord clamping improves neurodevelopmental outcome. But for infants who are depressed at birth, the current recommendation is immediate cord clamping. Ventilation with intact cord and umbilical cord milking has potential to improve outcome, but we need more study, and one of them we are going to do. So we should continue doing a delayed cord clamping till God or the nature decide to go high tech and start delivering a cordless babies. I'm showing this picture, I'm showing this photo, not to brag that Melania Trump, she visited our NICU and I have a picture with that. I want you to notice who's on the front. The real frontline worker, the nurses and the respiratory therapy, they are on the front line. And this is our chairman of pediatrics, and this is all neonatologists, they are on the back. So we should give importance to the nurses or the frontline worker. We should really give a lot of importance to them and empower them, because they are the one who's going to help us in traveling that extra mile we have to do for the delayed cord clamping. And thank you again for giving me this opportunity to talk to you. I don't know whether you can ask me a question or not. Thank you.
Thank you, Zubair sir, for your excellent, lucid, and informative presentation on a.
Dr. Mahesh, be a little louder.
Thank you, Zubair sir, for your excellent topic and lucid and informative presentation on very important topic that is in today's era, that is to improve the outcome of newborn babies, that is placental transfusion. He explained everything about placental transfusion, how clinicians are reluctant to adapt this process of delayed cord clamping, and how it is important and it is a need of hour. And many neonatologists and pediatricians will definitely help from this lecture. I have one question basically. Sir, what is difference between delayed cord clamping and milking of the cord in the as far as outcome of the baby is concerned?
Yeah, so I had few slides, but because of the time short, I removed this slide. So in full-term baby, there is a meta-analysis on umbilical cord milking and delayed cord clamping. And there is no difference in umbilical cord milking and delayed cord clamping. Actually, the hemoglobin is higher in a babies who are born with a C-section if umbilical cord milking was done. But in premature baby, especially the baby who are less than 28 weeks, umbilical cord milking was associated with severe intraventricular hemorrhage. So we have to be very careful in a very tiny baby, 22, 23, 24 weeker. We should not be doing umbilical cord milking in those babies. But the baby is more than 28 weeks, umbilical cord milking was safe and the outcome was as good as delayed cord clamping. Actually, in premature baby, there is a couple of studies which showed delayed cord, umbilical cord milking is better than delayed cord clamping, especially in a babies who are born at C-section. And the neurodevelopmental outcome was better with umbilical cord milking than delayed cord clamping.
Thank you, sir. And
Just one query, please. Sir, just one, please. Zubair, do you mean milking of cut cord?
Yeah, so no, we are milking the intact cord, because with cut cord, you can milk only once and it doesn't refill because you already cut the cord. But if your cord is connected to placenta, if you milk once, then it refills from the placenta. So you have more effective transfer of blood with the intact cord versus the cut cord.
But any benefit if we make it routine milking of cut cord?
But again, there is not enough data. So we have to be very careful for doing any new intervention unless you have a big clinical trial and you've seen a safety of this. So I will not recommend umbilical cord milking at this time, but you can wait for our study or some other study for the safety of this. So most of the organizations, they don't recommend milking of the umbilical cord. As we have seen in the premature baby, tiny baby, they don't have much, there was an increased risk of intraventricular hemorrhage on those babies. So we don't know, there might be some unknown risk too. So we have to look into the large clinical trial before we start doing this as a routine practice.
Thank you, Dr. Zubair. Wonderful presentation and excellent insights into the topic. I'm truly happy because you have made the bridge robust between Nagpur and New York. Thank you so much.
Okay, thank you very much. And really, you're doing an excellent job organizing this. I heard few talks, so thank you and keep it up.
Thank you.
Thank you, Agai sir, and thank you, Dr. Hadi sir and Dr. Mahesh for chairing this session. Now we will move for our another lecture by Dr. Naveen Jain sir. I invite Dr. Sanjeev Joshi sir and Dr. Kharatkar sir for chairing this session. Dr. Sanjeev Joshi is Director of Chirayu Criticare and Joshi Children Hospital, Yavatmal, was past IAP President, Yavatmal branch, is ex-National Secretary, visiting fellow to Australia and UK, member of expert group of AMLC, and he is also regional trainer for NRP. Dr. Kharatkar sir, well known to all of us, he is Director of Colors Children Hospital and Kharatkar Hospital, National President, Comad UK, National Secretary, Pediatric Neurology Chapter, Vice President, IAP ID Chapter, Fellow Guide, DCH, Joint National Coordinator, War Module 2020, and Task Force Member for COVID-19 Health Department, Nagpur. I request both of you to start the session.
Hello, am I audible? Hello, am I audible?
Yes,
yes.
A very good morning to you all. Thanks, Team NAPCON 2020 for this wonderful opportunity, and was very much excited to listen to Zubair, who was my first registrar during my residency. Leaving apart this nostalgic moments which we spent with Zubair, now come to the topic itself. Our today's speaker is none other than Dr. Naveen Jain, who is a very well-known faculty at the national level in the field of neonatology. In fact, I am a personal admirer of Dr. Naveen. He hails from the God's own country, that is Kerala, Trivandrum, and he will be highlighting us on some important neonatal interventions which had a huge impact on a long-term neurodevelopmental outcome of the baby. So with this brief introduction, a well-known faculty par excellence, Dr. Naveen Jain, please take over the mic.
Good afternoon, sir. And
Hi, Naveen.
thank you so much for such a beautiful introduction. And thank you to everyone from Nagpur to invite me for this academic event. And I'll just start sharing my slides, sir. Yes, I think I'm full screen now.
No, it's still not full screen.
Oh, it is.
Yes, now it's there.
It is.
Thank you, ma'am. And we'll go on with the subject. The theme of today's presentation would be a family trying to tell us, a baby trying to tell us that I was not born disabled. We know that all of us feel empathy, sadness, hurt, and a terrible feeling of sickness within us when we see a child who is struggling to do this basic things that we can do very easily. Being able to sit, being able to communicate, see the world around us, be able to handle a few things. Not just that the baby suffers and the family struggles, there is a feeling of anger to medical care, often leading to medical legal suits. And this is something we want to avoid after doing all the hard work in trying to save a sick baby. So the whole theme will be to look at those babies who are possibly not born with a problem and whether we can prevent creating disability during our medical care. The first scene I'm going to take is that of a baby born premature. Preterm babies generally have very good outcomes. And you can see in this image that even as young as 26-week babies and 750 grams at birth, these days can be promised a very good outcome. Not more than 15% babies have developmental problems. And if it is a little more mature baby, say 30 weeks, 1,250 grams, which most of us manage these days with little intensive care like CPAP and not even requiring parental nutrition, these babies, only 5 to 6% babies have disability. So it's a good thing to have a premature baby and we can target for a good outcome. Now getting to the brain stuff straight away, what can I do to make sure that my baby is in this 80 to 90% babies who develop normally? So the first message of the day is to look at these pictures showing the brain development. You've seen this in many presentations. A very smooth looking brain at 26 weeks, very small one with no folding at all, developing into a mature brain with several cortical folds of sulci and gyri. We all know that this is made of a lot of lipids and lipoproteins. Where are these lipids and lipoproteins going to come after the baby is born from? They are not going to come from the formula milk and not even from the parental nutrition, which is made from egg or some soya material. They are going to come from the mother's breast milk. And I can't start investing breast milk after the baby is medically stable. Breast milk has to come from day one. And just like we heard Dr. Zubair speaking about the last mile, we all talk about breast milk on conferences, but how does a baby get breast milk on day one in a NICU? So the first message I would like to give to the pediatric friends who are there is the prescription that goes out of the NICU as soon as the baby is admitted is that of a breast pump. We prescribe it along with surfactant. So patient has to buy breast pump, mother has to start pumping, and it may be that she will take a day and a half before she starts getting a few drops of milk that can be applied as a mouth paint, colostrum mouth paint. By the third day, the baby will be getting enough breast milk. So mother's own milk, mom, understandably, is the only substance that can go into the baby's brain and keep it as normal as if the baby had been in utero. We have a checklist in the part of our book called Blue Book. And you can see day one as the admission happens, we have a checklist for the nurses and the registrar to tick off saying that encourage mother for express breast milk. So sometimes the breast pump is bought, but it's just lying by the side of the mother. Somebody has to go and educate her how to use the breast pump and how to give breast milk to the unit. Now, the second part we can do, or we keep asking ourselves, is can I model the brain into a better structure, into as normal as a structure can be? Is it really possible? Is there an entity really called brain plasticity, or is it just hope that we have been trying to give ourselves? Let us look at this experiment. Look at this tiny fellow mouse running around his cage, playing with eating food, running up the slope and running down. Now, this simple experiment was done to prove something called experience-driven brain plasticity. Preterm mice were nurtured in 3 different types of cages. The left cage is the one which is a standard condition where you have many family members of the mice in the cage. The impoverished condition is which many of our NICUs are, where we keep all the family members out of an ICU, and the preterm mice or the preterm baby is alone. And the third one is the enriched condition, where you are having not only a family member there, but you also have enough activity stimulation for the baby, parents talking to the baby, touching the baby, stimulating the baby like normal babies would. So what difference does it make? Let us see whether you are having a normal impoverished or a standard cage versus an enriched case. So you can see that when they did autopsy of these mice, after the baby became term, the one who was in the standard cage had neurons with very poor dendrites and synapses. Whereas the one who was in the cage where there was enough activity stimulation had rich dendrite and synapses. This is robust evidence that whatever the baby experiences in the NICU from day one. So I think this experiment should go a sufficient proof for every parent to be allowed inside the NICU from zero. A 25-week, 26 weeks asphyxia baby should not be separated from the parents. They should be able to come and touch and take care of the baby from day one. So please do this. Promote brain growth. It's not just enough to protect the brain from injuries and promote brain development. So the second message of the day is to allow parents to participate in the care of the baby in the NICU from time zero. As soon as the baby comes into NICU, nobody can be better than the parents themselves, and continue with kangaroo care, of course, after that. So day one, our checklist also includes introduction of what we call as the early parent participation program, where parents are counseled to take care. Now moving to scene two, from prematurity, a common other situation that can be brain damaging is hypoglycemia. This is actually my class fellow once, and his baby was having excessive crying, and he went with the baby to the emergency room. The pediatrician there reassured him, saying the baby will be okay. Hours after, again he went back to emergency room saying the baby is crying. BFHI was practiced. He was told exclusive breast milk, nothing else. You go home. 2 hours later, the baby developed seizures, and then he was again incorrectly managed by giving 25% dextrose boluses. This is what happened to the baby in real. There was hypoglycemic injury, parieto-occipital damage, and the baby was lost forever in terms of his cognitive function. Compare these two pie graphs. The one, the 30-weeker I showed you, where there is 6% risk of disability, and the term baby who developed a symptomatic hypoglycemic seizure, more than 60% babies will have multiple disabilities, seizures, cognitive losses, cortical visual function, diplegic or quadriplegic CP, and this is very, very damaging. So what we can do, look at the revised guidelines of Pediatric Endocrine Society, which is very much more safe, saying that on day one, try to keep the blood sugar levels more than 50, and day two, keep, and 3 and beyond, keep it more than 60. You may take the cutoffs as 40 with old classical if you wish. The number is not what is important. What is important is to check actually in babies who are at risk, and to try and keep the sugar levels in the safe range and prevent symptomatic hypoglycemia. This is an important one. Very often, if you ask the resident on day one, how will you ensure if breastfeeding is happening well? They say baby is passing meconium 3-4 times a day, urine, and sleeping after feeding. This is not true. The first 2 days, the baby is not going to get enough milk. So the answer is not sleeping well, feeding well, and passing urine and meconium sufficiently. On the first 2-3 days, it is having a good latch. There is an acronym called latch, and important parts are whether the baby latches on, whether you can hear the baby suck, the type of nipple should be looked at, and written down. There should be seeing whether there is a comfort in the mother's feeding and whether her position of holding is good. So if you see a mother like in this picture who is distressed, who is falling off, getting tired, who is anxious, then this mother needs assistance for lactation, and you need person to dedicate to come and help. And in some cases, you may need to give supplemental milk, but that is not the message I want to give. The point is that every mother on day one should have an objective assessment in the notes that is latching taking place. No point in writing temperature, pulse, respiration in a normal baby where nothing is going to go wrong with this. So the correct position and holding of the mother should be important. Scenario 4, where we may get damage, is that of asphyxia. And you can easily see that if you have hypoxia, less oxygen, and ischemia, every organ of the body is going to get damaged. There is no body part which is living and does not require oxygen and perfusion. The heart will be damaged, endocrine, kidney, lungs, the blood system, the pancreas, the liver, intestine, everything, and the brain, of course. So this kind of a baby is going to require monitoring of multiple organs. And I find a very easy acronym stops to look at these babies. Look at the sensorium of the baby, check the temperature, oxygenation, perfusion, and sugar. Periodically have a table, monitoring table like this. Now, many of the other parts are already there in all the monitoring charts. People have temperature recorded, saturation, respiratory rate, heart rate, refill time, blood pressure, sugar. But I really wonder how many of us have a item called sensorium on our monitoring chart, objectively recorded. Now, let us see how this baby is going to be. He was born at morning 8 a.m., had a poor sensorium after needing resuscitation at birth. Then the sensorium improved, became yellow, and then it became even better green. This baby seems to be recovering well. We are doing the right things. Whereas if this was another baby whose sensorium remained red, red, red across the next 4 hours, this baby is in trouble. This is much better tool than a MRI, a NIRS, and also is telling me that I have not done something correctly with this perfusion or with the sugars. I need to correct it quickly, otherwise I'm losing this baby's brain forever. So my appeal is, the fourth message of the day is, please add sensorium to your monitoring charts of sick babies, not just in asphyxia and all other conditions, and objectively record the sensorium of the baby, because brain is an important organ of interest and cannot be neglected. If you see an MRI later at 1 to 2 weeks like this, where basal ganglia is already involved, this baby is completely damaged. If you're sitting in a small center and if baby required PPV at birth, kindly refer this baby to a center where multi-organ monitoring can happen, and do not use anticonvulsants just randomly. They are damaging to the brain. So this picture again comparing the outcome of a baby with severe asphyxia with basal ganglia injury, you can see most of them are either severe cerebral palsy and damaged, or yellow showing as moderately damaged, but there are no greens, they're all gone, compared to a 30-weeker where only 6% were having damage. So having asphyxia where you did not correct the sensorium quickly is going to be severely damaged. The last scenario of the day is that of jaundice. Now, jaundice should not be the word written in the newborn chart. It should be jaundice and active baby, and jaundice with not feeding, poor tone, and cry. Because we are not dealing with the liver disease. We are actually worried about jaundice causing the brain and causing damage. Then why are we not writing about that objectively? You just write what is the bilirubin value. You write the baby looks icteric till the sole. You write he looks icteric till the toes or to the face, deep icterus. But why are we not writing this baby is having icterus, but is actively feeding, crying well, and having good tone? So this baby is not having encephalopathy. Whereas the baby who is having poor activity, so a good note written that baby had no encephalopathy, whatever the bilirubin value may be, medical legally you are safe. Not only that we need to assess one time, we need to follow up this babies till day 5. I wouldn't be going to details of jaundice monitoring, but another investment which you need to do is to get LED lights and use blue lights for treatment of jaundice and prevent this severe devastating condition. So 3 words in the bind score which are there, bilirubin induced neuronal damage score. Our bottom line is that, is the baby crying well? Is he feeding well? Is he having a good tone? Very simple. So jaundice with encephalopathy has already happened. Then again, you can see it is the worst form of neurodisability that can happen to a newborn. The child will never sit, he'll never eat well, he will be lying down, he will be possibly in a tube feed, he will have quadriplegic CP. So this is the worst damage we could have done. So a jaundice with encephalopathy are either all red, or some of them may be moderately damaged, but no good babies. They're only bad babies compared to a 30-weeker where you can see only 6% disability was there. We only talk about premature baby hai, ye to acha nahi hoga, but we don't focus sometimes on these simpler conditions. So just in perspective, comparing these 4 conditions, a 30-weeker preterm baby may be most green and little red. A symptomatic hypoglycemia, lethargia, apnea, seizure after low sugars, more than 50% damage. Asphyxia, moderate to severe asphyxia with seizures, all damaged, some not so bad. And jaundice with encephalopathy, almost all damaged, and very, very few babies who may be mild or moderate severe damaged. Now, what we promise to do today, we should not listen to talks. We should make it happen. That half an hour should be spent well to change what we do. First investment, I will prescribe breast pump for a preterm baby. Ask for mother's own milk to come in, because this is the only milk which goes to the baby's brain. I will ask for parent participation, enriched environment. I don't want that mice who is lying alone and does not develop synapses and dendrites. I don't want hypoglycemia to happen. In my unit, I have moved to 50 in first day and 60 in third day onwards. Assess latching and not just how much motion and urine baby has passed in 1, 2, day 3. And if it is not okay, assist the mother. Asphyxia is a multi-organ injury. Please add sensorium to your monitoring chart. It is not enough to monitor vital signs. Jaundice and poor activity is what you should write, not just jaundice. And if jaundice with poor activity is there, it's an emergency. Start intense blue light, start exchange transfusion, whatever you may want to do. I would like to quote Dr. Lily Dubowitz, who is probably the greatest doyen of neonatal neurology. She says, it is a paradox that neonatal brain and neonatal developmental outcome everyone is talking about. But this is the one which is the least evaluated clinically. We want to do MRIs, ultrasounds, and EEGs, but we don't want to do newborn neurological examination or assessment. So we need to add to our clinical thinking, to our notes, what is the brain status of this baby. So I appeal, write in your chart from today onwards, add one more column besides temperature, blood sugar, heart rate, a column called sensorium. And it is very, very simple, nothing, no big rocket science. Tell your nurse, your doctor that if baby is not crying after every 4 hours, he is not demanding feed, he is not having good tone, then I have a problem, it is red. You can see this video, where show it to your nurses, very, very simple. This baby has a good tone, is moving spontaneously, is responsive, is good cry, and good movements. As simple as that. There's nothing great in this. Show this to your nurses and doctors, and they should record this. 4 or 5 hours have passed, and the tone is not like this, cry is not like this. This baby is in trouble, whether he has low sugars, jaundice, asphyxia, whatever it may be. And look at this baby, who is lethargic. We are lifting the baby, is hardly moving, no response to touch. He is dangling loose. This baby is in trouble. Whatever the underlying condition may be, he is not doing well. So simple, green or red. Ask your nurse, ask your doctor whether his sensorium is in green or red. If he is in red, then keep looking for the correctable factors like sugars, perfusion, whatever. So keep it very simple. Add sensorium to your vital signs of temperature, oxygen, perfusion, and sugar. So when we talk about the word development supportive care, many of us get confused with big things like I have to dim the light, I have to cycle the lights, I reduce the noise. They're all important. But please remember, it's a comprehensive package. I want to support the baby's brain development. So it has to include breast milk. It has to include the mother. How many of us will send our children away from home, who is a first 1 year, 1 day old child, 2 day old child, 1 month old child for 3 months where no parent is there? How can you do that to a baby in NICU? So have them there, have an enriched environment, and only then we can have good babies. Thank you for your attention.
Thank you, Dr. Naveen. Hello.
Yes, sir, I can hear you, sir.
Am I audible?
Yes, sir.
Yeah. Thank you, Naveen. Excellent presentation. Really, it's a, as per se, prevention is always better than cure. And you have proved that. There's a great message you have given that breast milk should be a part of the NICU on a very first day. Promote brain development, allowing parents. It is all very few centers are doing all these things. This message should go to everybody that parents should be allowed, breastfeeding should get started, and latching technique. Really, this is a need of time that we have to train our gynecologist. It's a duty of pediatrician to train the gynecologist that latching technique to be get. Because see, whenever we ask for the breastfeeding breast milk, whenever a patient is in NICU, they always say, "अरे यार तुमको क्या समझता है कितना मुश्किल होता है वो मदर को स्ट्रेस मत दो." This is all version by you have to gynecologist. You have to tell all these things and turn them. Really, sensorium is the new thing you told us, and about the jaundice encephalopathy. Really, it's a great. All the good 5 messages. Thank you, Naveen. Thank you. Any questions?
Thank you, Naveen.
Thank you, sir.
Excellent as usual.
Sir.
Thanks, Naveen. You are excellent as always usual.
Thank you, sir.
If any questions are there,
Anybody is having question? I think you covered all the things. There's a brainstorming session, actually brainstorming message, I can say. That's
to have a normal brain, throughout the life.
Thank you, sir. Thank you, sir. Thank you very much, sir.
Yeah. Thanks, sir.
Good presentation.
Thank you, sir.
Thank you, Dr. Naveen Shah, sir, for such an outstanding lecture. Thank you, Khadatkar, sir, and Joshi, sir. We will now start with our third lecture by Dr. Nitin Shah, sir. Chairperson will be Dr. Upadhyay, sir, and Dr. Khobragade, sir. Dr. Khobragade, sir, is our senior pediatrician of Nagpur. He is teacher and guide for many of us. He was professor in Lata Mangeshkar Hospital and associate professor in IGMC. He is director of Khobragade Children Hospital. Upadhyay sir, first of all, I will congratulate Dr. Upadhyay sir. Now he is Vice President of West Zone IIP. Upadhyay sir is Director of Colors Children Hospital and Upadhyay Children Hospital, Chief Organizing Secretary Pedicon 2018 Nagpur, National Organizing Secretary. He is National Executive Board member for 3 years, Chief Organizing Secretary Antimicrobiome 2016, Chief Organizing Secretary NCPID 2012 Nagpur, Chief Organizing Chairman Sepsis 2010 Nagpur, Vice President Maha IP 2014. I request both of you, sir, to chair the session. Thank you.
Hello. Good morning, everybody. Am I audible?
Yes.
Yeah. Good morning, everybody. We have none other than a towering persona in form of Dr. Nitin Shah with us for a lecture on hemophagocytic lymphohistiocytosis. Very important topic in today's present context of COVID, dengue, and all other things. Very rapidly coming up in last 10 years, and we have started recognizing HLH in detail. Dr. Nitin Shah, I don't think needs any introduction. He's a well-known persona in India and abroad. He was the national president of CIP in 2006. He is a fellow of IIP and fellow of Indian Society of Hematology and Transfusion Medicine. Dr. Nitin Shah is first person to look up to in the field of pediatric infectious disease and pediatric hematology, oncology. He is the last word in field of vaccinology. Realize this, friend. He is working with many prestigious institutions like BJ Wadia Hospital, PD Hinduja Hospital, Mumbai, and Apollo Hospital, Navi Mumbai, rendering his human services to the children all across the India. He is a hardcore academician. He is a very good human being. He is always available on phone, on WhatsApp, and on messages. You call him, you message him, he will answer you within a very short span of time. I recognize several times that. He is a teacher par excellence. He is guide to several pediatricians in India, and he is a philosopher in child health advocacy. Ladies and gentlemen, friends, may I present to you a persona par excellence, none other than our teacher, guide, philosopher, Dr. Nitin Shah, sir. Sir.
Well, thank you, Jayant. First of all, congratulations to you for your successful victory as the Vice President, and we look forward you to guide the IFA in even more better heights in the academics. My dear friend, Dr. Uday Bodhankar, Vasant, and all others from Nagpur. I mean, how many names can I take? So Nagpur is like second city for me after Mumbai. And I've been to Nagpur several times and to NAPCON also in the past. This is the first NAPCON that I'm attending, and I'm very happy to be part of it. And today the topic assigned to me, can you see the screen? Are you able to see the screen?
Yeah. No screen. Yeah, but not the slides.
Yeah, that's what I am not able to do it either. I don't know. Let me do it again. Okay.
Yeah.
Share the screen. Yes.
So anyway, welcome Nitin.
Yeah. Yeah. Thank you, Dr. Vadankan. All right. So as I was saying, this is the first NAPCON that I'm attending, and the topic assigned is take the fall when the counts fall. And I think that's a very appropriate topic because we are recognizing a lot of patients where the fever is there and the counts have fallen, and we really don't know what to do. So let's start with a case. A 4-month-old male child, you can see him, he's got some liver and spleen enlarged and he's very irritable. He's got fever without focus and irritability since 20 days. Very small child is very sick for 20 days. No response to oral antibiotics. He had that hepatosplenomegaly that you saw on the picture. He had normal CBC to start with, a normal pap smear and the normal electrolytes, but his CRP was 120. So someone thought of sepsis. They sent urine normal. They sent cultures, blood cultures. They were sent. They turned out to be normal because he was irritable. They did a CSF which showed 100 protein, sugar of 30, which is low because the simultaneous blood sugar was around 80, and there was 60 WBC with almost 10% poly and 90% lymphocyte. Someone thought this as a partially treated pyogenic meningitis because he was given oral antibiotic, very rightly so. And so he was admitted, worked up as sepsis, pyogenic meningitis, and given ceftriaxone and amikacin. Now he should never have received amikacin because that doesn't enter the brain. So that's the mistake number one. On day 5, he developed convulsions and did not respond, and the fever did not come down. So he was shifted to another hospital. There they did a repeat CBC. First time it shows that the WBC though looks normal, the neutrophils are just 10%. So his ANC, as we call, is just 450, which is very low. He has also very low platelet. They repeated a CSF where the CRP has jumped to 360, and the repeat CSF shows proteins which have jumped to 200. Sugar has fallen further, and now there are more WBC than before. But again, mainly most of them are lymphocyte. Thinking that probably he is not responding to ceftriaxone and amikacin, the pediatrician they switched to piptazo and vancomycin. Mistake number 2, never use piptazo in meningitis because the TAZ of the piptazo doesn't cross the blood-brain barrier. So it's a very poor drug for meningitis. So if at all, it should have been on meropenem or something like that. Anyway, patient deteriorates and convulsions continue. Now he starts having GI bleed. All his cultures in the first and the second hospitals have come negative. He is now switched to Mero and Vanco. Patient deteriorates, distress, icterus, distension, and with all this, he shifted to Hinduja Hospital, thinking that whether it is sepsis, whether some immune compromising condition, whether there's some congenital infection, whether he has leukemia because the counts are low, and so on and so forth. So what do we have in Hinduja when he comes to on the first day? We have a child who got pancytopenia. Hemoglobin is low, ANC is 220, platelets are 10,000. He has got abnormal LFT in the form of high SGAT, SGPT, GGT, and a high bilirubin. He has got coagulopathy because his PT and PTT are grossly high. His D dimer is high, his serum fibrinogen is low. That is a point to be noted. A low fibrinogen is a very important sign to HLH. His ferritin, which was never done before, is 2500. That is very high. His fasting triglycerides are 510, which is very high for a small baby. And his cultures, as we had said, was no growth. So what next is to do a peripheral smear and a bone marrow examination. And this is what the bone marrow shows. This is a large cell, as you can see, which has his eccentric nucleus, and he has eaten a lot of things. So he's eaten this pink material, which is all hemoglobin. All these blue dots that you see are the platelets, and this the debris. You can see some nuclear debris of the cells that have been eaten, and you can see one more cell below where it is showing on your right a pseudopod, or as if he's moving to engulf something which is nearby. So this is what we call a typical hemophagocyte, which is not just an activated macrophage, but which has eaten the cells like hemoglobin, nuclear debris, and platelets. So the diagnosis was, of course, hemophagocytic lymphohistiocytosis. So I like the adage that Dr. Ambekar Ashu always say that when you change the antibiotic the third time, don't do it, change your diagnosis. So in this child, before switching to Mero and Vanco, someone should have thought that this is just not infection because the cultures are all negative. We are dealing with something else. We send his perforin, it comes as 98% cell deficient, so he's got perforin deficiency. Parents were to be tested for future pregnancy point of view. They refused the test and they were worried about this child. So why does this happen? What is hemophagocytic syndromes? So definition of HLH is a systemic hyperinflammation which is due to dysregulated immune hemopoiesis. What does dysregulated immune hemostasis mean? One is life-threatening if not treated. Two, it is multisystemic. Third, it is uncontrolled. Fourth, it is excessive, more than what is required. Fifth, it is unnecessary because the source of infection might have disappeared, but the immune response continues. It is ineffective because it's not able to take care of the primary source of infection. And all this leads to unnecessary cytokine storm. The word that you know in the COVID time, that adults who get into ICU and ARDS, they develop what you call cytokine storm. So this is similar to a cytokine storm. And this is because of various acquired or inherited defects in the cytotoxic T cells and the natural killer cells, either in number or their function. So let me explain you this by a cartoon, and I'm sure this will make everything very clear. This is an infected target cell, say a macrophage or some cell which has got an infected those bacilli in this cell. Now these bacilli are sending this target in this infected cell is sending signal to the T cell and the B cell and the macrophage system to come and help to eat away this organism so that the infection is cleared. So what you need a cytotoxic T cell or a natural killer cell, and you need the macrophage monocyte dendritic cell as an effective cell which is going to engulf this infected target cell. Now, how does this happen? How does this infected target cell cleared? So you need a perforin, which are like bullets, which will create hole in this infected cell. This perforin has to be there. It has to be sorted out to come to the periphery. It has to be polarizing, come docking, that means come to the nearby surface, and now needs priming to be able to discharge from this cytotoxic or NK cell and fuse with the surface. So there are several steps involved, right from being present, perforin being present, to polarization, docking, priming, to fusion. And ultimately it will degranulate and it will, like a bullet, go into the infected cell, where along with that the granzymes will go. These are digestive enzymes which will eat away this entire cell, including the organism which are there within, and this cell will be cleared, or with the infected cell will be cleared. Now after this infected cell is clear and this NK cell activity is over, this system has to be doused. That is happens with what we call a auto death of the cell or a programmed cell death. And for that you have the fast ligand and the fast fusing one another, and with the help of capsid killing this entire system and dousing the fire. Now several mistakes can happen while this is happening in the body. And mind you, there is also a fusion between the macrophage and the cytotoxic cell, which also enables these cells to take care of the infected cell. So if you have defect in the perforin, which means perforin is absent, that is the type 2 of your HLH. If you have the perforin but is not able to prime or come to the surface and fuse, that is your monk gene, 13-4 monk gene, that is a type 3 HLH. Or you have defect in the fusion, and the fusion needs help from this syntexin 11 or the monk 18-2 gene. So you have this other two different types of type HLA, that is type 4 and type 5. So you have type 2, which is perforin defect, type 3, which is monk 13-4 defect, type 4, which is syntexin defect, and type 5, which is the monk 18-2 defect. These are the four primary genetic abnormality which lead to genetic hemophagocytic lymphohistiocytic syndrome. So we saw type 1, type 2, type 3, type 4, type 5. Type 1 is related to the 9q, the chromosome 9q 23.1 locus, but we don't know which is the actual gene which is leading to this type of HLA. So that is yet to be found out. And this together still takes care of around 50 to 60% of your primary HLA, and remaining 30-40% we still don't know what is the genetic basis. Now remember the last two, type 4, type 5, which are syntexin or syntexin binding protein. These are milder varieties. So you can see even in a child who's 8 years, 10 years, 15 years coming with a genetic HLH. Whereas the first three types, that is the perforin defect or the monk defect, they are the ones which are very severe, represent in a very early, like in this child. Now, there are other genetic syndromic HLH where the defect is either in the sorting, what we call the least defect, which leads to Chedak-Higashi syndrome, or defect in the polarizing of this perforin, what we call the AP3B1 defect, which is the another type of defect, which is what we call Hersmann-Kludlak syndrome. And the third is a docking, where the perforin just don't start coming out to fuse in the surface. That is the RAP27 alpha defect, what we call Griscelli syndrome. So just remember, there are three syndromic HLH where children have what you call partial albinism, either Chedak-Higashi, Hermann-Kludlaki, or Griscelli syndrome. So we have secondary HLH, or we have syndromic HLH with albinism, which is either Chedak-Higashi, Griscelli, or Hermansky-Pudlak. And there are certain HLH which are associated with immunodeficiency, which are either XLP, MEN, ITK deficiency, and so on and so forth, which are very rare and something which should be left to the specialist. So our patient had, if you saw first time, not only had the liver and spleen, but also looking a very fair child born to very dark parents. You can see these parents are dark, typical Indian like me, whereas the child is very fair. When a fair child is born to the dark parent, the parents are very happy that, okay, I have a fair child, but I am not happy because this is what you call partial albinism. So three things: a fair child, you can see the heterochromia, the iris also is very, very red color or faint color, not the dark iris that you would expect. And look at the hair, what we call ash colored hair, or like you see in an albino. So if the entire features are there, that's a typical albinism, which is a normal feature. But if you have partial albinism in the form of only iris heterochromia, ash colored hair, and a fair child, then that's what we call partial albinism. And these children have one of these three syndrome. So you look at the peripheral smear and you see these clumped granules, either in neutrophil or in the monocytic series. Same thing you see in the bone marrow, all the neutrophilic series, there are granules which are not finely dispersed but clumped. That is what we call Chediak-Higashi syndrome. If you have a very, very ash colored hair, you take a hair from your own head, mount it on the microscope, you take hair of the patient and mount it side by side. You can see normally in a normal hair, the pigment, the melanin pigment is dispersed very regularly, whereas here you can see it is in clumps or granules, but not seen in most of the part of the shaft of the hair. This is what we call Griscelli syndrome. And if you have a child who has got mental subnormality, has got albinism with bleeding and a profound mental retardation, this is more like a platelet dysfunction. This is what we call Hermansky-Pudlak syndrome. So we saw three syndromes: Chediak-Higashi, which has clump granules, very easy to make a peripheral smear diagnosis. If that is normal, take a hair mount. If you see poorly dispersed granules, then that is Griscelli syndrome. And if you have a patient with profound mental retardation, then that's more likely Hermansky-Pudlak syndrome. There are more than the primary, the secondary HLH is more common, especially in country like ours. I mean, I see at least 4 or 5 bone marrows where you see hemophagocytes in a child with PUO, and they are all secondary. You treat the primary cause and the hemophagocytic disease disappears. So you can see it in a bacterial infection like pyogenic, tuberculosis, typhoid, surgical abdomen. We see with all viruses, including HIV, EBV. We have seen in the pandemic H1N1 in 2009, when the new H1N1 came in picture. We have seen in malaria, Kala Azar, any fungal infection. So bacterial, or one of the infections are very common. If you see it in a rheumatological disorder like SLE or a juvenile idiopathic arthritis, then that's called macrophage activation syndrome, which is similar to HLH but different because the treatment is different. And oncologists also see sometimes HLH in patients with malignancy like either leukemia, lymphoma, including Hodgkin lymphoma, etc. And that is a very sinister disease because the mortality is very high in spite of the treatment of the patient. So if you see it in a patient with an SLE, you can see the typical butterfly rash with oral ulcers, especially palatal ulcers. Then that's typical of an SLE-induced hemophagocytis, what you call macrophage activation syndrome. So any patient of JIA or SLE starts having breakthrough fever and a repeat pancytopenia, and your ESR falls, then don't think that it is the response to your treatment. It may be because patient is going to macrophage activation. Immediately do a fibrinogen. In the fibrinogen is low, be sure it is macrophage activation. And unless you treat them with pulse steroid, you may lose a patient of MAS in a setting of a rheumatological condition. So when do you suspect HLH? Any PO which is unresponsive, which has multisystemic involvement. Where is the involvement is where the macrophages are there, because these are unnecessary macrophage activation or unnecessary macrophage induced hyperinflammation. So macrophages in the marrow, so pancytopenia. Your alveolocytes have, the lungs have the microalveolar cells, so you have lung involvement. Your Kupffer cells are macrophages, so you have liver involvement, and your microglial cells in the brain are in the CNS, so you have CNS involvement, and you can also get it in lymph node and the skin. So these are the predominant organs which are involved. So they get splenohepatomegaly and not hepatosplenomegaly. Spleen is more than the liver. They have abnormal LFT, coagulopathy, decreased fibrinogen with falling ESR, very important. High triglycerides and high ferritin. These are the two screening tests you must do in every PUO. A low sodium, and you can see hemophagocytes in bone marrow, in the organs like liver or lymph node. We have even seen hemophagocytes in the peripheral smear. In fact, there's a paper from Wadia by Dr. Karim Boy way back in 80s where she has described some 300 cases of viral induced hemophagocytic syndrome in children, where she picked up most of them on the peripheral smear, not even necessary to do a bone marrow. So you have cytopenia and hemophagocytes, then you can suspect HLH. Remember, a normal marrow does not rule out hemophagocytic syndrome. Absence of hemophagocytes on a bone marrow does not rule out HLH. If you have other criteria satisfied, you are perfectly justified in treating. You may have to repeat a bone marrow if there's a strong suspicion, and you may pick up the second time, if not the first time. Other thing, many times we have seen bone marrows done reported normal. We review the same marrow and we find hemophagocytes. So your mind will only know, your eyes will only see what your mind knows. So if you are not suspecting, you are not tuned to seeing hemophagocytes, how they look on marrow, you will miss them even if they are there. So good to review the bone marrow from a qualified, experienced person. These are the diagnostic criteria. Either you have a straight genetic diagnosis, then of course that is HLH, or you have to satisfy 5 of the 8 criteria: fever, splenomegaly, cytopenias, hypertriglyceridemia with or without hypofibrinogenemia, high ferritin. You have soluble CD25 not available in our country. You can do an NK cell activity low or absent, and you see hemophagocytes in the marrow or CSF or the lymph node. So if you satisfy 5 of these 8 criteria, even in absence of hemophagocytes in the marrow, you are justified in treating the patient with HLH, because if you don't treat in time, you may lose the patient. So supportive evidence is several symptoms of irritability, CSF pleocytosis. Sometimes you see monocytes or histiocytes in a CSF if an experienced pathologist sees the CSF smear. Skin may have rash or lymphadenopathy. You have, as I said, coagulopathy or liver enzymes deranged. Your LDH is usually high, your CRPs are high, and you have hyponatremia and hypoglycemia. So bone marrow is the best site to look for the hemophagocytes, but you can also, as I said, look at lymph node and the liver. So how do they look like? They look like this. You have a macrophage with a nucleus of it, and you can see a complete polymorph within. You can see a macrophage with a pseudopod with a lot of hemoglobin and platelets. So you keep on seeing this type of picture if you do a marrow in a patient with HLH. What is the workup if you do? If albinism is present, as I said before, do a peripheral smear and hair mount for Chiari-Higashi and Griscelli syndrome. If albinism is not there, you do a flow cytometry for perforin. If it is abnormal, it confirms perforin defect. You can confirm by a genetic test. You can do what is known as GRA, granule release or granzymes release assay, with or without IL-2 stimulation. And if that is showing your absence GRA, that is more like a Monk defect or a syntax 11 defect. Again, you can confirm by doing a genetic test. Today, you have a clinical exome sequencing available for 19,000. You can straight away ask for this, because it will not only pick up these two, but also other type of HLH by the same one single test of clinical exome sequencing. In all male patients, look for hypogammaglobulinemia, because you may have a patient who is actually a XIAP or XLP, and they may have chronic colitis. They are usually older children, and you can confirm the diagnosis by doing again a genetic test. All HLH should undergo workup for genetic defect irrespective of age of presentation. So don't let them just go, especially if you have a secondary HLH who relapses after you stop steroids. You should think of that he may be having some primary genetic defect. What are the principles of management? Most of them are fatal unless treated promptly. So control hyperinflammation. What kills the patient? Not the infection which triggered this problem, but the inflammation. So steroids, which help to reduce cytokine and spare the organs. Cyclosporin, it was upfront given in past, but nowadays we don't use it unless it's an add-on drug in a patient who is not responding. IVIG is another good option, which is less toxic. Again, in past, we used to use always etoposide as the drug along with steroid, but now we know etoposide can lead to like secondary myeloid leukemia. So we reserve this as a drug where the patient is not responding to steroid alone. So steroid is the #1 drug which you use. You use etoposide where you're suspecting either a EBV induced hemophagocytic, then yes, you can use, if steroids fail, etoposide. Treat the primary cause, your TB, your sepsis, your malaria, or entry, your dengue, or whatever it is, and the HLH may disappear with just short course of steroid. And for those with genetic defect, once they are controlled, you must find out a donor and do stem cell transplant or bone marrow transplant, because all of them would relapse and very high mortality, almost near 100% mortality without transplant. So this is the HLH protocol. Anyway, just remember to start dexamethasone. Why dexamethasone? Because it enters CNS better, and CNS is one organ which you want to save because many of them have CNS changes. So this is a protocol you can use. And if you have a patient with your macrophage activation syndrome with SLE or GRA, then you can use pulse methylprednisolone because CNS usually is not involved in those patients. See the long-term survival. So those who are effectively treated with stem cell transplant, a lot of them, 70% of them would actually survive. But if you have not treated with transplant, you can see a 0% survival without transplant. So transplant is must in all primary and in all those secondary who relapse after you stop the steroids. There are other modalities. As I said, MAS can be treated with steroids and IVIG. Secondary HLH can be treated with steroids and IVIG, and only those who fail to respond switch to the full protocol. You can have an ATG ALG, anti-thymocytic globulin, anti-lymphocytic globulin based treatment as a etoposide sparing because you're worried about secondary myeloid leukemia. You can use rituximab with steroids for your EBV induced HLH. And there are other which are experimental drugs which you should use only in higher centers and not with the primary pediatrician. So I will just end up by saying this once beautiful statement by our past president APJ Abdul Kalam, and I like it very much, that let's sacrifice our today so that our children can have a better tomorrow. All of us need to understand that HLH is very, very common in pediatric population. In past, we used to give steroid at random without labeling, and some of them used to be okay. But I think if you detect HLH in time and treat them in time, then you can prevent a lot of complication and save a lot of life. Well, thank you very much for your patient hearing and giving this wonderful opportunity to be the part of the first ever NAPCON. And I wish all the success to the organizers for the entire day yet to have the scientific program. Thank you very much.
Thank you. Thank you, Dr.
Thank you, Nitin. Honored to have you today. Thank you for accepting the invitation.
Thank you, sir.
Nitin Shah has given a very well presentation of a very relatively rare primary hemophagocytic lymphohistiocytosis, but at the same time, secondary hemophagocytic lymphohistiocytosis may not be quite rare, and unless there is a high index of suspicion in a primary disease where there is no good response or where there is no expected response in a particular child, one must suspect and go for the relative investigations. I just have one question.
Yes, sir.
How will you differentiate MISC from a patient of hemophagocytic lymphohistiocytosis? Because COVID-19 has given rise to a similar type of presentation. Does it fall in the same category of secondary hemophagocytic lymphohistiocytosis, or does it differ entirely from that of the particular condition?
Correct. So the MISC also has hyperinflammation or cytokine storm. So also is HLH. But HLH has a lot of organ damage, and unless treated in time, they will die. So COVID MISC usually do not have hemophagocytes on the bone marrow. If you have to do, they don't have such hopeless cytopenias. So your MISC presents in two different formats. Children below 6 years and below will come more like Kawasaki, where the WBC will be relatively normal, hemoglobin will be relatively normal. You may have a borderline low platelet, which is very unlikely to be have like pancytopenia in an HLH. You have an older child with MISC, like say adolescent, 12, 10, 13, 14 years, they come with toxic shock syndrome like. So they have diarrhea, vomiting, and they come severely pulseless, BP-less. They may have pancytopenia, but you resuscitate them and a day or two, everything starts coming out. What is more important in them is that CRP is high, the ferritin is high, but not that high, and the D dimer is extremely high, whereas D dimer is not extremely high in HLH. So I think HLH and MISC are having a lot of overlap, but they are two different things. I just want to have one word of caution about this MISC, that lot of children and adults are already infected with COVID, knowingly or unknowingly. And if they are immunocompetent, they will mount an antibody response. So just because antibody for COVID is positive in someone who is having fever doesn't make it as MISC. If we have seen patients having some different neurological problem also having antibody positive, they are having some TBM, something. Also, let's not miss other treatable causes just because the COVID antibody is positive, thinking that all COVID antibody positive with fever is MISC. Because you're going to give them steroids and things like that, and you may. So even if you did any MISC guideline, they say first rule out other infections. And they also say covered with a good antibiotic till you prove that it is MISC. So while yes, MISC is common in today's time, but HLH was there always in past, is going to remain even for the future.
Thank you very much. Anybody has any question? So thanks a lot for your excellent presentation, and that should remind every one of us that we should have a high index of suspicion, and for confirmation of diagnosis we should go for genetic and molecular testing. Thank you very much.
Thank you, Dr. Nitin Shah. It has always been a pleasure and honor to have you with us. Thank you very much for such a lucid lecture, and thank you, sir.
Thank you.
Over to you, organizers, please.
Thanks a lot, Nitin Shah sir. Thank you, Upadhyay sir and Khobragade sir. Now we will move on to our last but not the least part of our session, PET talk by Dr. Mahesh Babu sir. Chairperson for this will be Dr. Mandlik sir and Dr. Sangeeta Gedam madam. Dr. Mandlik sir is well-known pediatrician practicing since last 24 years. He is neonatal and pediatric intensivist. He is director of Colors Children Hospital and Suyash Nursing Home. Dr. Sangeeta Gedam madam is senior pediatrician, was secretary of first pediatric intensive care conference, and she is in close association with Nelson Hospital. I request both of you to chair the session.
Thanks, Jyoti. Disorders have been domain of the adult physicians up till now. But with increase in obesity and change in lifestyle, now the problems are seen in pediatric age groups too. To know everything about sleep, we have Dr. Mahesh Babu with us. Dr. Mahesh Babu Ramamurthy is a senior consultant and head of pediatrics, pulmonology and sleep division, Department of Pediatrics, National Hospital, Singapore. He has done his MD from Grand Medical College, Mumbai. He has done fellowship in pediatric pulmonology from USA and fellowship in pediatric intensive care from UK. He has got special interest in pediatric flexible bronchoscopies and sleep. He started the first pediatric sleep lab in India. So over to Dr. Mahesh Babu, sir.
Thank you for those kind introduction. I hope I am heard.
Yeah, yes.
Yes, sir.
Thank you so much. Thank you so much. Thank you for the organizers for giving me an opportunity to be in front of you. And this is a very new format that I'm doing it for the first time. I'm sure many of you also will be seeing it for the first time. So I hope we will go through this journey together. I've been asked to speak all about sleep, and I've been given 20 minutes. So that's kind of tells you how much the sleep is required by all of us. And therefore, let me just dwell into the project straight away. All of us are hearing so much about COVID these days, the pandemic of COVID, to the extent that every talk that you have with a neighbor is all about pandemics of COVID. But nobody is talking about the epidemic, or rather the pandemic of sleeplessness in humankind. Because I think sleeplessness is a much worse problem. And you will realize that when I finish talking at the end of the day today, that it kills probably more people than what COVID does in a long period of time. And if you look at it, it has almost become a fashion nowadays for people to say, oh, I can do away with less sleep and do a lot of work. In fact, if you look at mankind, almost 30% of our day is spent in sleeping. That means if a person lives up to 90 years, then about 30 years of your life, you are sleeping. Nature is not going to let you do an activity for 1/3 part of the time without there being a significance for it. And therefore, I think we'll have to dig deeper to see what the sleep is doing to us at all. And that is why this topic has been chosen by the organizers. Thank you so much for giving this talk. And basically, I hope the objective of the talk is to bring out the importance, see how sleepless all of us are and the effect of it, and a few tips as to how we can improve our sleep. Now, we all know that we need to sleep, but do you know how you go to sleep? You go in the night to your bedroom, you switch off the lights, you switch off the lamps, you close your eyes, and for most of us, luckily, we go to sleep immediately, right? But you try doing this in the morning after breakfast. You try doing this around 6 o'clock or 7 o'clock when you're in a busy clinic. There is no way you will go to sleep. So what is so special about the night time that the sleep comes to us naturally, right? So there are two processes which happen in the brain. The first process is something called the homeostasis process, right? Right from the time we start getting up in the morning, there is something called the sleep drive, which starts getting up in the brain. And this sleep drive, the longer we are awake, the more intense the drive to sleep happens. So if you're awake for a long time, the urge to sleep becomes more and more and more. Today, we know that this is because of buildup of certain chemicals within our brain. And we know that one of those chemicals is something like adenosine. So if you block the action of adenosine in the brain, like what caffeine will do to you, then the adenosine will not put you to sleep and therefore you'll become alert. And that's why caffeine keeps you alert. So these are called somnogens, and these are important for sleep drive. But it's not just the sleep drive which is important. There is independent to this, there is another process which is happening in the body, and this process is called the circadian rhythm. The circadian rhythm, you've all heard circadian rhythm for hormones, you have heard circadian rhythm for temperature, and so on and so forth. But sleep also is in the domain of circadian rhythm. And if you look at it, it's very interesting to see how this whole circadian rhythm was discovered. So you go back almost 300 years, in 1700s, it was a French geophysicist who at that time observed a plant called Mimosa pudica. This plant, like our sunflower plant, in the morning, the leaves are up and nice and bright. They trace the sun right through the sky from east to west. When the sun goes down, the plant goes down too. The leaves wilt and it's almost lifeless. Come next day morning, it starts up again. So everybody was thinking it's all because of the effect of sun rays. But it took a genius of this person to put this within a black box for 48 hours, complete black box for 48 hours. And basically, and what they did was even though in the middle of the night or at any time in complete darkness, if you went and had a look at this plant, the plant did exactly what it was doing when the sun was there. So it had a cyclical nature to the way it was coming up and going down. So people then realized that this is not due to sun, but it's an intrinsic quality by all living organisms to have this done, right? And it almost took 200 years after that for people to start looking at circadian rhythm in sleep. So it took a great scientist, a Professor Nathaniel Kleitman in the US, who along with his colleague, a research fellow, went into the very deep caves in Kentucky, complete darkness, pitch dark. And he went and both of them stayed in that darkness for 32 days. I don't know how they did it, but they did it. They measured a lot of parameters and then they came out, and to their surprise, they found that even though it was complete pitch darkness, You look at their sleep pattern, you look at the body temperature, you look at many processes. Everything was occurring in a very cyclical process, once in a day, once in a day. So it was an inbuilt cyclical process. The only difference was they found that this cyclical, the cycle time was not exactly 24 hours. It was a little bit more than 24 hours. In fact, it was close to 26 and 27 hours. But today we know in the last 200 years, a lot of research have shown the intrinsic cycle of the body is about 24 hours and 15 minutes. But it is those first rays of the sun which touch us in the morning. These sun rays wake us up. And when we wake up, then we become alert. And therefore, these sun rays are cue for us to set ourselves in rhythm with the nature. And therefore, we now begin to have a 24-hour rhythm when the sun is around, right? We all know that the nervous tissue is required for learning new things. We all know the brain is important for us to store information, but we don't know how. Sleep seems to be a very crucial factor in this, and it plays a huge role. I would like to compare the brain to a computer that you all know about much more. A computer, as you know, has two types of memory, right? So one memory is called the short-term memory or the RAM, which is about 8 MB in a typically good computer. And then you have the hard disk memory, which is the main memory. And today it is many, many GBs, 250 GB or 500 GB or 1 TB, you name it, you have it. So the crucial thing to remember is when you are working away and you have lots of things happening on your screen, the one that remembers all what is happening acutely is your short-term RAM memory. And it has only a finite capacity. If you spill over it, your computer will become extremely slow. And therefore, you need, for long term, you need the hard disk. Similarly, in the brain, you have the hippocampal structures on both sides. These hippocampus is a very small area, and that is the area which works like the RAM in the brain, the short-term memory. And the cortex that we have works as the long-term memory for us. And it works exactly the same way. For example, in the daytime, when you're collecting lots of information, it all goes and sits in your hippocampus. And if you don't sleep after you have learned something new, then it looks as if you have not hit the save button on your computer. Imagine you have been working on a document, you don't hit the save button, you lose everything that you have worked on. Similarly, if you have learned a lot of things, you don't sleep, you don't hit the save button, you don't remember much. So sleep is important for remembering what has been learned. Sleep is also important for learning new things because when you sleep, your hippocampus slowly takes off the new memories and gives it to the cortex and becomes free and empty. So when you get up in the morning, you're fresh, your hippocampus is ready to take new material, and then you learn something, you get it. If you don't sleep in the night, you are not able to take new information at all. So if you think you are a smart student and you want to do a 24-hour reading and you do an all-nighter, the next day morning, the exam will be a terrible uh, problem there because you wouldn't remember many of the things which you would have otherwise remembered. So sleep and brain is not just involved in collecting information and storing it. I'll give you an example of what I'm talking about. There was a pianist who was trying to play his piano and was learning a new sentence. He was trying to play a difficult one. He just couldn't get it. He couldn't get it at all. He got frustrated in the night. He said, I can't do this. He left the piano and went off to sleep. The next day morning, he got up. Lo and behold, first time he could do the whole thing without a problem. So something happened in his brain while he was sleeping. And what was that? The brain collected new information, it synchronized it with old information, repackaged it, and then kept it ready for us to use in the daytime. And that is the power of sleep, my friends, that we have to sleep well. And that's why the adage comes, sleep over your problems. Nobody ever says work hard on your problems for getting it, but sleeping over problems will have solutions for every single problem, right? So when does this happen? We know this process happens. When does this process of transfer happen? We all know that sleep is not a uniform period. We go to sleep, and when we get till we get up in the morning, it's not the same thing. Sleep is divided into multiple areas. The non-REM sleep and the REM sleep, for example. The non-REM sleep and the REM sleep happen in cycles, one after another. And each cycle is about 90 minutes. So every 90 minutes, you go through non-REM, REM, non-REM, REM. The interesting bit is the cycles which occur in the first part of the night have a lot of non-REM sleep. The cycle which happens in the end of the night has a lot of REM sleep, right? Now the non-REM sleep, don't worry, I'm not taking too much into science. That's not the idea of a pet talk. But the non-REM sleep again has multiple stages in it, stage 1, 2, 3. As you go deeper, it becomes stage 1 to stage 2 to stage 3. As you will see, the frequency of the brain waves becomes slower and slower and slower as you go into deep sleep. And the amplitude of the waves also keeps increasing as you sleep. Now, I want to take you back to your radio days. I know not many people listen to radio anymore. But if you're driving, I'm sure in a city, you will switch on to your local FM radio. And you hear wonderful songs, rich in music, very rich in content, no problem at all. Suppose you're taking a long car ride out of your city to visit somewhere. You start your day, you're driving, you switch on your radio, FM radio, and you start driving out of the city. When you reach a certain distance, the FM radio becomes very scattery and you can't hear it well, then you switch it off. And then you switch to AM radio, which is our good old AM radio, and the songs will still play on AM radio. Now, why is that? Anything which has a high frequency has rich content, but it reaches short distance. Anything which has lower frequency reaches longer distance. So in sleep, for example, when you are awake, when you are accumulating a lot of information, that is all in high frequency and reaching just the hypothalamus. But when you sleep, when you get into deep sleep, the slow waves are the ones which take the information from your hypothalamus and shift it to the cortex. In fact, in stage 2 sleep, there is something called the spindles. And it is the spindles which are actually the ones which carry the packets of information to the periphery. And this has been beautifully seen in functional MRI scans, and no problem with that at all, right? So the NREM sleep is the one which seems to be important in learning and memory. Then what does REM sleep do? We all know we dream during REM sleep, there is no question. And when we dream and you look at an MRI in sleep on a REM, there are 4 areas in the brain which get lighted up, right? So one is the visuospatial area of the brain, the occipital cortex. Then your cortical areas, that is where the old information is already there. The hippocampus area, where the new information is there. And the amygdala, where all your emotions are there. So it seems like there is a rich interaction between all these 4, and that throws up a beautiful dream for you and me to enjoy in the night. But in the process, there is integration of all this material. There is formation of new neural networks in REM. And when you get up in the morning, you are fresh and you have all the previous information synthesized, segregated, and kept ready for use for all of us to do. And therefore, brain is not sleeping while you are sleeping. In fact, brain seems to be working harder while you are sleeping, and therefore it's much more difficult for the brain while you sleep than when you are in the day. Stress and sleep also seems to have a very close correlation. If you have a very stressful day, then that night you might not be able to sleep very well. Similarly, if you have not had a very good sleep, the next day seems to be quite stressful, right? All of us experience that in everyday life. One of the ways that the brain does this, sleep, when you go to sleep, there are almost about 700 plus genes which change the way in which they function. About 50% of those genes are upregulated, which means they become more functional. And what genes are these? These are essentially genes which are beneficial for immunity. So if you sleep well, you have a good immunity. If you don't sleep well, your immunity goes down. And people have done elegant studies to show that children are more prone to get human rhinovirus infections when exposed to the rhinovirus if they have had sleepless nights than when compared to children who sleep very well. Adults tend to have a higher incidence of carcinoma when they are not sleeping. And nearer to you and me as pediatricians, people took a bunch of children, divided them into two groups. One group did not sleep well, one group slept well, and all of them were given a vaccine. What did they find? The children who did not get the vaccine did not respond very well to the vaccine. And therefore, right from very basic things in life, sleep seems to be absolutely important. The other 50% of the genes during sleep were actually downregulated. And what were the genes that were downregulated? These were genes which were involved in inflammation. And therefore, when you sleep well, your inflammation is low. When you don't sleep well on a long-term basis, your inflammation goes up. And that is why when you don't sleep well, chronic inflammatory conditions like diabetes, hypertension, cardiovascular diseases seems to have a higher incidence in people who don't sleep well. And these are very well proven. There is no question about it at all. Sleep also has a role on certain hormones in the body like the leptin and the ghrelin, which are useful for eating, right? And the appetite. So you would have all experienced on days when you watch a late night movie, or if you watch a late night IPL. For me, it is late night because IPL matches for me come very late nowadays. You will see that you have a tendency to snack in the night, right? And you don't go and take a good, healthy vegetable to eat at that time. You are snacking something which you will not do when you're conscious of what you're eating. You'll go pick up a Coke, you'll go pick up a very rich, cheesy sandwich or something like that. And that's going to be unhealthy for you. And that is the effect of sleeplessness on the body. I know of a sleep tech who basically, because he was a sleep tech, he was awake in the night. I hope so. And when he was awake, to keep himself awake, he used to eat a lot of junk food. He used to consume a lot of Coke. For a period of time, he ended up being obese. He ended up having cardiovascular problems. He ended up hypertensive. So he had a lot more issues than what it would have been if he had slept well. So that, my dear friends, is the importance of sleep in our everyday life. So I've told you so much about what sleeplessness can do. I'm sure the question in each one of your mind just now is, Dr. Mahesh, you've told us all the bad things. Now tell us, how can we change the lives both of ourselves and of the children who are under our care for them to help them to sleep better, right? There is no magic pill. Stick to basics is what is going to be the main theme. The first thing is avoid certain damaging things. The main damages that we do to ourselves are primarily caffeine, right? So if caffeine, as I told you, is the one that keeps you alert. So if you drink caffeine towards the end of the evening and later on, the half-life of caffeine is almost 6 hours. And therefore, okay, so the half-life of caffeine is quite long, and therefore you will not get sleep when you really want to go to sleep. Alcohol also is not a great friend of sleep, my friends, unfortunately. And alcohol is only producing sedation. It doesn't produce quality sleep. It actually produces fragmented sleep, and that is not good in the long term as well. So if we stick to some basics, one of the simple basics that I would say that all of us can, if we follow is good, is regularity in what we do. We can ask our children, and we should practice it ourselves if possible, is to have a fixed time of when we get to sleep. If you have a regularity of when to go to bed, and then your waking time is also regular, you not only get adequate sleep, you also will get an extremely good quality sleep. Try to keep the light in your bedroom low, keep it dark. No television in your bedroom. No using computers or screen time just before going off to bed. If you avoid all this, hopefully you get a better quality sleep. Let me end today with a quote from Dr. Matthew Walker. He is one of the sleep gurus. He says, sleep, unfortunately, is not an optional lifestyle luxury. Sleep is a non-negotiable biological necessity. It is our life support system. So that is the importance of sleep in our life. Thank you so much for the opportunity. I wish you all and all your children a happy good night's sleep from now on. Thank you so much.
Thank you, sir. Thank you, Mahesh Babu, sir, for such an excellent talk. Thank you, Mandlik, sir, and Gedam, madam, for chairing the session. Thank you, all speakers, for such an academic feast. And thank you to all chairperson for chairing the session.
Sir, just a few questions, Jyoti.
Okay, madam. Okay.
2 questions. One directly from me. Sir, should we say those of us who have very short sleep requirement should do something to increase the quality and quantity of sleep? This includes me. And there are many politicians who boast of just 4 hours or 5 hours sleep requirement. Should we do something to increase our quality and quantity of sleep? Yes.
You are getting me into political trouble. Of course, I'm not in India, so it's okay. But I know who we're talking about. But I would say to anybody, any man, I think enough sleep will help you function better. Think about this. If you are able to function so well with 4.5 hours sleep, what will you function with 7 hours of sleep? So we will be much better off when the leaders sleep much longer. That's all I would say.
Thank you. Thank you so much. Excellent pet talk. For the first time we have having it in a conference, and you did it so well, sir. Absolutely dream come true for me. Thank you so much.
Thank you. Thank you. Thank you so much.
Yes.
Thank you. Thank you all chairpersons for chairing the session. Now I will hand over the program to Dr. Sandeep Mogre.
Very good morning. Welcome back. Once again, warm regards from Academy of Pediatrics, Nagpur. First of all, I am thankful to Shubhra Madam, Dr. Mustafa for giving me opportunity to present myself to this August gathering. Coming to today's panel discussion on vaccination. Vaccines work by preparing the body to fight illness. Each vaccine contains either a dead or weakened germ or part of it that causes particular disease. Yesterday, we had a wonderful session on vaccination by Dr. Khadke, Dr. Rajiv Mota, and Dr. Ganesh Kulkarni regarding hexavalent vaccination, flu vaccination, and DPT vaccination. But still, we have many questions in our mind. So we have our panel discussion on vaccination, scientific explanation, and practical problems. For this panel discussion, I invite our moderator, Dr. Sanjay Marathe, sir. Sanjay, sir, are you there?
I'm there, absolutely.
Yes.
Very much.
I will briefly introduce Sanjay Marathe, sir. He is a well-known faculty senior pediatrician from Nagpur. He is a West Zone ACVIP member 2020-22. Then he is MD DNB in pediatrics, organizing secretary Pedicon 18, chairman scientific committee Pedicon Nagpur, director of Marathi Children Hospital and director of Colors Hospital Nagpur. He has many distinguished, you can say his long CV, but I will just introduce him. Marathi sir, you take over now. And also I welcome the panelists, Dr. S.G. Kasi. He is a convener ACVIP. Dr. Vijay Yavle, sir, past president, Central IP, and Dr. Sagar Kulkarni, vaccine expert. May I now hand over mic to Dr. Sanjay Marathi, sir.
Thank you, Sandeep, for your kind introduction.
My pleasure, sir.
After having a series of excellent talks since morning, let's go for a panel discussion which was long awaited. And thank you, Dr. Shubha ma'am and the team of NAPCON for giving me this opportunity. I can't wish for a better panel than this. And today I am so lucky and you can say I'm honored to have the such an excellent panelist in this panel. I welcome Dr. Sagar, Dr. Kasi sir, and Dr. Yevle. Please include them in the panel group so that we'll be able to hear.
They are there already.
Yeah.
We are there, sir. We are there.
Good. Just to introduce, I can say Sagar is a rising star in the field of vaccinology. And just to add to it, if all of us are following AAP guidelines, that is American Academy of Pediatrics, in his area, they are following Aurangabad Academy of Pediatrics. It's so popular.
Thank you, sir.
Dr. Yevle, who is a very good friend of, I think, a whole IAP, president of Central IAP 2014, a convener of ACVIP in the past. You name it, and he is there, whether it is vaccinology, whether it is immunology, whether it is infectious disease, the rational antibiotic choice and all. We have heard him in so many conferences at national and state level, and a good friend of mine. He has got his own multi-specialty hospital and he is heading the Apollo Hospital, the Department of Pediatrics. So I welcome you for this panel discussion. Dr. Kasi sir, a teacher par excellence, a national speaker for so many conferences for so many years, and now he is convener of the most prestigious ACVIP 2021, a guide for all, a guide for me personally, and always available for any query in the field of vaccinology at any time. And it's an honor for all of us to have Dr. Kasi sir, Dr. Yevle, and Dr. Sagar here as a panelist. In next 1 hour, we have discussed so much of COVID in last 8 months. I think we have forgotten about all other diseases, and everybody, including our patients, were in a lockdown mood. Now everybody is opening. We'll also open our own minds, try to discuss some other diseases also other than COVID. This panel is not a straightforward question answer session and on typical case scenarios, but my aim with such an excellent panel with me, I will try to get a scientific explanation from this panelist for our own queries so that all of us will be benefited with this. So I welcome all 3 panelists, and let us start with this first. I will share my slides. Can you see the slides?
Yes, sir.
Yes, yes.
So this is basically, we are going to discuss the evidence-based science. Now let us talk about the flu vaccine. This is the season where we are going to have the peak transmission of the flu viruses. Yesterday we have already discussed, but then I think the flu vaccine schedule and all that has created lot many, you can say not controversies, but the problems in our own mind that we do not have the answers for all of them. So I decided to take flu, certainly not to create the controversies, but to get answers. Let us start with Sagar. Sagar, in short, you can be very crisp in telling what is the schedule of flu vaccine, and then you can also discuss what is this universal against age appropriate, because it is creating confusion to give 0.25, whether to give 0.5. Some vaccines are only 0.5 available. Some will say, no, go ahead with the past. So will you please clarify for our audience what is the schedule and the universal against age appropriate?
So let me start by saying that when the child comes to you as a first timer, you have to give 2 doses. This you follow between 6 months to 9 years of age. But after 9 years of age, we give single dose only. As far as the quantity of dose is concerned, from 6 months to 36 months, we are using 0.25 ml. After 36 months, we are using 0.5 ml. But recently there has been a change. Now they have shown that even if we use 0.5 ml in children between 6 months to 36 months, it is going to be immunogenically equal, in fact better only, and the reactogenicity is not that much increased. So slowly the recommendations are going to change. Let us say we are in the overlapping phase, and each company might be having its own DCGI approval for 0.5 ml dose even to the children between 6 months and 36 months. As far as the present recommendations are concerned, we advise flu vaccine to all children below 5 years of age. After 5, it is advised only in high-risk children.
Sagar, do you mean to say that universal dosing is going to be a norm in future very soon?
Yes, yes. So everyone is now of the opinion there is no point in having two different formulations, and a single formulation might work for everyone.
So take home message for all of us that in most probably in future we'll have a universal dose of 0.5 irrespective of the age, but the schedule of the age wise will remain same, that we'll have to give 2 doses of 0.5 between 6 months to 3 years, and after first time if you are giving 2 doses 6 months to 8 years, and subsequently 1 dose of 0.5, and there will be a universal dose of all the vaccines of different companies. After knowing this, thank you, Sagar. Sir, it's a very confusing thing when to give the flu vaccine. This question is for Dr. Vijay Yevle. Sir, when should I give the vaccine? Should I give at any time as the recommendation has come, or should I give the pre-monsoon to get the maximum advantage? So what is your take on this, Dr. Yevle? Hello.
He is there, but he's talking with, he's mute. You can't hear him.
Hello.
I'll just check.
Are you able to hear me?
Oh, yeah.
Should I ask the question?
Hello. Hello.
Yeah, Vijay, you're heard.
Go ahead, sir. Go ahead. Yeah.
Can you hear me? Hello.
Hello.
Am I audible?
Yes.
Can you? Yeah. So I was talking about the.
No, he's again muted himself. Yevle sir, please unmute yourself.
No, he is unmuted only. For some reason, he cannot be heard.
Should I go to the next question and then we'll come back to his question?
Yeah.
I think someone can call him up and speak to him.
Dr. Shubhaman, can you call Yevle sir?
So meantime, I think Kasi sir can answer this thing.
Okay.
Yeah.
You want me to take the same question?
Yes, sir, we can go ahead with the same question, and the next question will also for you.
Okay, now when should I offer the vaccine? Now, basically, you have to give the vaccine before the onset of peak disease activity. So when does the peak disease activity occur? There's been a large study done about 10 years back by what is known as the Influenza Network India. 10 centers evenly distributed all over the country, followed up for 1 full year. And what they found that the peak influenza activity is usually in the monsoon period in the vast portion of the country, except the extreme north, that is Kashmir, and the extreme south, some parts of Vellore and Tamil Nadu, Chennai. So the implication of these findings is that for most of the country, the vaccine should be given pre-monsoon. So that is sometime between April and June. For the extreme north, it needs to be given in October or November. And even in the south, which is covered by the northeast monsoon, Chennai and lower southern part of Kerala, which includes Vellore, you may have to give the vaccine sometime between September and October before their peak season. So basically, vast majority of the country, it is a pre-monsoon vaccine.
Sir, because of the recommendations, the confusion has been created that as soon as the child becomes 6 months old, you must offer a vaccine.
Yes.
So how
Now,
to manage this? Because CDC very specifically says give and try to get a maximum protection if you give just before the monsoon starts. But
right.
our recommendation says you give as soon as the age crosses 6 months.
Now, if you see 6 months to 5 years, and specifically 6 months to 1 year, is a period when influenza carries the highest mortality and morbidity. So it is essential to protect these children as soon as possible. So here one should not look at what is a recommended strain, but start vaccination with whichever strain is available. The subsequent year, you can switch over to a pre-monsoon schedule. This is, I think, what is an acceptable practice parameter.
Yeah. Sir, with this, I think some questions have come in our mind. Which strain to use? Southern hemisphere, northern hemisphere, or what is called as latest available? Lot of confusion has been created in the minds of common pediatrician. And I will say, then I will ask few questions on this. So what is your take? Which strain I should use? Whichever is available, or what is the latest available? Or should I go by the zones which WHO has already described and India has put into a southern hemispheric zone?
Right. Now, India falls in the South Asian zone of transmission, where the strains are more allied with the Southern Hemisphere strains. So the recommendation of the ACVIP is preferably to use a Southern Hemisphere strain. And since the Southern Hemisphere strain comes sometime in April and May, it very well fits into a pattern of pre-monsoon vaccination. On the other hand, should we at all use the Northern Hemisphere? Yes, there is also recommendation both by IAP and by the WHO that as far as possible, when a choice is available, the latest available strain should be used. So I think pre-monsoon, use the Southern Hemisphere. If you're immunizing the first time, any time after the month of September, when the Northern Hemisphere strain is available, preferably use the Northern Hemisphere strain. I would like to emphasize that this is not based on strict scientific studies. There are no studies from our country which show what is the type of virus circulating in a particular season. So this is just an expert opinion.
Sir, now the question based on this, now we are using Southern Hemisphere vaccine since the month of say May till September. And
Yes.
now a Northern Hemisphere vaccine has come with the two major changes in the group A. If
Right.
I believe that in India we will be benefited by the Southern Hemisphere vaccine, which is now also available to me in the market
Right.
till June 21, and the latest one which is available in the Northern Hemisphere vaccine, if I have explained to my patients that from May onwards, my patients will be benefited by the Southern Hemisphere vaccine. Now I say, no, even if it is available, I go with the Northern Hemisphere vaccine because that is latest available. How to
Right.
convince the parents?
I think the first thing we need to remember is India is a very vast country, from 8 degrees north, the southern tip, 34 degrees north, that is Kashmir. Now, when you have a such latitudinal extent, there is going to be a difference in the epidemiology of influenza in the different parts of the country. Okay, so it is not possible to have uniform recommendations all over the country, right? Now, regarding coming to your query, Southern Hemisphere has to be used when you're giving it in the pre-monsoon period, when it is really the right time to start the vaccination schedule. We must also remember that once you give a vaccine, the protection does not last for more than 6 to 8 months. The antibody falls to very, levels which are really not protective after 6 to 8 months. So you're not going to have protection till the next vaccine schedule, which is going to be over a year. Please remember all these rules in this influenza vaccination game was done in the temperate zones, which have very, very clear-cut seasons. That means you begin the season October, November, it ends in March, and from March to October, September, there is just no influenza. Whereas if you look at tropical and subtropical countries, not just Asia, not just India, any country in the tropical or subtropical region, the epidemiology is characterized by year-long transmission with peaks occurring at certain times. And in vast majority of the country, the peak is in the monsoon time. So I think the recommendation for using the most recent strain has been done because if you take the Southern Hemisphere strain, it comes into the market 6 months after the recommendation was made. Now that recommendation 6 months back was based on data 1 year before that. So if you keep on giving that strain, even after the Northern Hemisphere strain is available, you're looking at a formulation which is almost 1.5 to 2 years old. So from that point of view, it is preferable to use the latest strain available.
Sir, my only query is the Northern Hemisphere vaccine, the strains have been isolated for the Northern Hemisphere countries. How the
Yes.
patients in my country will be benefited, or in, say, for Maharashtra, if we believe that the Southern Hemispheric strains are circulating, and now I give it to a Northern Hemisphere saying that now it is going to protective, then how I can explain scientifically that Northern Hemispheric strains which are not going to circulate in this part has to be given on a priority?
First of all, Dr. Sanjay, there is no data to show that Northern Hemisphere strains are not circulating. There is no data. Whatever little data we have, the same study which I told you, about that 10 centers all over the country,
Hello.
had shown that throughout the year,
Hello.
there is usually a good match in that particular season between the vaccine strains and the circulating strains. See, as far as India is concerned, you cannot have clear-cut guidelines like the temperate zones as far as influenza are concerned. Even the WHO has said that in a country with a very large latitudinal extent like India, or for that matter, China or Brazil, it's always better to have a staggered approach and vaccinate at the appropriate times, which may not be the same for the entire country.
So can I add one thing, Dr. Sanjay?
Yeah.
So let us say scientifically, I want to have a vaccine which should be perfect match as far as possible. Okay, that is the standard sentence. Right. So what are the strains which are there in the Northern Hemisphere 2020 is Guangdong, Manon, Hong Kong, Washington and Phuket. And what is proposed for the Southern Hemisphere 2021 is Victoria, again Hong Kong, Washington and Phuket. So 3 strains are same what is available in Northern Hemisphere and what is being proposed for Southern Hemisphere. But the older Southern Hemisphere one already it is changed. 2 strains have changed. So what will be preferable will be Northern Hemisphere. That is clear scientifically also.
Hemisphere 2021, there are 2 major changes in type A. They are not the same as what Northern Hemisphere has got. Yes, sir. Dr. Yevle, sir.
Sanjay, can you hear me?
Yes, yes.
I'm sorry, I was unable to convey. Okay, see, Sagar, regardless of which strains are present in Northern Hemisphere, what Dr. Kasi said is extremely important. How are the recommendations made? You collect data from all over, analyze it, and the scientists predict which is likely to circulate in the coming year. So for the Northern Hemispheric recommendation, the meeting occurs in the month of February, and the seed virus is given to the company, and by the time the vaccine is out, it is September, October. So that is the latest collected and collated data based on which the vaccine is manufactured. So naturally, that becomes your latest available strain. So you are in a transition period, say in the month of October, where both the strains are available, SH as well as NH. Remember, these vaccines have expiry of 6 months. So the SH vaccine strain, which is still available in India, would expire in January 21. However, relatively, it is an older strain as compared to the NH strain, which has come in the market and is marketed now. So please remember one principle: use the latest one that is available,
irrespective of the zone.
Yes, Dr. Sanjay, I just one comment can I make?
Yeah.
See, when the WHO makes its recommendation of Northern and Southern Hemisphere strains, the data from India is considered for both the recommendations and not only the Southern Hemisphere. And it's not only India, many other countries in the tropical and subtropical zones are considered in both the hemispheric recommendations. So we cannot have watertight compartments.
Absolutely.
Another question with Dr. Kasi sir. As we have said, the child turns 6 months, suppose in the month of say February, and I have given him 2 doses of January and February and March, the old northern hemispheric vaccine which was available at that time in
Right.
this year. Now I say you come to next July, so I will adjust your vaccination schedule. The next dose is in next July. So what I have done, I have given him a the old one northern hemisphere. Now he will be missing the recent southern hemisphere. He will be missing the recent northern hemisphere strain. And now I will be giving which is supposed to be given for the next southern hemisphere. Am I doing something wrong, or should I revaccinate in the month of June again?
Okay. Now, there is a recommendation that there is no need for more than 2 doses of influenza vaccine in a particular influenza season, especially for children below 3 years. But what is influenza season in our country? We don't have an influenza season. It's a year-long transmission of the virus with occasional peaks. Now, what you are given in January or February, as I told you, will not last for more than 6 months. So irrespective of whether the northern hemisphere strain is similar to the southern hemisphere or vice versa, your vaccine is not going to protect. Again, what I am telling is my personal opinion and not any official opinion. In this particular case, I would like to repeat a southern hemisphere dose in once that particular vaccine is available. Sorry. Yeah, that's right. I'll like to repeat a dose again sometime in June, July, or August or September, a little later, and then change over to the schedule to a southern hemisphere strain from the next year. Here we are looking at a child who is 6 months, who is at high risk for influenza morbidity, mortality. I would rather be over careful rather than stick to guidelines which may not be strictly applicable to our country.
Can we ask this child to come in the month of April and May and start vaccinating for the first time?
No, don't postpone. Don't postpone after 6 months. No, it's not worth it because, as I said, again, it's a high risk situation.
You mean to say better to revaccinate again for the southern hemispheric?
My personal opinion is yes, it is better to revaccinate.
So Sanjay, to recapitulate,
yeah,
in a given influenza season, not more than 2 doses, but in a year you may give more than 2 doses. For example, this child who has taken 2 doses of northern hemispheric strain vaccine can be recalled within a year, as soon as the southern hemispheric strain is made available. However, do not defer the vaccination, especially in very young children, for want of the latest southern hemispheric strain vaccine in the market.
Wonderful. Very well said, Dr. Vijay.
Another question. Suppose somebody has, Dr. Yevle, somebody has received first dose in the month of September with the southern hemispheric vaccine.
Yes.
Now in the month of October, both the strains are available, southern as well as the northern hemisphere. What should be the vaccine dose should be given, whether on the southern hemisphere or a northern hemisphere?
This is again a peculiar situation. Remember, the first dose of influenza when you give acts as a priming dose, and you need a second dose in a child who is less than 8 years of age. So in such a child, if in this overlapping month, I would prefer to use the southern hemispheric vaccine only. That is my logic, and the vaccinology tells me. But there is no, I would want Kasi's opinion on this and Sagar's opinion also.
Sir, as I said, the matching one is the northern hemisphere because 3 strains are going to be same as far as the southern hemisphere 2021 is concerned.
Sagar, it may not happen all the time.
Yeah.
This year, at least this year.
Yeah.
This year, let's talk about this year.
Yeah.
So my opinion will be, I will be using northern hemisphere now.
This year, okay. No.
This year, I am talking about this year, yes.
I feel you should stick to the southern hemisphere because the priming, its 2-dose priming should always be with the same vaccine.
Correct.
And suppose some parents will ask the IT people, if they said, should we revaccinate with the northern hemispheric vaccine for a better protection? What will be our say?
I would say no.
No.
Whatever they've received.
Because except the tip of our country, most of the countries is most of the flu activity occurring in monsoon months, for which SH vaccine is the latest one.
I think we can skip this. We have
Yes.
already discussed. So
Yeah.
take home message for all of us is to use the latest one. But there is no harm in revaccinating again. If you have given it in the early period of the year, you can revaccinate this child and give better protection. So I think most of the queries on this flu vaccine has been cleared. This was just a question for food for thought for all of us. Should we have a vaccine strain, something like a combination of all, to get a maximum protection to our pediatric population? Just a thought came to my mind. In future, may have this kind of a combination vaccine of northern hemisphere and southern hemisphere.
By the way, before 2009, India used to get only the NH strain, if you all remember.
Yeah. I think this problem will be solved once we have a protein vaccine.
Yes.
So these are only the academic inputs for this flu vaccination. Now we'll go to the second, that is HPV, another important vaccine. This question is to Dr. Sagar. Sagar, this is a very common question. Unfortunately, such an important vaccine is never promoted neither by a pediatrician nor by a gynecologist. And every time we'll say it's an excellent vaccine, must be given. And the only vaccine where we can establish a causal relationship between an infection and a malignancy. And now we say at 10 years, please give 2 doses of HPV vaccine. And a common question asked by the parents, why can't we wait for another couple of years because my child is too small? And why you want to give a vaccine? So how do you counsel these parents and convince them to give this vaccine in this age group of 9 to 14 years?
Basically, yeah. The basic brief answer is that we need to give the vaccine before the infection sets in, and there will be no point in vaccinating the child after the infection sets in. That is the first point we have to tell. Second, we have to tell them that don't promote this vaccine as a sexually transmitted diseases vaccine. Never promote. I personally promote it only as a cervical cancer or anti-cancer vaccine, and specifically tell them that it has nothing to do with sexual intercourse. This disease can transmit even by manual, genito-manual, oro-manual, even exchange of underwears and all sorts of activities which are bound to be there even in teenage and even at this early age. So never to assume that your child might not be exposed. So better to vaccinate the child as early as possible, because not only the immunogenicity is good at this age, but the effect will also be good at particular. That is how
So
I
excellent
concept.
immunogenicity in this age group, protection before they are exposed to the viral infection, so we can get the maximum advantage, and non-inferiority has already been established. Excellent.
Yes.
And only 2 doses will be required.
Yeah.
Right.
So
in an immunocompetent girl.
Absolutely. In immunocompetent, only 2 doses, 6 months apart. Now, Sagar, this is a query which is very commonly asked. A 10-year-old girl who has received 2 doses, the second dose was given after 4 months. Is it a valid dose? Yes or no? If it is not, should we give the third dose? When we should give?
So if the second dose is given before 5 months, it is considered as invalid. The
Absolutely.
gap between the 2 doses should be 6 months. Now the question is when it should be repeated. In this particular case, I would like to preferably keep a gap of 12 weeks between the second dose for a better effect. That is the ideal thing.
So take home message for all of us, if the gap is less than 5 months, it should consider the 3-dose schedule, and the third dose should be after 12 weeks of the second, but ensure that the gap between the first and the last dose should be of 6 months. That is the clear-cut take-home message for all of us.
Clear-cut.
Right.
Dr. Kasi sir, this is a very common situation where we recommend it to the age group from 9 years to 45 years. And when we are advising this vaccine to our patients, we also say, even to mother, we advise them as it is recommended till 45 years. Mother is going to ask how I'm going to be benefited when I was already exposed. Most probably I'm already exposed to the HPV infection. And at this age, how much benefit I will get it. So how, sir, we should counsel, and how even the gynecologists can counsel the mothers to get the vaccination?
Okay, now first, this is a prophylactic vaccine and not a therapeutic vaccine. Point number 1. Point number 2, the immunity induced by natural infection is unpredictable and short-lasting. So occurrence of an infection once with a particular high-risk serotype does not confer long-lasting and definite immunity against that particular serotype. Studies have shown that the B memory cell response following vaccination is far superior to that induced by natural infection. Okay. So for all these reasons, the other important reason is that studies have shown that it is extremely uncommon for a lady to be currently infected with more than one high-risk serotype. Okay, so if the lady is infected with 16, this vaccine is going to give close to 100% protection against type 18 and vice versa. Now, looking at it from other point of view, especially in the future 3 study, where they looked at the efficacy, efficiency, safety in the little elderly, that is 25 to 45 years of age, they found that in the vaccinated cohort, even unrelated issues like cervical procedures, etc., were reduced by 40 to 45% in the vaccinated cohort versus the non-vaccinated cohort. So looking at all this data, it is definitely worthwhile offering this vaccine even to older sexually active women, keeping in mind that this vaccine is recommended or licensed only till 45 years of age.
So definitely some advantage will be
Yes,
given to mother.
yes.
And there is no need to do pap smear or any DNA testing for HPV before giving the vaccine.
No, and even the future 3 studies showed that in this particular age group, the efficacy of the vaccine was close to 89% versus 98% in the younger age group.
So we can certainly recommend it
Certainly,
to mothers.
yes, yes, yes.
Yeah.
Sanjay, while there is no need to do pap smear, let us not forget that these two are not two mutually exclusive preventive tools.
I was
Even
about
in
to say that.
vaccinated children, girls, I mean, ladies, they must continue to do.
If you are vaccinated does not mean that you should stop even screening yourself for that. It should be a life. Another most commonly asked question, suppose that I can ask Dr. Sagar and then we'll ask other special panelists to advise. If my child has received first dose when she was around say 12 years, now she has forgotten to take the second dose, now she has come at 17 years. Now she has come with this record of one dose which has received in the age of 12 years. What should be done? Should I go according to the age of the child now or should I give only the 2-dose schedule? So what is the recommendation, Dr. Sagar?
Oh, I think I will continue with the same series which I actually started at the age of 12 years. So in this particular case, I will give only 1 dose and complete the series. That is what I would advise.
Which vaccine you would like to give? The same?
Yeah, and
or
now ideally I should be using the, so first thing I have to be very clear in my mind, what is my objective. If my objective is only prevention of cervical cancer because of type 16 and type 18, I will give the same vaccine, that is bivalent vaccine. Second reason is there are no studies, interchange studies between bi and quadrivalent. And third, which we always say that interchange should not be done. But let me say, Dr. Marathi, a hypothetical situation that nonavalent vaccine is available. Okay. If I have a very broad perspective in my mind that I want to protect the individual against the extra 7 serotype, and my aim is not only to protection against 16 and 18, in that case, I will complete the whole series of 0, 1, and 6 with nonavalent and not with a single dose. That vaccine I am going to consider it as a separate vaccine. That is my opinion.
Sagar will not go into the controversy and discussion on a wrong topic because nonavalent is not available.
Not, it's a hypothetical thing.
But I will say CDC guidelines. At present, CDC has made it very clear. You can complete the schedule with whatever vaccine available. It will have the same effect. Whether it is nonavalent, quadrivalent or bivalent, protection against 16 and 18 will be same. There are no studies. If I give additional doses, 1 or 2 of nonavalent will be an advantage. So better will not go into the discussion of all this because it's a big topic itself for discussion. So very clear-cut message, complete with the whatever the first dose has been given. So consider passage and complete the schedule. Absolutely. Now for the PCV vaccine, this question is for Dr. Yevle. Sir, suppose the cost of the vaccine is same. And if the cost is an issue, how do you select? PCV10 is what Synflorix, now I will use the word Synflorix. PCV10 is what Palmosil we have got. And third is PCV13, which already there. So how do you select when the cost is a factor and cost is not a factor scientifically?
Okay, scientifically speaking, the difference between the existing PCV10, that is Synflorix, and PCV13 is PCV13 has those 3 additional serotypes, type 3, type 6A and type 19A. Now, type 3, whether you have antibodies or not, in the real world, it doesn't have really very significant impact on prevention of pneumococcal disease caused by type 3, which has a very thick capsule around it. So the question remains about the remaining two types, whether 6A is cross-protected by the 6B, which is present in the synflorix or not. Though the manufacturers claim it is always better to have antibodies which are found by the presence of direct antigen, direct stimulation by the antigen. So 6A definitely, and plus the protection against 6C would be better if you have a 6A antigen in the vaccine. So on that ground, PCV13 would score better over PCV10. Then the 19A, again 19A, especially mucosal disease, I'm talking about both 6A and 19A, you require better GMCs, better UPA titer antibodies, which would definitely make PCV13 a better vaccine as compared to the PCV10 vaccine scientifically. However, the Serum Institute vaccine is not yet available in our country. Very soon it will be available. This vaccine is going to be a real game changer, let me tell you, because they have removed the PCV. They have not included the type 3, but they have included the 6A and 19A, and they also have shown very robust titers and the sero response in their Gambian data. The study which is in India is also, though not published, is showing very good seroconversion and titers, especially 1, 5, and 14, which are the serotypes which are pretty prevalent and responsible for pneumococcal disease in developing countries like India. So PCV10 would be something from Serum Institute India, which would really, be, I would say, a customized vaccine for Asia and Latin American and African countries. So of the two available vaccines, if the cost were same, I would prefer the PCV13 vaccine.
And if, okay, so scientifically speaking, PCV13 is a better vaccine as compared to the others, but all of us are looking forward for the PCV10 by the Serum Institute, which has got the ideal combination which suits to our country.
Yes.
Just in short, Dr. Yevle, can you tell us, in NIP they are using 2 primary with 1 booster. Can we use it on our practice, or in our practice we should stick to your 3+1, which is the ideal schedule for all our patients?
First, let me clarify what this 2+1 schedule in NIP means. It means 2 doses in the primary series, which are given 8 weeks apart. That's very important to understand. The first is at 6 weeks, the second dose is at 14 weeks, and the booster is given at the time when the child visits for MR vaccine, that is 9 months. So there are a lot of factors which are taken into consideration when you incorporate a vaccine in the National Immunization Program. The programmatic aspect and the impact as a preventive tool when used on mass scale. This vaccine would prove to be a good, this schedule would prove to be a good schedule, provided you have an excellent coverage. As your vaccine uptakes across the population improves, this would definitely deliver. However, for an individual, in individual practice, when NIP, the pneumococcal vaccine is still not made available across the country in all states and districts, I would certainly stick to 3+1 schedule for an individual protection, where this schedule will be the best available schedule for an individual.
So very clear-cut message from Dr. Yevle, use 3+1 for in our practice. In future, when the NIP in all the states they will go for 2 primary plus 1 booster, we might change our recommendation subsequently. Thank you, sir. This question is basically to update our own delegates who are attending this. This question is for Dr. Sagar. In short, Dr. Sagar, tell me, what is the PCV schedule for an immunocompetent having no high risk about 2 years, as they say 2 to 5? We'll limit it to 2 to 5 only. First question.
So below 2 years, we know 3+1 schedule. After 2 years, if the child was unimmunized, if I am using PCV13, single dose. If I am using PCV10, 2 doses.
This is what the schedule we should follow. Now, sickle cell disease is very common in this part of the country. And cochlear implants, we can see many patients with cochlear implants are coming. Now, in the age group of 2 to 5, now you just tell me what should be the schedule for this pneumococcal vaccine if a patient situation number 1, where he is fully immunized for his age before 2 years, what should be the schedule? Then we'll go to the second question.
Okay.
For an sickle cell disease and cochlear implant, both.
Right. So if the child is a 2 years old child who is fully immunized 3+1, I can directly give him PPSV23 for a sickle cell child and again repeat the same at 5 years of age. But
First
if the
dose
child is
of
unimmunized or
polysaccharide after how much time?
so the first dose should be given 8 weeks after the last
8
dose
weeks
of the PCV.
last.
Always use PCV first, never use PPSV first. And the second dose should be 5 years after the first dose of PPSV 23. That is the basic. But to go ahead, I'll specifically say that let us divide these special circumstances again into two different broad categories. So one category is that which is going to have a highest and continued risk of pneumococcal IPD. For example, let us say sickle cell, asplenia, myelomas, malignancies. So, and the second one is those which are not at that much increased risk, like let us say chronic heart disease, liver disease, cirrhosis, cochlear implants. So in the first group, if the child is unimmunized, I will give 2 doses of PCV 13, 8 weeks apart, then PPSV 23 after again 8 weeks, and PPSV 23 after 5 years. But the other milder version, that is the cochlear implant, a single dose of PPSV 23 might suffice. That is what is the answer.
So a clear-cut message: with sickle cell disease, unimmunized, you give 2 doses of PCV 8 weeks apart and give 2 doses of polysaccharide vaccine to start with 8 weeks after the last PCV and the second dose after 5 years. In case of cochlear implant, which is not an immunocompromised situation, you can go away with the single dose of polysaccharide after giving 2 doses of PCV 8 weeks apart.
In sickle cell, I would like to add that we should be giving penicillin prophylaxis also lifetime.
Yes.
If not lifetime, then at least for 5 years, it should be given.
Yeah.
So now the question on rabies, Dr. Sagar will start and then we'll add other panelists to add on this. A 5-year-old who had got category 3 bite by pet dog 3 months back. Now mother has come to you with the child saying that 3 months back that my daughter or son had a dog bite. Now situation number 1, she has not given any vaccine to this child at that time because it was a pet dog. And then now she said, I heard that this dog was killed immediately by the people thinking that it's a rabid dog. What should be the dose schedule?
Okay. So first, let me start by saying a very basic principle that dogs are not carriers. First thing. So if the dog has lived beyond that 10-day observation principle, then we are safe. That is the first thing. And then I would like to answer your question.
Yeah.
Now here, the dog was not euthanized by the authorities, neither it was tested laboratorically. And we don't know when it was done. The mother has noticed that the dog was killed immediately after the bite. So consider this dog as a rabid because he was not checked, and you will have to give rabies immunoglobulin and 5 doses or 4 doses. Let us discuss out that later on of anti-rabies vaccine. Now, in the other two situations that the dog is now healthy or the dog died after 2 months, in both the situations, the dog has outlived the 10 days observation period. So ideally speaking, there was no need to do anything, but here is a but. I would like to counsel that child that though the dog was not rabid at that time, but you take the pre-exposure prophylaxis, that is the 0728 schedule, that I will advise because I have got a chance to give that to the
we have an
person.
opportunity
That is
to
what
do
is my
pre-exposure prophylaxis.
Right, very correct.
The second question.
And how long which you have asked, sir?
Yeah.
What WHO says that if you have lots of resources, there is no shortage of immunoglobulin, no shortage of vaccine, then you can give it up to 3 years also. But in resource limited setting, at least see to it that this is done till 1 year of bite or 1 year of bite.
Now this question, I know this is a controversy, so we'll ask Dr. Yevli and Dr. Kasi sir. Sir, post-exposure prophylaxis 4 doses versus 5 doses, then RIG versus monoclonal rabies antibodies, and pre-exposure prophylaxis 2 doses versus 3 doses. I will just clarify this. The WHO has strongly recommended 4 doses. The ACVIP has recommended 4 doses. The NCDC says 5 doses. So if we have recommended this, then few people, you can say KOLs, they will say, no, we'll give 5 doses for the legal thing. So what should be our stand? What you will give, 4 doses or 5 doses, RIG also or monoclonal?
Rabies is a fatal disease. If you look at the product insert and the recommendation by the national authority, it continues to give the old recommendations of using 5 doses. Whereas there are a few states where they have adopted this new recommendation of 4 doses. So legally, though the bodies like ACVIP and WHO have recommended 4 doses, I'm not too sure whether legally, and given the product insert that carries dosing of 5 doses, one would be really safe in practicing 4 doses. However, world over, there is a move to shorten the duration of vaccination, immunizing the exposed child, so that the compliance improves and we see no death with rabies. So as of now, from legal angle, I would certainly recommend use 5 doses until such time that the recommendations change and the product insert also changes.
Sir, you will use monoclonal antibodies or RIG for this?
Both are equally effective. Monoclonal antibodies are now easily available. They are cheaper, and RIG availability has been always erratic, and safety and reactogenicity wise, monoclonal antibodies are better. So I would certainly use monoclonal antibody.
Dr. Kasi, sir, your opinion?
Well, from the legal point of view, I think we have to follow the national or the NCDC guidelines. Generally, if the NCDC national guidelines gives more number of doses, it's always better to go for more, because there you are legally safe. Now, coming back to this 4 versus 5 doses, I think basically the shift has occurred not as an economy or cost saving measure, because data has shown that there's no use in giving an extra dose, 5th dose. The rise in antibody titers post 4th dose versus the post 5th dose is very insignificant. Secondly, when they have looked at rabies mortality, they have found that all those who died have died within 28 days of the initiation of the post-exposure prophylaxis. That means adding a 28-day dose is not going to make any difference as far as the morbidity and mortality is concerned. And similar studies have come even from laboratory animals, where the protection is irrespective of the number of doses. And please remember, rabies is a disease where a bite occurs, inoculation occurs locally, multiplication occurs locally, and then it gets attached to the axon. And once it gets attached to the axon, you have missed the bus. So your idea is to get as much of antibodies locally. Having systemic antibodies does not help in this situation. So in this particular case, I think what we have to emphasize is RIG. You're subsequently initiating active prophylaxis to have a little longer duration of protection. So that longer duration, whether you give 4 or 5 doses, makes no difference. So scientifically, 4 doses is correct. But I think legally, from our country point of view, I personally feel it's better to stick to 5 doses.
But if you go legally with the same, my question is, the NCDC does not say use monoclonal rabies antibodies. Then are we safe legally?
Definitely. Yes, the rabies.
You should not use it. You should
Please,
use RIG.
yes, the NCDC has not recommended because according to them, sufficient data is not available in our country, but I do not know what they mean by sufficient data. There are enough studies from our country for both rabies shield and twinrab to show that it works as well as, if not better than, the rabies immunoglobulins. Please remember, as far as rabies is concerned, which is a uniformly fatal disease, when there is an evolution of a regimen, I mean, it's better to stick to something that has been time tested and proven rather than going for something new.
Can we be legally wrong if we give monoclonal rabies antibodies and not RIG? If somebody will go saying that.
See, actually, such a case has never come to court. And once it comes to the court, it's not, I mean, national guidelines will be given preferences, but standards of care are going to be considered. And standard of care by the WHO definitely states that monoclonal antibody not only is as good, they say it should be preferred over immunoglobulins, mainly because it has a lot of advantages. It's easier to produce, you have a better quality control, it costs less, no question of any transmission of any diseases, there's no cruelty to animals or anything involved. From all points of view, it's a superior intervention compared to using rabies immunoglobulin. And I think we are moving the right direction. And I think, as you have said, as far as practice parameters are concerned, I think let us stick to the recommendation of ACVIP that both are equal, but monoclonal antibodies has certain advantages. But as far as the number of doses are concerned, I think let's stick to the national schedule. I think you have to tailor it according to your needs and what is going to save you when there is some controversy.
Sanjay, in a lighter vein, suppose you have a child who comes with dog bite, and if he has concealed a dog bite in the past, and your current regime fails,
You're
how
done.
you are so
No.
yeah. Anyway, let's move ahead.
After this, I will go for another controversial recommendations. We started with polysaccharide typhoid vaccine, which was a very ordinary type of vaccine. Then we said Eureka, when we had this typhoid conjugate vaccine. Depending on the immunogenicity trials, the WHO has also appreciated this vaccine. And because we were not very sure in the arm between 6 months to 2 years, at that time they said better to take one more dose and keep the high doses of antibody titers, so that in a long term we'll have better information and then we'll stick to this. So we added one booster to this. And the last recommendation of ACVIP says, oh, and the WHO also said there is enough data till 5 years that the GMT titers are above fold 4 and it is persisting, and even in between it is going up and down. So up to 5 years, nothing has changed. So give only one dose irrespective of the age. People have started saying, no. ACVIP can say one dose, WHO can say one dose. I will give 2 doses because I prefer giving 2 doses. So my question to Dr. Yevle, sir, on scientific grounds, how do you think that 1 dose or 2 dose? Your own explanation. Then I will ask Kasi sir his explanation.
No, I think this blending of grief and gratitude is a very difficult.
Hello.
Yeah.
Okay.
Yes, sir.
Now, Sanjay, first of all, typhoid is a bacterial disease, number 1.
Yeah.
Number 2, let me give a clarification that conjugating polysaccharide does not make it 100% efficacious vaccine.
Yeah.
Even the TCV, the typhoid conjugate vaccine, does not have 100% efficacy. I'm sure all the listeners are aware that the efficacy which is tested in the human challenge and in the country like Nepal is around 86-87% against blood culture proven typhoid disease. Number 2. Number 3, as you have rightly said, the recommendations have evolved over a period of time based on the immunogenicity data which was studied by the vaccine which was manufactured by Bharat Biotech. Initially, they had data up to 2 years where they showed sustained levels of antibodies and without a significant, remaining pretty high over the minimum required. Now, mind you, that minimum required is extrapolated from the study done on a different typhoid conjugate vaccine, and it's an arbitrary level where the efficacy in that cohort was matched with the titers in those subjects, and that has been extrapolated. So honestly speaking, we do not have a definite correlate of protection. However, assuming that that is the reasonable correlate of protection based on the 2-year data ACVIP said, and an excellent boostability, and taking into consideration the fact that very young children may not have opportunity to get boosted by natural infection, the ACVIP then recommended 2 doses in this age group below 2 years of age. Subsequently, when this vaccine was reviewed by WHO SAGE, they looked at the data which was submitted for 5 years. And again, as you rightly said, in the age group below 2 years, they could demonstrate persistence of antibodies both in boosted as well as unboosted individuals, which were well above the minimum required for protection. Again, that minimum is that presumed correlate of protection. We know that there is something beyond these antibodies which is in action. However, if you analyze this antibody kinetics, there is a drop in antibody levels and then there is a rise again. This perhaps occurs because of natural boosting. Secondly, if you look at the avidity index of these antibodies in unboosted, the avidity index is not as robust as found in the boosted individuals. There is a dip in avidity index as well. So having said all this, and then typhoid disease is a bacterial disease where even following natural infection, what does not develop a robust immunity, and you have a very high inoculum and you get typhoid again. And in real life, even following 2 doses of typhoid conjugate vaccine, we have seen disease occurring. So taking into consideration all this, it is my personal opinion that for a child who gets typhoid conjugate vaccine below the age of 2 years, a repeat dose may be required. However, WHO would make a recommendation based on the data which is available. So there is no, there is data to say that the antibodies persist. However, there is no robust data to say that how long it would protect in terms of efficacy. But WHO would make a recommendation for masses in general, and ACVIP has followed the same recommendation. But for the reason that I have tried to explain, I personally feel that a second dose would be required, especially in children who have been inoculated in the age group less than 2 years of age.
Sorry to interrupt in this. Suppose even if you have seen the boostability response, it is
Yes.
only for the first year. Again, it has come down to the same. So it is not that if after giving a booster, it is persisting on the high level for 5 years. It is persisting only for 1 year. Again, after 1 year, the levels are same.
But,
so you never know what high is.
But we do not know what is going to happen after this dip in the titers which occurs following a booster when they are exposed to a natural pathogen. We do not have that data as of now.
5 years data, boosted and non-boosted. The boosted kids are only 1 year titers, then they have come down to normal, almost
Agreed,
same.
agreed. But we do not know when these children are challenged. Those who are boosted, those who are unboosted, challenged in future. What would happen? We really do not know.
But whether the boosted child will have a different immunogenicity response if they are exposed to the natural infection.
You look at evolution of recommendation all other vaccines. All those which were recommended as a single dose over a period of time, the recommendations have changed, where we have learned from our experience and the epidemiology that single dose has not worked in the long run. Antibodies do decay, and especially now we are in in the era where there's a lot of typhoid, a lot of natural boosting. As the vaccine coverage improves, and this is being discussed at a very high level, and this vaccine will be fast tracked and very soon will be introduced in the national immunization program. So I do not know.
I definitely not going to protect you for getting less number of multi-drug resistant typhoid. Neither 2 doses will give you better protection for your kids. But most probably in your practical or your personal opinion, you will continue to give second.
I will, sir. I do practice it that way. Young children, I give a second.
If you look at the evidence-based opinion regarding persistence of antibody titers, ACVIP has privy to the 7 years data. Even at the end of 7 years, in the less than 2 years and above the 2 years, the antibody titers are at least 4 to 5 times higher than the seroprotective titers. Okay. So based on the antibody titers, there is no indication for giving a second dose. That is one thing which we have to remember. The second thing we should remember is efficacy data is available only for children who have been given the vaccine after 2 years of age. There is no efficacy data for children between 6 months and 2 years. Now, if you compare the Vietnamese vaccine and the Bharat Biotech vaccine, the efficacy is almost similar for both the vaccines. That was 87.5% over 42 months of follow-up. Whereas with this vaccine, in the challenge study, it was 87.1. In the Nepal study, it is somewhere around 85%. So it's always very similar. So I think what data is applicable for the VRP, we can even apply to this vaccine as far as seroprotective titers, both for short-term and long-term protection. Now the issue comes to those less than 6 months, less than 2 years. We know that vaccinated early, the immune system is still immature. We know that the antibody titers may not be good, the quality of antibodies may not be as good. Okay, we know many of them, and we know in the below 2 years, the titers have dropped drastically by the end of 2 years. Of course, but never gone to titers which are not protective. And then they have reasons stating that there is natural infection. Natural infection may vary across populations. Remember, this study was done in a population which covered mainly the low income area or the low middle income, but not the higher income areas, which may be more relevant to us in private practice. But all these are theories and postulates. You see, when we make a recommendation, we have to give more importance to existing scientific data. Expert opinion, if you see in the hierarchy of evidence, is the lowest. And that cannot be made a decider for making recommendations. So taking this into consideration, I still prefer a single dose of typhoid conjugate vaccine.
Thank you. So we'll not.
Hello.
Sir,
what is conclusion, Sanjay?
Hello.
What is conclusion, Sanjay, ultimately on this issue?
At conclusion, we'll take at the end of the discussion question and let me tell you, recently under the guidance of Kasi sir, ACVIP has given excellent immunization guidelines for him during this COVID-19. So I will ask Kasi sir to take this question and just give a take-home messages for all of us. The questions which will kill, because there are many cases where mother was positive, the baby was born. Then we have many cases that they were worried about whether to take their kids to the pediatric hospitals for vaccination. Whether my child will be having more chances of getting other infections, suppose or a COVID infection, suppose I have taken a vaccine. So I would like to Dr. Kasi sir to just give and take home messages on this question.
Okay, thanks, Sanjay. Now, taking the first question, if all due precautions of SMS is followed and adequate precautions are taken in the immunization center, there is no reason why there should be increased risk of getting COVID by taking your child to a vaccination center. Now, is my child more prone to COVID-19 infection? Answer is a clear no. What is the risk if I vaccinate during the incubation period of COVID-19? There is no data as far as COVID-19, but taking other viral vaccines, viral infections into consideration, there should not be any increased risk in vaccinating during the incubation period. We should continue with the same schedule. There is no doubt about it. Now, the last question is immunization for newborn if mother and child both are positive. Now, in case both mother and child are positive, if the baby is symptomatic or asymptomatic or mildly symptomatic, or even if he is moderate to severely symptomatic, the recommendation is to postpone the hepatitis B till discharge, and OPV and hepatitis B also to be, OPV and BCG also to be given at discharge, but provided at least BCG and OPV should be given within about 15 days. It should not be extended beyond that under any circumstances. Now, but if the mother is positive and the baby is negative, if he is asymptomatic, you immunize like any normal child. If he is mildly symptomatic, like any normal child. But if he is severely symptomatic but not tested, then you postpone the vaccines, as I said previously. That is, postpone hepatitis B till discharge, postpone OPV till discharge, and postpone BCG. But preferably give both hepatitis B and OPV within 15 days. Here, a caveat, if the mother is HBsAg positive or HBeAg positive, you apply the same conditions as a normal child. You do not postpone hepatitis B vaccination.
Give on a priority these things if mother is positive.
Yes.
So very clear-cut message from sir.
Sanjay, just a point. More than 700 newborn babies delivered at Nair Hospital. Babies roomed in with the mother. Not a single newborn baby was symptomatic or developed COVID.
Yes.
So don't worry unnecessarily.
We are very fortunate that we can vaccinate them as normal
Absolutely.
babies. Sir, Kasi sir, I will not go into the details. The repurposed vaccine of BCG and MMR till yesterday we are saying that there is no recommendations for this. But recently ICMR has says that there is some role of BCG in adults. Sir, your take on this? Because so many patients are asking us about their grandfathers and all that. Is there any change in our policy about the BCG in adults?
No, see, basically, this issue of MMR and BCG came up because observational studies showed that there was some inverse relationship between BCG and MMR and the severity of COVID. because of that, studies have been initiated. And now the studies done regarding BCG and COVID in our country by ICMR, which has been done in quite a few centers, initial studies have shown that BCG elicits a good immune response in the elderly. But we must remember that there is immune senescence at 60 or 65 years of age. You may elicit a quantitatively good response, but qualitatively it may not be good. Remember, the B cell response following immunosenescence is you get good number of B cells, but most of the B cells are basically memory B cells and very few naive cells. That is, the capacity to react to new antigens becomes less and less. So unless we have efficacy data, I don't think any strong recommendations can be made for the use of these vaccines as far as prevention of COVID is concerned.
Thank you, sir. So very clear-cut message. Now this question is for Sagar, who was keeping quiet for a long time. And as Dr. Yevles has said that you should have the DCGI approval and the government should approve it. Now my question to Sagar, a 9-month-old child who has come to your clinic, who has received 2 doses of Rotacil or any rotavirus vaccine, and now he has come for the 3rd dose, which he has missed, unfortunately. What will be your reaction? And suppose I tell you that he has received Rotacil, which has been cleared by Government of India, DCGI approved, and already included in package insert. Will you give the 3rd dose even if the child is 9 months, or you will not?
So Marathi sir, I think you have decided to stroke all controversies today.
Not to create controversy. Just to ask the open, because these are the questions asked by other pediatricians to us.
So basically, I would like to say that I am convinced with the WHO take-home message which they had given, that you should remove the age restrictions till 3 years. I'm convinced by that. I know that more 47,000 deaths will be prevented. There might be some cases of interception. First thing. Second thing, I am also of the opinion that I should follow the government guidelines till 1 year. But what was preventing me? What was preventing me was a DCGI approval. What was preventing me was the studies, as they were not available from the vaccine companies, and the product monographs were also not changed. But as you have rightly said, recently the Rotacil liquid, I'm not talking about the lyophilized one. The lyophilized product monograph says 6 months only.
Yeah.
But the Rotacil liquid monograph, if you see, they have mentioned safety studies that there were no cases of interception even till 1 year. They have specifically said that Rotacil liquid can be used till 1 year of age. So here we have approval also. Here we have studies from vaccine company also. Here we have entry which has been done in the product monograph also. So here I will give that vaccine till 1 year of age also. But other vaccines, Rotarix or Rotavac, again, I am going to go back my statement that there is no approval.
Sir, Kasi sir or Dr. Yevle, would you like to agree with this?
I agree with Sagar, but one more additional point is, if you look at the adverse events of into suspension following rotavirus vaccine, it is temporally related and causally related following the first dose of, by and large, rotavirus vaccine. Yes. So it is unlikely that this would occur with the 3rd dose. So I would be liberal and I would use it at 9 months of age. And with Rotarix, the question doesn't arise. It's only 2-dose schedule. For the other brands, I would use.
Kasi sir?
In private practice, I will strictly stick to recommendations. I will not bend the rules. Now, stick to established recommendations. Okay. And clearly the recommendations show that you have to give before 32 weeks in general by the WHO or whatever vaccine is being used. Of course, these recommendations came at a time when Rotacil was still not in existence at all. I would prefer not give. Now, second, if you see what is the difference in protection between 2 doses and 3 doses, studies with Rotatech has shown between 2 and 3 doses, the incremental protection is minimal. So I feel even with 2 doses, this child is adequately protected. At the same time, by not giving the 3rd dose, you're saving your backside. I will not give a 3rd dose after 9 months.
So Kasi
Still recommendations change.
Okay, but as Marathi sir is saying that recommendations will be changed by ACVIP, means you only. So if it has already come in the product monograph and now it is legally valid, will you be changing the recommendation this year?
So are you spilling the beans?
No, I don't think, no. We have really not considered changing at all. It will create a lot of confusion. That we should have uniform recommendations for all the available rotavirus vaccines.
Sandeep, I will ask you how much time do we have, because we have already crossed 1 hour and another speakers are already in the line. Dr. Sandeep
Sir,
Mogre.
yes, sir. The discussion is fantastic. We have got eminent faculties with us, but I'm sorry, the time is up, and we should wind up our discussion.
Fine.
Thank you, Sanjay
Can I-
Marathi sir, for the
Can I ask
fantastic
one question?
moderation. I am thankful to Dr. S.G. Kazi sir, convener ACVIP, Dr. Vijay Yavle sir, past president Central IIP, Dr. Sagar. Great discussion. Congratulations.
Thank you, sir, Dr. Yevle sir and Dr. Sagar, for your scientific inputs, clearing our doubts. And I'm sure delegates will go with the very clear ideas with minimal controversies now left. There are many questions to be discussed, but I'm sure we'll have one more session and we'll have the same panelists and we'll discuss on the same platform.
So,
Thank you once again on the behalf of NAPCON. Yeah, madam.
So thank you so much, Sanjay, and
Thank
for
you.
your excellent moderation. As expected, this is the highlight of our conference. And as you said, I still have 2 more months to go till my tenure ends. So we will have one more session with the experts.
I have kept my promise also, madam, that I will
Yes,
get
yes.
Kazi sir and Dr. Yevle and Dr.
Yes,
Sagar.
yes. Thank you, sir. Thank you,
Thank
Kasi
you.
sir. Thank you,
Thank
Dr.
you.
Yevle, Dr. Kulkarni.
Thank you.
Thank you very much. Thank you for the opportunity. Thank you.
Thank you.
Thank you, panelists. Now we go to the next session. That is, we have a few lectures. The session in charge are Dr. Meena Deshmukh, madam, Dr. Pankaj Agrawal, and myself. I welcome Dr. Meena Deshmukh, madam. Are you there, madam?
Hello. Yes,
Dr.
yes,
Pankaj
she's there.
Agrawal.
Thank you,
She's
sir.
there.
Thank you. Let us move on to the next session after the wonderful session on vaccinology. I welcome the chairpersons for the today's next session, sepsis mimics in neonates. Our first chairperson is Dr. Nishikant Dahiwale. He is a fellow in neonatology from CMC Vellore and NICU in charge and director Nucleus Mother and Child Super Speciality Hospital. And our next chairperson is Dr. Sandeep Yadav, sir. He's a well-known pediatrician and neonatologist of Nagpur. He's a director, Health City Children Hospital. We welcome you, sir. Over to the chairpersons.
Good afternoon, everyone, and thanks the organizer for giving me opportunity. And I'm going to introduce Dr. Swapnil Bhisikar, a shining star in neonatology in Nagpur and also in Vidarbha. He is a senior consultant in New Era Hospital and is also associated with the Nucleus Mother and Child Super Specialty Hospital. He has experience in neonatology for last 8 years, and he is also expert consultant in lactation. He has many original articles published in the national and international journal, and he has won a Best Research Award during his DM curriculum. I welcome you, Dr. Swapnil Bhisikar. Dr. Swapnil Bhisikar, are you there? Dr. Bhisikar?
Am I audible?
Yes. Welcome you, sir.
Yes,
Over
you're
to you.
audible. Share my screen. Yeah, so today's topic is sepsis mimics.
Yeah, you are audible, Swapnil.
Yeah. I will move it. So my first, actually, I generally keep this slide at the end of my presentation. That lesson in life, they are learned, they are repeated until they are learned. So what this says that if you are not getting, applying this thing in our practice, that if you are not able to approach coming to one conclusion about whatever the diagnosis this thing, the thing is going to be repeated until the thing you are coming in front of it. Now a topics, the term says that sepsis mimics, the importance is given again to sepsis. However, my job is to take you away from the diagnosis of a sepsis and when to think beyond giving ampicillin, gentamicin, any kind of drug which are listed over here, and to think beyond sepsis, or maybe sepsis like situations, or maybe having subtle sepsis but underlying situation which is hovering in the baby, which is really completely different. So what is neonatal sepsis? Neonatal sepsis at one hand is very scary. At one moment you are going to say to the parents that baby is good, at the other moment the baby can land up suddenly into the very morbid conditions. It has various long-term morbidities. It is one of the leading cause of mortality also. However, by saying so, we cannot avoid the overuse of antibiotics in NICU. There are antibiotic associated complications which can be a short term, including renal failure, to the long term, causing change of microbiota leading to obesity and all. Also, it makes change, addition of antibiotic or change of antibiotics makes clinician blind about the actual diagnosis of the what is going into the NICU baby. Now, if you take into the usual causes of diagnosis, I mean, it's acute deteriorations or gradual deteriorations, all the whatever I have listed in this slide, that within 24 hours or between 24 hours to 7 days, or maybe more than 7 days, sepsis always remains one of the differentials. However, in picture shown in these slides, none of the babies will be benefited from the giving antibiotics. This picture shows that baby is having some certain kind of a heart conditions, I will say absence anomaly, and this is a surgical condition, that is tracheostomy fistulas. This is having a baby with a severe IVH, in which antibiotics they are not going to one, or maybe antibiotic could be the one of the cause of giving causing such kind of a large IVH. In this picture, there is a large PDA. Definitely, it will not be benefit from giving antibiotics. And in this picture, there are multiple collapses, which is definitely not being improved by giving antibiotics. Now, this is the slide which I wanted to show you, that if you give antibiotics unnecessarily, maybe the diagnosis may be something different, and if you give antibiotics, there are composite outcome, that means mortality as well as incidence of IVH, incidence of NIH, it is much more with each day antibiotic being given to the baby. And at the same time, long-term mortality, long-term morbidities, severe neurological injuries also increases if you give long-term antibiotic to the baby. Now, by saying so, I just wanted to say, in order to avoid darkness, either you have to open your eyes or switch on the light. That means if you want to come to one conclusion that this is a diagnosis, you have to look into the babies. What are the other possibilities apart from sepsis? Now, in case of NICU, these are the common symptomatologies in which it could be subjective. Most of them, they are subjective. You can see if there is tachycardia, it may be a transient thing. It may be, if there is tachypnea, it may be also a transient thing. So coming to sepsis per se diagnosis will be difficult if this kind of subjective findings are not rechecked or reconfirmed. So if this is thing, if they are symptomatology like these things, you are going to order a sepsis screen in the neonate. Now, what I am going to do in next few slides are I'm going to tell you that how sepsis screen can mislead you by giving antibiotics and not getting the results. So I will enlist some few case-based scenarios. So this is a case scenario one. These are the common case scenarios which will everyone be able to relate it. That this is 36 weeks to 2 kg IUGR neonate. Mother was having absent, which is going to reversal of diastolic flow. It was an emergency LSCS. Baby was kept with mother for feeding. However, the baby had abnormal movements for which the cause was found to be hypoglycemia. Again, the hypoglycemia was treated appropriately by giving D10 bolus, and then baby was shifted to NICU. At NICU, baby was in little bit, we can say this baby is in hypothermia with heart rate being 140, apneic, and there was no response, but the baby was completely lethargic. Again, the RBS was low. Was started on GIR of 6. Now, investigation which was sent after starting GIR was CBC, blood group and electrolyte, which is a common scenario in NICU. So what we have got that hemoglobin was 24 gram per TL, which is on higher side. TLC is 3,400, which is very low, and platelets, thrombocytopenia is there, and CRP being 12, which is, if you consider some lab more than 6 is supposed to be positive CRP, and urocreatine, which is normal for that age, and sodium is on lower side, that less than 130 or 135, and again the lab glucose is showing hypoglycemia. Now the question is, are we dealing with sepsis in this scenario? Because CRP is being high, TLC is being low, platelets are also low. So these are all three pointers which points towards that there is a sepsis. However, the real question is not about whether to give antibiotics or not to give antibiotics. The real question is there some other pathophysiology going inside the baby? Now, if you take CRP as a marker for sepsis, positive predictively means if CRP is positive, what is the chance that baby is going to have sepsis? It is supposedly very low in case of a EOS. EOS is that is early onset neonatal sepsis, because there are multiple neonatal, multiple non-infectious etiology having from stressful birth to any kind of injection baby is receiving, that it produces inflammatory response which can cause CRP being elevated. So by this statement, we can say that antibiotic can be avoided. No, it cannot be avoided. But the question we have to ask ourselves is, are we dealing with only sepsis, or there's some kind of a thing which is going associated with sepsis, which is causing all kind of problem? So in this clinical scenario, we can say that polycythemia was one of the cause which is going along with the CRP positivity. Now, CRP is a compound which is being produced by liver. You can see that with after birth, CRP rises gradually. So a rising CRP initial 24 to 48 hours, we cannot take into consideration that this is because of sepsis. Similar thing we can conclude about procalcitonin also. So there are no actual lab parameters which will guide you that this baby is having sepsis or not having sepsis. Similarly, course of TLC, it rises and then it falls. Such kind of these are the two charts which is used for term as well as for preterm babies. Now you can see that TLC count at this is neutrophil count, which is at birth, which is almost like around 3,000 or 4,000, which rises to not more than 7,000. So if you take into consideration in case of IUGR babies, this response is also suppressed by chronic stress in utero. So having TLC count which is almost lower than the lower limit can be contributed to IUGR status. At the same time, polycythemia per se can cause TLC count to drop. Similarly, is a feature with platelet count. Platelet count has been documented to be on lower side, and maybe thrombocytopenia in babies with IUGR. Now, coming to our scenario, our case scenario. This slide's not moving. Our case scenario, that baby was given antibiotics, partial action was done, GR was increased, which is management of hypoglycemia, but still the baby is having hypoglycemia. Yes, this is a scenario which we can get in NICU. Now again, investigation were planned. We have sent hemoglobin, and then TLC count has improved, platelet count has gone down again. Blood gas was done just to find the cause why the baby is having persistent hypoglycemia, hypoglycemia which is persistent. We have done baseline investigations, which is blood gas, ammonia, lactate, CRP. CRP is again raised in this case. Sodium was on lower side, potassium is normalized, creatinine is also, it's normal for that age. Insulin, which was on higher side, cortisol, again, it is normal for that. And blood culture was, it came out to be sterile. Now, in order to evaluate this case with the point of view of sepsis, what we have got only CRP being raised. Again, what I have told you that CRP is an inflammatory marker. It's not a marker of a sepsis. So in that case, it only tells us that that continuous inflammation is going inside the baby's body. Now we can see that hemoglobin is 20. That means hemoglobin has fallen from 24 to 20. But I will tell you, this was an arterial sample, which was a click in this case, in which you again has polycythemia, because we have done venous sampling, and again it came out to be 24. So now polycythemia, which was initially normovolemic polycythemia, now it has gone to hypovolemic polycythemia, because as the day increases, as the day has gone from 1 to 3, there will be dehydration because of evaporative blood loss, evaporative water loss from skin or from skin. In that case, the polycythemia, which was initially normovolemic, now it is becoming hypovolemic polycythemia. So this baby again will require partial exchange. Now again, we'll talk about hyperinsulinism in this case. Though there was insulin level which was on higher side, but we have to consider before giving any of these drugs. These all drugs have side effects. Before giving any of this drug, are we dealing with a transient phenomena or we are dealing with a permanent phenomena? So a permanent hyperinsulinemia, these babies, they are mostly large in size. They grow rapidly because insulin level in their bodies, they're at their peak. So even so these baby, if they are not gaining weight and this baby is having insulin level which on a higher side, this is very less likely that this baby is having permanent hyperinsulinisms. So for transient insulinism, any of these drugs, they are not indicated. They indicated the treatment of underlying cause, which is in this case is polycythemia. So if you treat again polycythemia, then that will be resolved. So this what has happened to this case, this baby has again given, we have what I have found in various analyses that 5 ml का blood निकाल दिया, 10 ml का blood निकाल दिया. This should not be the case. You have to do partial exchange with the total whatever the formula has been given. It comes out to be around 10 to 15 ml per kilo of body weight, and body weight can be calculated by using this rolling charts. And if you do this kind of thing, see, if you do partial exchange properly, we have to counsel parent in that way also, that we are doing partial exchange to remove the blood in order to decrease the viscosity. It doesn't mean that आज blood निकाल दिया तो कल जाके उसको blood चढ़ाना पड़ सकता है, because उस moment पे हमें what we want to do at that moment is that we have to decrease the viscosity, and there is only one way to decrease this viscosity, that is to remove baby's blood in whatever manner that we have discussed. So what are the learning points from our case? That CRP, it does not guide us in starting antibiotics, because if you find baby is lethargic and if you ordered CRP test, it can come out to be negative, because CRP takes are at least 12 to 24 hours to rise, and we are not going to see rise in short while. One CRP normal does not guide to withhold antibiotic decisions. Sequential CRP just indicates inflammatory continuations, which may be sepsis or which may not be sepsis also. CRP may take time to resolve or may not normalize, not normalize within few days. So antibiotic duration cannot be guided by the use of CRP. Even TLC count along with platelets can be low on day 1 to 3 in IGR. However, if platelet count continues to be low after day 3, yes, we have to find some other etiology for thrombocytopenia. Yes,
He is not audible.
Hello. Dr. Swapnil sir, you are not audible. Hello. Dr. Swapnil sir, you are not audible.
Hello. I think we have lost Swapnil.
There might be some connection issues.
And unmute yourself, Pankaj.
Hello, ma'am. Am I audible?
Yes, you are.
Yes, you are.
There might be some connection issues.
Dr. Pankaj, we are not able to hear you.
Hello.
Yes, madam. Some network issues there. Dr.
Hello, ma'am. Am I audible?
We lost the connectivity with Dr.
Yes.
Swapnil. So we'll just wait. He was about to finish, right?
Yes, I think it was almost.
Yeah, ma'am, it was almost over. We can wait for another 10 to 15 seconds if he gets back.
Sandeep.
I think yes, madam. We'll wait for a few seconds if he's able to join. Otherwise, we'll switch to the new lecture.
Then
next
otherwise
lecture.
we'll move to
Yes,
he is there.
Yeah. Can I continue with second case?
Yes, sir. Please. You have another 5 minutes.
Yes, now he's back.
Yeah. Okay. I will
He's
continue.
back.
I will stop in 5 minutes. Yeah, this is a late preterm, mother being GDM, not
Sandeep,
well controlled GDM.
unmute yourself. Dr. Swapnil,
Baby was admitted with diagnosis of TTN and was given oxygen
please
support.
unmute yourself. We are not able to hear you.
No, madam, we can
We
hear
are able to hear you.
We are able to hear it.
Okay. So this is a case of TTN, the transient tachypnea of newborn. which require CPAP support. Yes, sometimes these BVs, they can require CPAP support. Respiratory rate was quite high, 110 per minute. Bilateral air entry was good, and fine captations were there at basal area. This baby,
Dr.
since there
Swapnil,
was only
please connect your screen. Your screen is not visible. Reconnect your screen again.
Yeah.
Share your screen.
Yeah, is it okay?
No,
Is it okay?
Still not able to see.
Yes, we can see now.
Yes, it's getting started.
Okay. Yeah. Should I move?
Yes.
Yes.
Yeah, you continue
Okay.
with your lecture.
Okay,
Yes,
so this is a
yes.
case of TTN which requires CPAP support. Mother is being GDM. This is a common scenarios, and we have done basic investigation,
Pardon,
that is
Dr.
CBC, which is
Swapnil. You were on which case? Was it case number 2 or 3?
case 2. Yeah, case 2.
Okay. Fine. Go ahead.
Yeah. This respiratory distress was persistent on day 2. Respiratory rate has been decreased from 110 to 100. X-ray was repeated again. You can see the shadows which are there on peripheral fields. We have done sepsis screen, which came out to be positive. Blood culture was sent on day 1 itself. Now the question is, are we dealing, since the respiratory distress is persistent even on day 2 of life, are we dealing with sepsis here? Now this respiratory distress persisted even on day 3. Now again, if CRP is positive, can we consider giving antibiotic to this baby? No. In this case, since the mother is being GDM, which was not well controlled, and it is an elective LSCS, in which chances the transient tachypnea newborn is very high, this baby is bound to have a TTM which will be persistent. This is called as a malignant TTM. But now the interesting part is coming. This baby started apnea after day 4 of life, which requires stimulation. That's why CPAP support was continued. This happens usually in our ICUs, no? So we have done CBC, which was quite normal. Platelet is normal. CRP has increased from 6 to 10. Urine culture and CSF study was done because to find what is the cause of apnea. We have done blood culture, which was done on day 1 of life, which came out to be sterile. Calcium, phosphorus, sodium, USG head, all they came out to be normal. Now, why these apneas? They are occurring on day 4, and that too so severe, which requiring CPAP support. Now, there was no response to caffeine. This baby ultimately required intubation and landed on ventilator. 34 to 36 week babies, 2.4 kilo babies is landing up on ventilator because of apnea. So what we have thought of some kind of metabolic disorders. So I have ordered ammonia and lactate, which came out to be normal. NBS was sent, but I will tell you because of short order, it came out to be normal also. CSF was done, which was also normal, not suggestive of any kind of a meningitis. Now, but this baby, after day 7 of life, after 3 days of ventilation, this baby responded. And this baby was again extubated from CPAP and then continued on HFNC, and there were no apneas afterwards. So what is the
Hello,
diagnosis?
sir, last 2
Why this
minutes to
baby
wind
was
up, sir.
having recurrent apneas? Yes, we have given antibiotics for. Yeah. So what I have want to convey in this case is that if the baby is not responding to 8 mg per kg of caffeine, we can increase the dose up to 20 mg per kg, because there are various studies which are now telling that caffeine citrate can be increased up to 20, or in some studies they are going up to 40 mg per kgs to tackle this kind of apnea of prematurity, in which when you have excluded rest of the parameters. Now coming to the drug doxapram. Yes, doxapram is also one of the drugs which can be used in case of babies who are having recurrent apneas and who are difficult to extubate, difficult to take care from ventilator. I think before, should I go to case 3 or is it?
Sir, time is over already, so
time.
I think that should skip that case.
We can give we can give 1 minute for any questions, or somebody has anything to ask to the speaker.
Okay, so this is the case of what I want to highlight is that if
Dr.
there
Swapnil,
are if there is
Dr.
there are
Swapnil,
two
sorry to
neonates.
interrupt.
Yeah.
Yes, sorry to interrupt. I think Dr.
Just
Pankaj, is
one
the time
more
over?
case.
Hello. Yes, sir. Yes, sir. Please. So, Sandeep, sir, you were
So you
saying
can
something.
just briefly tell us about this case.
Yeah, of course.
Yeah.
The
So
another
I
1
will
minute. You can
just give
wind up
two
in
minutes.
1 minute, 1 to 2
This
minutes.
is okay. I will wind up. So this is a case in which the two neonates at the same time in ICU was started having respiratory distress after getting overcoming their prematurity status, which has been increased from 650 grams to around 130 gram in an ICU. Ultimately, what we have found that this baby was having multiple collapses and respiratory distress, and since both the babies were having respiratory distress which occurred in an ICU and we considered as an outbreak, ultimately what we have found is both these babies were having rota as a rhinovirus as an infection, which has been transmitted from one attending sisters to both the babies. This kind of case, they will not respond to any kind of antibiotics. Again, it is a common scenario. I will just highlight this neonate. Day 4 neonates with fever landing up in encephalopathy with rash like this thing is nothing but it will not respond to any kind of antibiotic whatever you're going to give the babies, and CSF will show that it will be a bacterial management meningitis, but actually this is a diagnosis of a chikungunya in neonate, which will happen on day 6 to 8 once the mother is having chikungunya in during the last 10 to 14 days of her pregnancy. Again, if you what I want to convey that if in case of neonates, if you have persistent rise in CRP and you are not getting organisms, try everything to find the organism, because in some of the cases we have found CMV as a cause of a feed intolerance, in which baby has received IV ganciclovir and the baby and patient has come out. This is a case of congenital tuberculosis in which the baby was persistently not gaining weight, was having cough, which we generally miss. Cough is not taken seriously in neonates, but ultimately this landed up in having congenital tuberculosis, and we treated with antitubercular drugs. Ultimately, if sepsis screens are negative and baby is requiring ventilator for long period of times, we have again come to one of the unusual differential diagnosis of interstitial lung disease, which we have diagnosed on gene analysis. But ultimately this child succumbs. So what I want to convey is that sepsis screen is a very what you call as a misleading to pointer towards sepsis. However, sometimes they can point up to subtle sepsis, rising CRP with no organism. Think about viral, think about other organisms, other etiologies to come to the conclusion apart from giving antibiotics. And that's all, sir. Thank you.
Thank you, sir. Sandeep, sir, you want to say something? Hello.
Thank you, Dr. Swapnil. Excellent talk.
Thank you,
Thanks
sir.
a lot. We were happy to have such a knowledgeable speaker like you in our NAPCON, and you gave an excellent talk. There are a lot of things the audience learned. There are so many septic mimic things, like simple things like hypothermia, PDA, IVH, and not to just rely on the lab parameters. Always go into the history, look clinically, always reassess your decision time to time. Just don't wait once you start antibiotics. Try to avoid antibiotics and follow as much as aseptic precautions as possible. Excellent talk, Dr. Swapnil. Thanks a lot. I would ask if anybody has any questions, they can ask Dr. Swapnil.
Sir, we can take the questions later on.
We don't have
Actually,
time for
we
question
don't have
answers.
time actually.
Yeah.
So can we move on to the next session? So
Yes.
chairperson
Thanks
for
a lot,
our
everybody, and we move to the next session, sir.
Thank you, sir. Thank you. So chairpersons for the next session on aneurysms in children are Dr. Anil Raut, sir. He is the past president of IIP Nagpur, an EB member of Central IIP from 2020 to 2022, and Dr. Nilesh Kumbhare. He is the senior pediatrician from Sauner. We welcome both of you, sir. Over to Dr. Anil Raut, sir.
Good afternoon, everybody. In this session, we all know that enuresis, that is inability to control micturition, is a common problem in pediatric population, and that too nocturnal enuresis is very much common. It has to be tackled in your own way. Otherwise, most of the time I tell parents of children with nocturnal enuresis, तुम्ही याचं आताच काहीतरी करा, otherwise याची बायको समोर जाऊन पळून जाईल. So these are the things, and if it is not a simple nocturnal neurosis. It can be something neurologically. It has to be diagnosed and treated at the proper time. And we have eminent speaker for that, renowned nephrologist from Nagpur, Dr. Achanta. Over to Dr. Nilesh.
Thank you, sir. Today we have with us Dr. Srinivasa Achanta, who is a practicing pediatric nephrologist since 15 years, and he is the director of Kavya Kidney Clinic at Bantali, Nagpur. Over to Dr. Srinivasa sir for his presentation on neurosis. Thank you. Srinivasa sir.
Good afternoon, everybody. At the outset, I would like to thank the organizers of this NAPCON wholeheartedly for giving me a chance to deliberate on this very important and frequently encountered topic, that is childhood enuresis. So I'll share my screen with you. So first we start with the definition of what childhood enuresis actually means. It's in simple terms an uncontrollable leakage of urine, also defined as wetting at an inappropriate time and place in a child older than 5 years of age. And it can be either continuous or intermittent. We start with some case scenarios which will give us a deeper insight into the problem spectrum, the presentations and the treatment. A 5-year-old girl presented with intermittent incontinence since 3 years of age, and the urinary frequency was normal. There was no urgency or hesitancy. On physical examination, she was average build and average nutrition. The back and spine on external examination was normal. Her basic urine routine was done, which was normal. A sonography was done. Bilateral normal sized kidneys were there with corticomedullary differentiation was well maintained. But a very important finding on sonography was that the bladder was distended with post-void residue, that's PVR, of around 50 ml. Any post-void residue more than 20 ml at any age is significant. So this post-void residue is definitely significant. Subsequently, an MCG was ordered and the bladder was found to be in normal position but was over-distended and many lateral diverticuli were seen. And also on that X-ray, spina bifida of S1 and S2 was seen. So an MRI spine was ordered and it was found that the child had a thin syrinx running throughout the extent of the spinal cord with the lower end of the cord at the upper border of elbow. So this was a neurogenic bladder. This is the picture of the MCUG, which is showing diverticuli. The MRI, which shows the syrinx in the lower area. So the child was asked to have a voiding diary maintained by the parents, and the child used to void after every 2 to 2.5 hours, and the max voided volume was 80 ml. So a urodynamic was also done, and it showed that detrusor overactivity was present, and the bladder capacity was 90 ml. So the child was started on tolterodine and clean intermittent catheterization to give relief of the residual urinary volume. Now we are coming to the second case. This was a 9-year-old boy who presented with recent onset of increased frequency and urge incontinence. He had nocturia since last 15 days, which was not there previously. And there was no dysuria, hematuria, pyuria, or any fever. So the investigations were ordered. Again, a urine analysis was done, and it showed that around 8 to 10 pus cells per high power field was there. But there were no proteinuria, there was no glucosuria. A urine culture sensitivity midstream clean catch was ordered and it grew E. coli more than 1 lakh. So the colony count was significant. A USG KUB was ordered, which was normal. The child was treated on lines of a simple UTI with oral ofloxacin for 7 days as per the sensitivity report. And after completion of the therapy, the incontinence disappeared completely. So this case, the enuresis was a secondary enuresis and it was due to UTI. And once the UTI was treated, the child was relieved of the symptoms. Now we come to the third case. This was a 10-year-old boy who had presented with dribbling since birth. The child belonged to poor socioeconomic strata and so never had sought treatment for the condition. And the parents used to think, ये तो होता है बच्चों में, ये normal. The past history gave a significant history of recurrent pyurias and dysuриas. But again, these symptoms were neglected. And on examination, the child was average built in nutrition. A urine analysis was ordered, it was normal. A urine culture sensitivity was done, which was sterile. Kidney function tests were done because the child had long-standing complaints. Blood urea was 46 and serum creatinine was 1.1, which was significantly high for his age. A sonography was done. It showed bilateral hydronephrouretrosis and the bladder was distended with post-void residual volume of 50 ml. MCG was done. Posterior urethral walls were found. The bladder was trabeculated and there was bilateral vesicoureteric reflux. Now this is the picture of MCUG where you can see reflux on both sides to the extent of grade 5. So the child was managed with fulguration of walls and a low unilateral ureterostomy was done. A course of tolterodine was tried and also timed voiding was encouraged in the patient. So this was a case of an obstructive uropathy. So now we come to the fourth case. This was a 10-year-old boy who had presented with bedwetting and the child had never gained nocturnal continence. The child passed urine at least 2 times during night daily, but there was no daytime increased frequency, no polyuria, no polydipsia, no dysuria, pain in abdomen or pyuria. There was no history of constipation. There were no recent stressors or problems at school. There was a significant history of enuresis in the father and an older sibling. On examination, the child was normal build, spine and back was normal, and the child was psychologically distressed because of bedwetting problem. So again, the child was investigated, urine analysis and urine culture sensitivity were normal. Specific gravity of the first morning sample was 1.015, which is fairly okay. USG was normal. Fasting sugar and kidney function tests were normal. So this child is a case of primary nocturnal enuresis. So we'll come to the management of primary nocturnal enuresis. So the non-pharmacological management, reassurance to the patient as well as the family. Fluid redistribution should be advised. We'll come to the details. Voiding void volumes, the frequency has to be maintained, and also daily, night, whether the child is passing urine in bed or not, and if yes, how many times should be noted. The child was explained along with the parents alarm therapy, and after 1 month of doing alarm therapy, the frequency had decreased by around 25%. Now this is a picture of an enuresis alarm where you connect the probe to the child's genital areas, and once the child initiates wetting, the probe detects the wetness and gives an alarm which wakes up the child. So the child halts the passage of urine in sleep when he is awakened and then attends the washroom. But the child continued to have a poor self-esteem, so a trial of tolterodine was given. And subsequently, it was noted that there was reduction in bedwetting by around 80% within the first 2 weeks of initiation of therapy. But yes, simultaneously, the non-pharmacological measures were continued. Total therapy was continued for 12 weeks with tapering of the drugs. And again, for the next 12 weeks, the non-pharmacological measures were reinforced. And at the end of 6 months, only occasional episodes of bedwetting were noted, around 1 per every 2 weeks. And so the treatment was further continued. Now, we can differentiate incontinence into 2 types, which is continuous and intermittent. And intermittent incontinence can be either daytime or nocturnal incontinence. Now, what are the causes of incontinence? In case of continuous incontinence, it is always organic. So congenital malformations like ectopic ureter, damage to external sphincter, and neurogenic bladder can be there. Whereas intermittent daytime void would be voiding dysfunctions, neurogenic bladder, non-neurogenic, neurogenic bladder. And nocturnal incontinence is always multifactorial. And incidence of spina bifida would be around 0.3 to 4.5 per 1,000 births. Now we come to some epidemiology of primary nocturnal enuresis. 15% of the 5-year-olds have primary nocturnal enuresis, and approximately 15% enuresis resolve their symptoms each year. And by about 10 years of age, only 10% of children remain enuretic. About 5% of 10 years old and 1% of adolescents may remain enuretic subsequently. Now, etiology of primary nocturnal enuresis would be developmental delay, like delayed functional maturation of the nervous system causing failure of arousal mechanisms. Some genetics are also involved. If both parents have been nocturnal enuretics, 77% offspring have nocturnal enuresis. And if one parent has nocturnal enuresis, then 44% chance that their children may have enuresis. And major dominant gene is located on chromosome 13. Sleep disorders, enuretics tend to be deep sleepers. And in enuretics, many times functional bladder capacity is decreased. Now in history, we have to get into details of incontinence, whether it is intermittent or continuous, whether it is recent onset or prolonged. What is the urinary frequency? If the child is voiding more than 8 times per day or less than 3 times per day, then it is abnormal. We have to ask whether the bladder sensation is appreciated or not by the child, whether there is any history of gait abnormality or impairment of sensations over lower limbs, or there is any motor deficit in the lower limb, and whether there are any symptoms of dysuria, urgency, or hesitancy. So in enuresis patients, we need to see whether there is any weight loss, excessive thirst, whether there are any urinary tract infections, differentiate whether it is primary or secondary enuresis, whether there are daytime bladder symptoms, what is the voiding frequency, whether there is constipation, fecal incontinence, whether there have been any behavior problems, like the child is having some problems at home because of some fights with the parents or fight with the siblings, or is the child having some disturbance at school, and is the child abnormally depressed by enuresis episodes. And again, the family history has to be obtained. So examination and investigation wise, physical examination is always important. You need to check the weight, height, blood pressure, and a basic neurological examination with more concentration on the lower limbs and the abdomen. Genital inspection is important, and if constipation is there, we need to do a rectal examination. Urine test in the form of dipstick to detect any glucosuria, any leukocytes, protein, erythrocytes, and bacteria. And if UTI is suspected, urine culture sensitivity. Blood tests like kidney function test, blood sugar should be done. Radiological investigations like sonography, MCUG, and if indicated, MRI spine need to be ordered. So bladder diary has to be maintained, as I have previously enumerated what all needs to be noted. Voiding charts to be noted, and maximum voided volume is very important. Now there is a very important formula, like how do you calculate the expected bladder capacity? So expected bladder capacity is calculated by adding 1 to age in years and multiplying the product by 30. So if, for example, a child is 10 years old, so we add 1 to it, that is 11, and we multiply this sum by 30. So 330 ml would be an expected bladder capacity roughly for a 10 years old child. And we also look into the max voided volumes, and we infer that if the child is having less than 65% of the expected bladder capacity as the max voided volume, then it is small capacity. And if the child is voiding more than 150% of the expected bladder capacity as the max voided volume, then it is a large capacity bladder. Urodynamics, we won't go into the details because usually pediatric nephrologists and urologists would go into the details. So in urodynamics, we would see what is the voided volume, what is the urine flow rates, what is the residual urine after maximal voiding, what is the detrusor pressure and activity, and what is the bladder compliance. And if detrusor overactivity or underactivity is noted, the treatment would differ. And in dysfunctional voiding, also UDS can detect these issues. So treatment-wise, we need to treat the underlying condition. Urologic referral may be required in most of the cases. Structural abnormalities require surgical intervention. Detrusor overactivity, high pressure bladders would require a course of tolterodine combined with clean intermittent catheterization. And in low pressure bladders, tolterodine doesn't work. So in those children, only clean intermittent catheterization would help. And even if this doesn't help, then creation of continent stomas surgically would be required. Non-pharmacological measures, urotherapy. So information, reassurance, regular voiding habits, prevention and treatment of constipation, and appropriate voiding important. So in fluid distribution, we need to tell the parents that of the total day fluid intake, the child should take 40% between 7 a.m. to 12 noon, remaining 40% before evening, that is from 12 noon to 5 p.m., and only 20% of the daily fluid intake should be given after 5 p.m. The child should not consume high caffeine diets like coffee, tea, colas, chocolates, ice creams, because these interfere with the sleep cycle and also cause diuresis. Voiding charts and bladder diary usage is very important. Support and encouragement to the family as well as the child. And if the child who has been previously continent starts again having one wet night per month after remaining dry for 6 months, then it is again defined as a relapse of nocturnal enuresis. Bladder training exercises like daytime bladder exercises useful, especially if the functional bladder capacity is low. So if the child has a severe urge to pass urine, the child should start learning to hold urine to increase the bladder capacity. And the success rate of enuresis alarms is around 66%, but 46% relapse, but it is more effective than imipramine. Usually alarm therapy should go for 12 to 16 weeks and need to continue till 14 consecutive dry nights are achieved. Pharmacological measures wise, daytime incontinence plus nocturnal enuresis, trial of oxybutynin can be given in the dose of 0.1 to 0.2 milligram per kg per day, but oxybutynin usage is approved only after 12 years of age. Tolterodine is better for small functional bladder capacity. Until 5 years of age, the dose would be 0.5 milligram BD. Between 5 to 10 years, 1 milligram BD. More than 10 years, 2 milligram BD. Or also 0.1 milligram per kg per day can be given. Imipramine needs to be avoided as the relapse rates are very high. That is around 96%. And also imipramine decreases REM sleep and increases vasopressin and it relaxes detrusor. So this table just shows us the comparison of oxybutynin and tolterodine. So dry mouth, constipation, blurred vision, mood swings, dizziness, flushing, fatigue, dyspepsia. These are all more in oxybutynin as compared to tolterodine. The new drug on the block, desmopressin, intranasal is not indicated as high risk of hyponatremia and seizures are there. Oral tablets can be given 1 hour before bedtime. Start at a dose of 0.2 milligram, give for 2 weeks and titrate the dose according to the response. We can escalate till 0.4 milligram. Nowadays, melt tablets are also available, which are more effective to be given 30 to 60 minutes before bedtime. Start at a dose of 120 micrograms and in 2 weeks may escalate to 240 micrograms. But we should not give during fevers, vomiting, diarrhea, sports day or vigorous exercise. It does better than alarm therapy in the first week, but the end of 12 weeks, alarm therapy is better than desmopressin. It is indicated in nocturnal polyuria cases where the nighttime urine output is more than 130% of the bladder capacity with the normal functional bladder capacity. So the latest guidelines state that desmopressin should be used only for sleepovers and in camp attendance, and a therapeutic trial should be given 6 weeks before actual therapy. So we're coming to the last slides, that is take-home messages. So incontinence can be either continuous or intermittent. Continuous incontinence is associated with structural abnormalities of lower urinary tract. Most patients would require a urologic workup. And intermittent nocturnal continence, non-pharmacological measures preferred for treatment and combination therapy in resistant cases, response rates 70 to 80. Thank you.
Thank you, Dr. Achanta, for your informative lecture. And one thing I noticed that you were seen on two photographs with two different backgrounds. It was just Achanta watching Achanta. Thank you very much.
I'm
Thank
sorry
you,
for
sir.
that, sir, because actually the network in my end is not good since last 4-5 days. So I sent a recorded presentation already to the organizers. And for taking any questions, I was online. I'm sorry for that.
Thank you so much.
We were seeing you watching your clone, whether he's talking properly or not. Thank you
Sir,
so much.
thank you for the first time we could do it in NAPCON, a video presentation sent by you, sir. Thank you so
It's a
much.
novel thing. It's a novel thing.
Right. So hereafter, more and more things are going to be virtual, but we are blessed to have your real presence, sir. Dr. Achanta, thank you so much.
Thank you.
Thank you, sir. Over to Meena Deshmukh, ma'am, for the further proceedings.
So, good afternoon all. And thank you, Dr. Pankaj Agrawal. Thank you, Shubha madam, for giving me the opportunity. Moving on to next session, that is immunology and immunodeficiency for the generalist. For this difficult topic, we have expert faculty, our very own Dr. Girish Subramaniam. I request Dr. D.S. Bhagwat, very senior pediatrician from Nagpur, and Dr. Praveen Page to chair the session. Over to you, Dr. Praveen Page.
Thank you, Meena.
Dr. D.S.
Dr.
Raut.
Meena.
Yeah, Page sir, you are audible.
Introduction kar raha Page.
Dr. Praveen Page.
Yes. I hope I am visible. Hello.
Girish has started his screen sharing.
You go ahead with the introduction. You go ahead.
Okay. Good afternoon, dear friends. I, along with my senior teacher, Dr. D.S. Rao, we are thankful to the NAPCON committee for giving us this opportunity for chairing a session on a talk on immunology and immunodeficiency by Dr. Girish Subramaniam. Girish has been a consultant pediatrician and an academician for the last 30 years. He's the director of Colors Hospital, and I would congratulate the committee for selection of this type of his speaker, because he is the only person who can keep people awake at this time of Sunday siesta time. Girish, over to you. Girish?
Thank you, Anil. Audible?
Is he there?
Yeah.
And visible?
Yeah. Yes, sir.
So
Yes,
to
you are
understand, okay, to understand, am I full screen?
No, you are not full screen.
Yeah, okay.
Yeah, now you are there.
So to understand immunodeficiency, let us first understand immunocompetency. What happens when the microbe tries to enter the human body? The microbe first encounters the first level of defense, which can be classified as physical, chemical, and microbial defense. Physical defense is our skin and intact mucous membrane. Chemical defense is the acidity in our stomach, some enzymes like lysozyme. And don't forget the microbial defense. Many of you might be surprised how microbe enters the defense of our body. The most important natural defense that nature has provided to us is the thick coat of microbes which line our skin and mucous membrane, full of commensal cells. You take antibiotics, you get rid of the commensal cells, and the body is ripe to be entered by pathogenic microorganisms. So use antibiotics judiciously. The microbe some way breaches this first line of defense and enters the body. As soon as it enters the body, there are some non-specific patterns on all microbes. These non-specific patterns are known as pathogen-associated molecular patterns. Please hold on my word, they are non-specific, they are non-antigenic, but they are non-specific patterns which are found in almost all microbes. They could be peptides, they could be peptidoglycan, or even RNA segments in viruses. These pathogen-associated molecular patterns are identified by our receptors These receptors are known as pattern recognition receptors. Pattern recognition receptors. The commonest PRP, the commonest pattern recognition receptor in our body is toll-like receptor. This is one example of a pattern recognition receptor. This pattern recognition receptor now attaches itself to this pathogen-associated molecular pattern, releases a lot of cytokines which lead to leukocyte neutrophil emigration. So the next step is, in response to these cytokines, these neutrophils, they start adhering first, they start rolling, and having rolled at a particular point, they squeeze between the endothelial cells and enter the tissue. Having entered the tissue, again, these same receptors, pattern recognition receptors, now pick up the pathogen-associated molecular patterns. And the next step that occurs is that this leukocyte, this neutrophil, engulfs this bacteria and digests this bacteria and gets rid of this bacteria. So this is the first line of defense after the physical, chemical, and microbial defense has been breached. This is the first line of defense which can be described as the phagocytic defense, which is mainly consisting of neutrophils and macrophages. In case the microbe is fortunate enough to escape this phagocytic defense, the next defense that the body has is the complement system. And here we have the alternate complement pathway and the lectin pathway. Lectin is a pattern recognition receptor. The pattern in the pathogen is the pathogen-associated molecular pattern is mannose, which is found in almost all bacteria. This lectin binds to this PAMP and stimulates the alternate complement, the lectin pathway, and in a similar way, the alternate complement pathway. These two, when they are stimulated, they lead to the activation of the enzyme C3 convertase, by which C3 is converted to C3A and C3B. C3B is an opsonin. This opsonin coats the microbe and it becomes easy for the macrophage and the neutrophil to phagocytose this organism now. So in case the microbe has escaped phagocytosis in the first step, it is phagocytosed better under the influence of the opsonin. In case this is not done, what happens? This goes further. We have what is known as the membrane attack complex, C5, C6, C7, C8, C9. This membrane attack complex, as the term indicates, attacks the microbe and gets rid of the microbe totally. So the complement alternate and the lectin complement pathway help in opsonization as well as in membrane attack complex formation. Thereby the bacteria is taken care of. This is as far as extracellular microbes are concerned. What happens if a microbe enters the cell before it can be gotten rid of by the macrophage, the neutrophil, or by the complement system? So we come to what is the fate of these microbes, which are intracellular microbes. The classic example being viruses. When you have the intracellular microbes, NK cell has a specific toll-like receptor which picks up the pattern on viruses which are found intracellularly. The NK cell, as soon as it finds a receptor intracellularly on any other cell of the body which has been infected by viruses, these natural killer cells, as the term indicates, they are natural killer. They immediately get rid of these cells which are infected by viruses. And as far as intracellular bacteria are concerned, as far as intracellular bacteria, I told you that the macrophages have phagocytosed the microbe. They are unable to kill it. If they are unable to kill it, they secrete a substance which is known as interleukin 12. Interleukin 12 now conveys a message to the natural killer cells that I am infected, I am unable to get rid of the microbe. And this NK cell, in response to this interleukin 12, secretes interferon gamma. Interferon gamma boosts the immunity of macrophages, and the macrophages are now able to kill the microbes which have escaped the initial phagocytosis. So this is how intracellular microbes have been taken care of by this system. So the first step is phagocytosis, where you have macrophages, you have neutrophils, you have the complement system, and you have the natural killer cells. These four together constitute what is known as innate immunity. Innate immunity is something which you are born with. It is non-specific. It does not depend on any antigens which are present on any specific bacteria or viruses. It is a non-specific response to all the bacteria and the viruses. Since it is only directed against foreign antigens, it is never directed against self-antigen. And hence innate immunity, unlike adaptive immunity, has never been implicated in autoimmunity. But being non-specific, it creates a lot of non-specific inflammation, and hence this has been implicated in a group of conditions known as autoinflammatory diseases. An example of an autoinflammatory disease is a periodic fever syndrome, or what we more commonly see is systemic onset juvenile idiopathic arthritis. In case the innate immunity has been inadequate to get rid of these microbes, the adaptive immunity takes over. And in adaptive immunity, you have the two systems, the B cell system and the T cell system. The B cell system, the bacteria are recognized, the antigens on the bacteria. They are not the non-specific pathogen-associated molecular patterns on bacteria. A specific antigen for a specific microbe stimulates a specific antigen receptor on this B cell. So our B cells have a huge repertoire of receptors which can identify practically every antigen which is present on Earth. So this identifies this antigen which is present on this bacteria, and having identified this antigen, this B cell now stimulates the production of, gets converted to plasma cells which lead to production of antibodies, immunoglobulins. Now these immunoglobulins, what do? They coat the microbes. Having coated the microbes, they act as opsonins. Having opsonized the bacteria, now the macrophages can kill them. Secondly, these antigens, they form immune complexes with these antibodies, and these immune complexes are taken up by the classical complement pathway, ultimately leading to the membrane attack complex, and the microbe is gotten rid of. This is how the B cells take part in adaptive immunity. When it comes to T cell, we have the CD4 cell and the CD8 cell. Now CD4 cell is a very haughty cell. It is not like the B cell which can get easily stimulated by any antigen directly. The CD4 cell needs to be presented with an antigen. So this is where innate immunity and adaptive immunity come together. Here you have a macrophage or a dendritic cell which has ingested the microbe in innate immunity but hasn't been able to get rid of the microbe. So what does it do? It has not been able to get rid of the microbe, but what it does, it presents some of these antigens in conjunction with MHC type 2 receptors. All dendritic cells in our body have MH2 class 2 receptors. Antigen, when it is picked up by these MH2 class 2 receptors, can now stimulate the CD4 cells. And what does the CD4 cell do? Having been, you can see here that this is the CD4 cell, this is the receptor, which can identify the MH2 cell, MH2 receptor in conjunction with the antigen. Having identified this CD4 cell now stimulates the B cell. So the first type of antigen that I described in the previous slide was a B cell stimulation, which was not dependent on T cell. But these antigens are dependent on T cells. So these are known as T cell dependent antigens, which lead to stimulation of B cells. So B cells can be stimulated directly by T cell independent antigens. They can be stimulated indirectly by the T cell dependent antigens. And if you understand this, you will realize that when we classify immunodeficiency, you have B cell immunodeficiency. You have never isolated T cell immunodeficiency. You have B cell immunodeficiency and combined immunodeficiency. Why combined? Because whenever the T cell is immunodeficient, and whenever there is T cell immunodeficiency, there is always associated B cell immunodeficiency. If you have understood this pathway, you will understand why. So this is the reason why you always have combined immunodeficiency, never isolated T cell immunodeficiency. Now this CD4 helper cells, as I told you, stimulates the B cells to produce plasma cells which will produce antibodies. In addition, like the NK cells, it also leads to release of interferon gamma. Interferon gamma helps the macrophage activation and killing of cells. So again, it promotes phagocytosis. This is how CD4 cell helps in killing of extracellular microbes. When it comes to intracellular microbes, we have the CD8 cells taking over. Now, every cell in our body has MHC class 1 receptor. Every cell in our body. Unlike MHC class 2, which is present only on dendritic cells, MHC type 1 is present in every cell of the body. So any cell of the body gets infected by a microbe or a virus, this cell then presents that intracellular organism in conjunction with MHC type 1. And when an antigen is presented in conjunction with MHC type 1, the CD8 cell gets stimulated. When the CD8 cell gets stimulated, it leads to the activation of CD8 cells and the production of what is known as cytolytic T cell. This cytolytic T cell leads to killing of the microbe either directly or indirectly by release of perforins and granzymes. So cytolytic T cells kill the microbes directly. The CD4 cells kills the microbe indirectly. So to briefly revise, we have three types of cells. There are basically three groups of cells. One is the phagocytic cells. In innate immunity, you have the phagocytic cells, which engulfs and destroys microbes. You have the complement system, which again destroys microbes either through the activation of the alternate complement pathway or through the activation of the classical complement pathway by opsonization or by formation of the membrane attack complex. Or you have the natural killer cells, which are excellent cells, excellent murderers of viruses. When it comes to adaptive immunity, you have the B cells. B cells get rid of extracellular bacteria, while T cells predominantly get rid of intracellular viruses and bacteria. They also help the B cells in getting rid of extracellular bacteria. So basically you have innate immunity, which consists of phagocytic cells, complement cells and NK cells, and you have the adaptive immunity, which contains of T cells and B cells. And if you have understood this, very easy to understand what are the various infections which are seen in these various immunodeficiencies. If you have phagocytic disorder, as soon as I said, as soon as the organisms enters the body, it breaches the skin, the phagocytic cells takes over. And here, if the organism is not controlled, you have an infection which further worsens. So you have more skin abscesses, lymphadenitis, and pneumonia. Then you have a condition known as leukocyte adhesion deficiency, which is because the neutrophils are unable to adhere to the endothelial cells. And another thing, another example of a disorder is the chronic granulomatous disease, where these phagocytes having phagocytose the microbe are unable to digest the microbe. So you have chronic granulomatous disease. See, these are the three diseases of the phagocytic system. When it comes to the complement system, if there is a defect in the complement system, and if there is a defect in the early stages of complement C1, C2, C3, C4, you have early onset lupus. We will not go into the detail of this, but when you have defects in the terminal complement components, you have the Neisseria infections. When it comes to NK cells, especially you have an increased incidence of infections. As a matter of fact, there is a specific NK cell type disorder which leads to recurrent herpes simplex encephalitis, because NK cells are specifically responsible for the killing of viruses. If you have disease of B cells, and I told you the B cells are especially important for killing extracellular bacteria, and the B cells which work without T cell help in killing the T cell independent antigens. And the T cell independent antigens are those bacteria which have capsules, the pneumococcus, the meningococcus, the H flu. These are the ones which have capsules on them. So in the absence of B cell, you have specifically infection with these organisms, which mainly cause respiratory tract infection. While if you have a deficiency of T cells, obviously you are going to have all intracellular infections, the viral infections, the fungal infections. And because T cells also help in B cell function, you also have infections with various bacteria. Now some examples to illustrate what I have just told you. And these are all real life examples taken from my archives. This baby was a 10-day-old female child who was brought to me on day 10 with severe omphalitis. When I went into the family history, I realized that their elder sib had died at the age of 1 year. Just before death, they had done a CBC, and the CBC was 1 lakh per cubic millimeter, and the polymorphs were 80%. Before a bone marrow could be done, they were said that probably this child has leukemia because the total count was 1 lakh. Though the differential count was 80% polys, which is unlikely in leukemia, they were said that probably this child had leukemia. When I saw this, I realized that this was a condition when you have significant neutrophilia. This is seen in the condition known as leukocyte adhesion defect. As the term indicates, in this there are absence of some adhesion molecules on neutrophils, because of which the neutrophils cannot adhere to the endothelium. They go to the site of inflammation, but they cannot adhere to the endothelium. Because they cannot adhere to the endothelium, they are unable to phagocytose the microorganism. Because they are produced in large numbers in response to the infection, they have significant neutrophilia. At all times, these children will have a neutrophilia. The total count will be about 20 to 30,000. And when there is infection, they have total count in the range of 80 to 90,000 with predominantly polymorphonuclear leukocytosis. Now, these adhesion molecules are nothing but CD18 cells. So, simple way of diagnosing this condition is to send the CBC for flow cytometry. And if you find diminished CD18 cells, you have clinched the diagnosis of leukocyte adhesion deficiency. They often manifest, and this is an excellent clue to pick up this disorder, delayed cord separation. If any of you has ever wondered, how is it that nature makes sure that between 7 and 14 days, the cord falls off? The cord falls off because of infection. At the base of the cord, there are a number of bacteria which colonize the base of the cord. Having colonized, the neutrophils enter there, and these then lead to lysis, and subsequently the cord falls off. In the absence of neutrophils migrating to the base of the cord, there is delayed cord separation. This is an excellent clue that is often seen in these children, and hence they often present as omphalitis. And even with minor wounds, the wound healing is significantly delayed. With another excellent clue, though the wound healing is significantly delayed, you will find these children with grotesque ulcers, but total absence of pus, because pus is nothing but neutrophils, and neutrophils cannot migrate into these ulcers. So absence of pus with grotesque ulcers and delayed cord separation suggests a diagnosis of LED deficiency, which further, the suspicion is further enhanced because of significant leukocytosis with polymorphonuclear leukocytosis. This 12-year-old boy has had recurrent lower respiratory tract infection since early childhood. 1 year before he came to me, he had 3 episodes of pneumonia. Each time he had received anti-tubercular therapy under the treatment of a pulmonologist. The first 2 times he had received regular anti-tubercular therapy. The third time he had received multi-drug resistant therapy. All 3 times the pulmonologist had investigated him very well. He had resistant pneumonia, resistant to other antibiotics. Thrice rather, he has had a gastric aspirate for AFB, sputum for AFB. Twice he had bronchoscopy, but no AFB could be demonstrated. But all 3 times he responded to anti-tuberculous therapy. This heightened my suspicion. No doubt he had responded to anti-tubercular therapy, but how is it despite such intensive investigations, not even once they could find an AFB? So I wondered whether in reality he had staphylococcal infection all 3 times, and the rifampicin of AKT had led to resolution of pneumonia. So I got some tests done, and the first test that I did was to rule out B-cell immunodeficiency, because B-cell immunodeficiency, as I've already told you, presents with recurrent pneumonia. And if you see here, B-cell, the marker for B-cell is CD19. CD19 was absolutely normal. I got an immunoglobulin level done. All the immunoglobulins were normal. Immunoglobulin G, A, M, E, all were absolutely normal. So I was not dealing with B-cell immunodeficiency. Recurrent pneumonia, probably staphylococcal, not B-cell immunodeficiency. The next suspicion is chronic granulomatous disease. So a simple test for this is nitroblue tetrazolium and dihydrorhodamine test. These tests were done, and as you can see here, both these counts were 0%, confirming a diagnosis of chronic granulomatous disease. Imagine this child had a severe immunodeficiency, but he was diagnosed for the first time at the age of 12 years. Another important point that I want to emphasize, do not think that all children with primary immunodeficiency, if undiagnosed, will die early in life. They can be diagnosed even later in life. They present with recurrent bacterial and fungal infection. Staphylococcus aureus and aspergillus are the 2 most common infections. Because these infections cannot be, these macrophages, the neutrophils phagocytose these organisms, but they are unable to kill them, it leads to a granuloma formation. So if you have granuloma, but the patient AFB is negative, to suspect chronic granulomatous disease. And the problem here is that the neutrophils, once they have ingested the macrophages, they get rid of the macrophages by the production of what is known as reactive oxygen species. These children who have chronic granulomatous disease have a defect in the NADPH system by which reactive oxygen species are not produced, and hence they are susceptible to infection by a group of organisms known as catalase positive organisms. The inheritance can be both X-linked recessive, which is a more severe variant, and autosomal recessive, which is a less severe variant. My patient had an autosomal recessive variant, and hence he lived up to this age, and he's still alive, and he's doing well with some prophylactic antibiotics and antifungals. This was a 7-month-old child born to third-degree consanguineous parents. He was born 2.6 kg. Yes.
Sorry to interrupt, sir. We have already completed 20 minutes.
Okay, just 2 more minutes.
Yeah.
So this patient presented with severe failure to thrive, chronic diarrhea. He had persistently draining BCG sinuses, and there are small nodules on the skin. When we did fine needle aspiration cytology of these nodules, we found AFB. So in reality, this patient had disseminated BCG. We got the test done. CD3 was 0, CD19 was 0. Immunoglobulin levels were very low, suggesting a diagnosis of severe combined immunodeficiency. This was another patient who presented with recurrent pneumonia, 7-year-old boy. 7-year-old boy, recurrent pneumonia, we suspect A gamma globulinemia. We did a immunoglobulin level, which was all of them were very low. We did a CD3, CD8, 19 count, which was 0. So a diagnosis was Bruton's A gamma globulinemia was made. So to summarize, when you suspect PID, first suspect PID if you have unusual infections, recurrent infections, severe infections. Having suspected, even if you're not an immunologist, just like me, I am also not an immunologist, 4 or 5 simple tests, and you will most likely, more likely than not, you will be able to arrive at a diagnosis. Look at the absolute neutrophil count. If it is less than 1500, suspect congenital neutropenia. Look at the absolute lymphocyte count. Count ALC of less than 2500, suspect T-cell immunodeficiency. Third step is nitroblue tetrazolium and DHR. If it is absent or very low, suspect chronic granulomatous disease. Do a immunoglobulin level. If it is very low, suspect B-cell immunodeficiency. Do a lymphocyte subset analysis. If CD3, CD4, CD8 is low, you suspect T-cell immunodeficiency. CD19 is low, you suspect B-cell. All are low, you suspect combined immunodeficiency. Sorry for exceeding the time by a couple of minutes. Thank you very much for a patient hearing. If there are any questions, if time permits, you can ask me now, or you can WhatsApp the questions. I'll be glad to answer. Thank you very much.
Dr. D.S. Babu, sir, kindly unmute yourself.
Thank you very much, Dr. Grace, for a transparent lecture on this difficult subject. A few important points just I would like to add. A leukocyte adhesion defect. Normally also the delayed separation of the card is there in nearly 10% of the population. But if you have a delayed separation more than 3 to 4 weeks plus umbilitis, you are thinking more towards the leukocyte adhesion defect, because normally also delayed card separation is there. That is one. About the chronic granulomatous disease, another name is given, very simple name to understand, is a impotent neutrophil syndrome. That is another name given for this. Another differential diagnosis, nearest differential diagnosis for chronic granulomatous disease is a Crohn's disease, where you can have a multiple abscess, perineal abscesses, and not only perineal, but gastric outlet obstruction. Both is common in both, that is granulomatous disease and in case of Crohn's disease. Sometimes it becomes very difficult to differentiate, but if you study the granuloma, you can differentiate it along with the test which the speaker has already said. Nowadays they go for this nitroblue tetrazolium test was used up to 1990. Nowadays that is also used, but along with the flow cytometry. Another important, very, very important thing for SCID is, and he has already said SCID and presented SCID and a sex-linked A gamma globulinemia. The most important thing is SCID presents earlier before 6 months, and the gamma globulinemia presents after 6 months. And the interesting finding when you look at the baby is there is an absence of tonsils and lymph node in both the cases. But by history, The SCID presents earlier. The most important thing about SCID is in few countries or few places they have got the neonatal screening test. If you do it neonatal screening test and if you go for the transplant before 3 months, survival is best otherwise. So these cases, these children having a SCID may die with the severe infection or they may die with the vaccination. So the vaccination part about the MMR, varicella, the BCG should be avoided in those children. A simple test, you can go for the TLC, total leukocyte count. And if you get a lymphocyte count less, absolute lymphocyte count less than 1,000, do not vaccinate. You must suspect, and in presence of absence of the tonsils, absence of the lymph node, you suspect it could be a SCID, and you go for the investigation further. But do not give vaccination if the lymphocyte count, absolute lymphocyte count is less than 1,000. So there are some warning signs. What we say, there are some warning signs when you think about the he has already mentioned warning signs, but when the warning signs in an individual are more than 2 or more, like number 1, if you get the ear infection, new ear infection more than 4 in a year, if you get a sinusitis, severe sinusitis more than 2 in a year, if you get pneumonia more than 2 in a year, if you get oral thrush and a fungal infection of the skin, which is not getting treated earlier. Number 4, the antibiotic course may require more than 2 months. Still there is no healing, and they require always intravenous antibiotics. Another, if you get a multiple abscess of the subcutaneous as well as the abscess in the deep-seated abscess, like abscess in the liver, abscess in the spleen, and if you get a family history. So these are the warning signs. And another most important thing is the child has a diarrhea and does not gain weight properly. So these are the nearly 10 warning signs. And if any child has more than 2, you must suspect and you must exclude by investigating this. But always one has to keep in mind that the vaccination should be delayed or postponed until unless you exclude the condition. Otherwise, you may kill the child with the vaccination program. About BCG, there are 2 conditions where BCG should not be given or avoided, like a SCID, and another is a macrophage dysfunction syndrome. So that is about short practical points when you deal with the any, and so this, when you do not have a neonatal program, a simple TLC or simple CBC can tell you many important things about the immunodeficiency. Thank you very much, Dr. Girish, for a transparent lecture.
Thank you, sir. Thank you very much. I must confess that Dr. Raut has been a role model for me when it comes to learning and comes to humility. I think Dr. Raut is my role model.
Yeah.
Thank you very much, sir.
Thank you, Raut, sir. Thank you, Dr. Praveen Page, for sharing the session. And thank you, Dr. Girish Subramaniam, for a very informative talk. So moving ahead, this most awaited and innovative session is ahead. That is PET Talk. That is idea of our president. From a renowned leading psychiatrist from Mumbai, Dr. Harish Shetty, Your Mind Matters. For this session, I invite Dr. Praveen Mishra and Dr. Amit Nemade, pediatric orthosurgeon from Nagpur, to chair the session. Over to you, Amit.
Thank you, madam.
Hello.
Yeah.
Hello. Good afternoon, everybody. Myself, Dr. Praveen Mishra, and my colleague, Dr. Amit Nemade, take this opportunity to welcome Dr. Harish Shetty, who is a practicing psychiatrist from Mumbai. He is a renowned national and international faculty in the field of psychiatry. Dr. Harish did his MD psychiatry from KE Mumbai and postgraduate diploma in comparative mythology from Mumbai University. His field of interest are depression, suicidal behavior, de-addiction, anger management, and how to manage violent patient, which is the need of the hour. So I welcome Dr. Harish, and the floor is yours now, sir.
I'm honored to be here, and thank you, Shubhada, for inviting me. Thank you, NAPCON organizers, for inviting me. And honestly, I've been listening to a few lectures, world class, absolutely mind blowing. The last one and the rejoinder for that also, I think, was a learning for me. You guys are very lucky because you're pediatricians. I'll tell you why. You guys are lucky because you work with children. And as somebody said, the simplest minds are the most profound, educated minds are not. And when you deal with the simplest minds, the joy is double. The joy of getting the child back on his feet, but the joy also of the child smiling at you innocently as and when he's better, crying at you innocently as and when he's in pain. I think that's the free stress buster, or something which improves your state of being is very, very important. As I look at you guys, pediatricians, I see 2 or 3 things which I have learned. One is that working with children, you're also childlike, not childish, childlike. See the glowing face of Shubhada and Meena now. Absolutely glowing. I mean, how can you miss this? So naturally, though there are tense moments, stressful moments, you have a continuous ability to be childlike. Chota bacha jaisa innocence jo hai, it is there inside you. In spite of all this, I also learned something more from you guys. You guys also do not lose hope. You try your best. Your equipments, your methods, your medications, going back to immunology. And I've seen pediatricians, when the child goes home after a difficult ordeal, the joy in the eyes of the pediatrician is much more than the joy in the eyes of the psychiatrist. And that, I think, is extremely, extremely gratifying. So you guys stimulate me in different ways. Going back to the state of affairs as of now, what do pediatricians, what do psychiatrists, what do physicians, what do ICU guys need to learn during COVID times? Number one is that after visiting a funeral, most of us go into an existential mode. What is this all about? What is the purpose of life? What is money all about? Why this? But again, on the next day, how many patients did I see? How many hospitals did I visit? How many names I have on different papers, which is also very important, continues. But COVID has moved the existential signboard a little higher up in our mind screen. And so as we continuously live in the existential mode that anything can happen to us, we can get infected, we are slowly realizing that small things in life don't matter. What is extremely important in life is how we deal with ourselves, and what is extremely important in life is how do we deal with others. Is there a balance within and is there a balance without? And some of the new researchers which has really impressed me is the research on gratitude. If one pediatrician has treated your patient because he has left you, the child has left you, or the baby has left you and gone to somebody else, and you hear about it a little later, what is it that you should do to remain healthy, to remain positive, and to remain childlike? And the best thing to do is to pick up the phone and say, I'm so grateful that the child has improved. Why not? Without me. But you did your best. And what is it that you really learned from that child? And this does not only change the doctor who receives this gratitude, but it also changes the doctor who shares the same gratitude. And that is one of the most important research points as of now. Gratitude brings down toxic emotions inside your body. Gratitude calms down your toxic emotions and you will remain much more healthier. And but is it so easy? It's not so easy at all. It's not so easy at all because there are a lot of questions which come from mind before we express our gratitude. Number one, I mean, how is it? It's anxiety provoking. I have been practicing for 28 years. This young boy is practicing for 12 years. How should I share this with him? Is it right? The second most important question is social anxiety about sharing gratitude. Will I be able to do it in a way? I have never done that in the past, or I have done that very superficially at times in conferences and in meetings. And number three, what is very important is, will the other person believe that I'm trying to seek some benefits for the same? But what is very important to also learn is gratitude improves mental health. Those who talk about positive feelings and those who talk about we rather than I have better mental health and better positivity. The third thing which is very important is gratitude also changes the brain, and that I think is extremely important. Now, can I give you an example here? If I say that probably you had to leave the hospital at some point of time because of different reasons, and you had to give the hospital to your junior, and when you come back after some time, after a week, suddenly the patient whom you knew for the last 25 years suddenly says that, sir, in the next follow-up, I would like to meet your junior. What is it that he did so different than what you did? You start thinking, but at that point of time, you say, my God, it's beautiful. You tell me what we do, because now the world is not hierarchical, the world is flat. And a younger consultant sometimes may be able to teach an older consultant, in spite of the fact that the older consultant may have had gold medals and may have had more papers than the younger consultant. And that is so important for the mental health of all doctors, including pediatricians. At times, most of the male doctors, not the female doctors, are not aware of the emotions. Women generally say, "Are काय ग मला त्रास झाला ते patient बघून." I did not understand what was happening to the patient. काय ग मला एवढं संताप आलं. Men generally are very stoic. परंपरा, प्रतिष्ठा और अनुशासन मेरे pediatrics practice का तीन स्तंभ है. And if a doctor feels like crying when a patient dies, and the doctor says, I don't know why. And I still remember that doctor who said, Dr. Shetty, we as pediatricians, we have to numb ourselves when there's a death in the NICU. We can't be wearing our emotions on our sleeve. And I said, no. I said, don't wear your emotions on your sleeve, but be aware of those emotions. He said, no, you would not be able to treat the other patient. I said, there's no need to cry or no need to feel like crying and express your emotions at that point of time. But in the evening, if you work in pair, sit down and say, Mala, dukha zala, I really did not know. And I felt like crying. And doctors, male doctors, if they say that, much more than the female doctors, honestly, I'm saying your mental health will be top class, because ultimately sadness is a positive emotion. Depression is a negative state. So debriefing across at the end of the day is so important to understand feelings and to really improve our mental health. As we do that, it so happens at times that we have done 20 years of your practice and 30 years of practice and 40 years of practice. And at that point of time, you start wondering, ye kashala, konala, kiti divas. And as you run around different hospitals, run around your patients, as you live above the hospital, in a house, in a flat, in a floor, and the hospital is beneath, you're available to the patients all the time. But self-care is so important. The patients will find another doctor if you leave this earth, but your family will not get another mother and the father. I think that is so important for you to understand. And when to say no. I got 3 calls in the morning, urgent. I said, sorry, ma'am, sorry, sir. I will not be able to meet you or even talk to you. Monday is the time. And if it's very urgent, if there's a suicidal patient or a homicidal patient, these are the numbers you can call. Me nahi tu. And that, I think, is extremely important for our health. Now, I would request all pediatricians here in this NAPCON, to put names of 4 other pediatricians on your letter pad. I did that 25 years ago. Avti bhavti je practice te karta, त्याला सांगून, after informing them. I have written that if you're not happy with me or for any other reason, if you want to see somebody else, these are the 4 names, these are the 4 numbers, please go and meet them. My God, once one psychiatrist told me, Harish, मैं तेरा assistant नहीं हूँ, मेरा नाम डाला. I said, assistant नहीं, तू मेरा boss है यार. If he's unhappy with me, he's safe with you. I have faith in you, which is why I put your name and your number. And your mental health will improve, my dear men and women, my dear friends, brothers and sisters. Do that and you see insecurity dies. And you become secure. And all those 5 doctors, one, the prescription paper, the 4 doctors will have more practice because everybody will say, these guys are together. And they will help each other when it comes to my child. So important. And that brings down insecurity and improves health. My dear friends, sometimes we are faced with violence. And it's not because we did not do our job. It's not because we did not communicate to them about what is happening. We communicated them step by step and we informed them step by step, but still there is violence. And then what happens? What is so important is to rush to the doctor's hospital at the earliest and see to it that you're available to him. No, even if he's not invited you for his opening because you are perceived as a competitor, still hold each other's hands and be a sakli, be connected so that it's not your health, but other health also improves. In the COVID times, when I conduct sessions with our doctors, many doctors across time on the Zoom or even live, many people ask, many hospital owners ask me, what is the most important stimulus? What are the 3 most important stimulus to see that doctors remain inspired during tough times? I said there's only 3. Number 1, is it salary? I said no. Number 1, genuine appreciation. And what is the number 2? Genuine appreciation. And what is number 3? Genuine appreciation. People don't work for money all the time. People work because they feel wanted, they feel touched, they feel respected, and they feel that their work is valued. This really helps. Lastly, my dear friends, because I've been given only 15 minutes, we have found across research in our practice that saying hi to a patient when he enters is important, but saying bye to a patient is as important as saying the hi. Other day, I was talking to Corona warriors. Be there when the patient leaves the hospital. If you are an intensivist, be there as much as you can. Among the team, 1% be there as the patient leaves the hospital. And not that. Even when the body bag leaves the hospital with close relatives, be there. And if you can, one of the persons in the team can leave the body bag in the ambulance or leave the patient who is recovered in the car or in the ambulance or in the auto and saying a proper bye, not only helps the patient, but improves your mental health, improves our state of being. My dear friends, all the pediatricians who are glowing, from Girish Subramaniam, who made a fantastic presentation, and before that, aneurysms, and even Dr. Page, who gave a point-to-point practical tips. He had come prepared. See the glow on their faces, see the humility, see the gratitude. And let me tell you, these things change your face value. How you feel defines how you look. It's not the light on the face of Meena or Shubhada which makes them glow. It is the internal light inside their body, inside their being, which makes them glow. So my dear friends, keep your light glowing. That's the only request I have. In COVID times, let us preserve our 1200 grams of brain. Let us preserve our goals and let us preserve our dream. Pediatricians are one community who are childlike, who have a lot of innocence inside them, who have a lot of compassion inside them. Compassion, each one of us is compassionate, but few discover it in a lifetime. And you guys have it all the time because you play with your children when they get admitted. You play with them as they go. You talk to them about small things. And most of your children who have been under your care grow up. And even after the age of 18, they say, you treat us. We don't want to go to a physician. Very few people remember physicians, but all patients remember pediatricians. Thank you for inviting me to this beautiful seminar. Thank you, NAPCON, for making my day. I am indeed grateful and I'm indeed honored to be in the august audience of some of the best pediatricians on the earth. Thank you.
Thank you so much, sir. Excellent pet talk. And I cannot thank you enough for being with us today. Despite your such a busy Sunday schedule, you have enlightened us so much. Thank you so much, sir. Yes, Meena, you can
Yes.
continue.
Yeah. We are proceeding to next session. I hand over mic to Dr. Mustafa Ali and Dr. Bhagyalakshmi Rajan for next group of sessions. We're
Good
already
afternoon.
running very late.
Good afternoon, everybody.
Yeah.
Our next session is on tool in pediatrics, and our next speaker is Dr. Shyam Kumar Kashawa. He is a professor and head Department of Intervention Radiology, Christian Medical College, Vellore, and his area of interest is intervention radiology. He has over 210 publications, and he's the editor journal of Clinical Intervention Radiology. So, Dr. Shyam Kumar sir will talk on interventional radiology in vascular anomalies. Thank you.
Good afternoon. Interventional radiology in vascular anomalies. Vascular anomalies are very common, and these can affect different parts of the body. Vascular anomalies are known to medical field for the last 2 centuries. The best classification is ISWA classification, that is International Society for the Study of Vascular Anomalies. On the left side of the table, we see all tumors, whereas on the right side, vascular malformations. Vascular malformations are congenital. These are abnormally formed blood vessels. In the diagnostic workup, we need to know detailed clinical problem. For example, this particular child has got a swelling on the backside of the chest. When I asked him when this lesion becomes large, he bends forwards like this and shows it is enlarged, which indicates that this is a gravity-dependent problem, like venous malformation. What we see from outside is tip of the iceberg. We need to do imaging to know what is the deeper extent. Is it close to some vital structures? Is it closer to airway? Then we plan the intervention and follow. Among the imaging, the most important imaging are ultrasound and MRI. Let us see a few case examples. This is a 7-month-old baby. Mother noticed that there is a swelling in the lateral aspect of the face 10 days after birth. On imaging, we can see that it's very well defined, predominantly solid. And on ultrasound, it's echogenic, and you can see there is a large vessel within the lesion. So when we see something predominantly solid, well defined, these are representative of hemangiomas. Hemangiomas require a proper detection. They don't require much active intervention unless there is some problem. For example, this child, swelling was the only problem. We just followed up, and you can see that over a period of time, the swelling is reduced, no biopsy done, no surgery done, no sclerotherapy. And recently, when we asked the parent to send the photograph, you can see that this swelling has totally disappeared from the patient. Let us move on to some other kind of examples. This is a 6-month-old baby who had problems at various stages, something like noisy breathing, patient required hospitalization, and one CT identified a supraglottic mass. Chest radiograph was unremarkable. Patient was sent for ultrasound neck. That time we saw vaguely a lesion on the right side, posterior to the thyroid. We suspected a veno-lymphatic malformation. The gold standard of investigation is MRI, which shows the exact location and extent of this lesion. You can see these extensions are like amoebic pseudopodia. And within that, we'll see some areas of dark signal, which are representative of phlebolytes. When we give contrast to veno-lymphatic malformation, the venous spaces, they enhance because they contain blood. Venous malformation, they are the commonest types of venous vascular malformation. And these are located beyond the capillary bed. These are abnormally formed venules. There is no angiogram required to diagnose a venous malformation. Diagnosis is done on MRI and ultrasound. This patient required multidisciplinary approach. We did extensive counseling. Before we did sclerotherapy, patient was anesthetized, a scopy was done on table, and this is the appearance of the bulge. Following that, we have punctured this venous space under ultrasound guidance, and we have injected a sclerosant. Our choice of sclerosant is sodium tetrahedral sulfate. Following injection, there will be an intense thrombophlebitis, which is different from patient to patient, during which there can be increase in the swelling transiently. And this increase in the swelling can remain for few days, maybe up to 10 days. During this time, we have to really take care of the patient, especially a patient like this, which is close to airway. We followed up to 2 weeks and then discharged from the hospital. Patient came for follow-up after 2 months, and patient is really asymptomatic. Venous malformation can affect different parts of the body. For example, here orbit is involved. Next to the globe, we injected sclerosant under anesthesia. This is the contained space of venous malformation. After we injected, there was a rapid increase in the swelling. It increased to an extent that there was increased intraocular pressure. This is really dangerous. This can stop the blood flow to retina and can cause irreversible vision loss. So in such situation, we have to reduce the pressure inside the orbit by doing a smaller procedure called lateral campectomy. And this patient is doing very well. And you can see during follow-up, the swelling has significantly come down. There's another child who has got large swelling in the anterior part of the chest. Compared to the previous patient, here you can see multiple pockets, and we gave contrast to this patient, and there was no enhancement within this space. This is how it appeared on ultrasound. There is no flow detectable. This is an example of lymphatic malformation. When the cysts are large like this, we call it as macrocystic lymphatic malformation. We drain the lymphatic fluid. This is how it appears. And then we have done sclerotherapy. This child showed very good response during follow-up. Let us move on to some other type of example. This child is having an enlarged tongue. He had undergone surgical treatment. His tongue was partly removed. This is a residual swelling, and he is not able to close his mouth properly. And to hide it, he was wearing a scarf around his face, and this is how he was seen. On ultrasound Doppler, we can see there is a lot of turbulence within this. And on MRI, we can see no signal area, what we call as flow void. This indicates it's a large, fast-flowing blood vessel. This is a typical appearance of an arteriovenous malformation. Arteriovenous malformation requires treatment based on how symptomatic it is clinically. This particular patient required treatment, and we have done transarterially, and we have done angiogram. We have identified the nidus, which is close to mandible, and there is a large venous sac. We injected liquid embolic agent. Here we have taken hystoacryl and lipiodol, and this is soon after injection, and we can see the shunting has significantly come down. You can see that chronic opening of the mouth has made a secondary deformity of the maxilla and mandible. Let me show you some association. This baby who has got multiple vascular malformation, discoloration on the face. Patient has undergone a sternotomy for a cardiac problem. There are lesions in the tongue also. This is the sternotomy defect. There are lesions in the brain. There is an infarct and narrowing of multiple arteries. This is a spotter. This is called Facey syndrome, which has got so many components. Another case example, child is complaining of swelling in the neck. Right now, we do not see any swelling as such. But when we ask the child to demonstrate, he did something like a Valsalva. There is large swelling. So this is almost looking like a venous malformation. But when we did ultrasound, there was no mass. There is no lesion. But when we asked him to do Valsalva maneuver like this, there is gross distension of internal jugular vein. So this is a case of jugular venous ectasia. We just counseled, we have not done any active treatment, and no active treatment is required. This is another child who was sent for interventional radiology management. Some of you can diagnose it may be a spotter for you. You can see skin lesions here. This is an MRI of the same patient. The left eye globe was inoculated, soft tissue in the orbit. This is a case of neurofibromatosis. Neurofibromatosis is a mimic of vascular anomaly. So we have to identify which are the vascular malformations, what type it is, and what treatment is required. And we also should know which one just requires a proper diagnosis, counseling, and follow-up. Imaging plays a major role in detecting what type it is and what is the extension of the lesion. I would strongly advise, whether it's a sclerotherapy or surgery, before we embark on the treatment, we need to know the full extent and what exactly it is. Intervention is required only in select cases. Thank you for your attention. I'll be happy to address any questions. I thank Dr. Srikant Kotekar for giving this opportunity to share some of the experience with you all. Thank you.
Thank you, sir. Sir, you want to say something? To the next session, that is all about pulse oximeter. I hand over the mic to Dr. Shubda Khirwadkar. Thank you.
Thank you, Dr. Mustafa. And I am really honored and privileged to introduce my mentor, my teacher, and one of the most inspiring person who has the best brilliant mind I have ever seen. Not only that, he is a person who has the knack of attaching to the latest technology wherever it is. And we learn so many things from him, despite being supposed to more attached to the technology. So, sir, a very techno-savvy person, a person who has such a clarity of thought, which is always revealed in all the deliberations and discussions he makes for us. Thank you, sir, for being with us. Over to you, sir, for your talk on all about pulse oximeter, a rage these days. Sir, please unmute yourself.
हूँ मैं
वीडियो स्टार्ट करना है?
हाँ 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 ठीक
वीडियो स्टार्ट करना है?
हाँ अभी एक बाकी है बीच में ठीक है
अनम्यूट योरसेल्फ
नहीं सध्याशी नाही करायचं
इकडे बंद करा काय आलंय हे बघा
I hope you can see my slides.
Yes, sir.
Shubda, thank you very much for those good and inspiring words for me. But I have been an admirer of your team this year. They've done a wonderful job.
Thank you.
Please excuse me, I was not there at some points, but my heart was always there. I mean, I was observing what was going on. It's been a wonderful IP year with all of you, with Mustafa and the entire team. So we're talking about the fifth vital sign, and that is pulse oximetry. I'm also going to cover in the 20 minutes that is given to me something about COVID and how it's getting used. So the fifth vital sign is extremely important. It's like almost a thing which is there in every home today. So with pulse oximetry getting inside your house, I call this as an ICU residential expansion. ICU has gone into your house through the pulse oximeter. This wonderful Japanese Tokayu Oyogi invented pulse oximetry. Depends on Beer-Lambert physiology law. The history of oximetry is related to Second World War because the pilots were getting hypoxic and about 20% aviation accidents were because of this hypoxemia. So that's where as is true of most of the important discoveries, pulse oximeter was also discovered during the Second World War. And we talk of pulse oximetry, it's about alveolo-arterial gradient. This highly complex term means how easily oxygen can go from the alveoli to the pulmonary capillaries. And this is the hallmark for survival. This is where the ventilators work. And this is where, it depends on how good you would survive. So this is something which is very important. From the environment, the oxygen must go to the mitochondria. It goes through lungs. blood gets oxygenated, and when it goes to the lungs, most of it, 98%, is bound to hemoglobin. Now remember this figure, 98% of oxygen is bound to hemoglobin. Only 2% is going free as oxygen, as unbound. Now, ABG talks about this 2%, whereas pulse oximetry talks about 98%. You might ask then, if it is so, then why is ABG the gold standard for oxygen issues? The reason is both are equally important. Free oxygen is the driver. It actually takes oxygen from environment to the mitochondria. So this drives the load of oxygen from one place to the other place. The load which is carried by the hemoglobin is determined by the pulse oximeter. And when the blood goes from the tissues to the lungs back again, this will be the central venous blood gas and saturation. So we'll not touch of this at this point. Now, whenever I've taken this lecture, people ask me as to, if you buy a pulse oximeter, how you would know that the pulse oximeter is reliable. So one extremely simple, very useful test is, when you use a pulse oximeter, measure your own heart rate by putting your hand on the radial artery and try and correlate that with what the pulse oximeter shows. If it shows the same heart rate, then your pulse oximeter possibly is doing a good job. Second, you can see the red mark, and at one point is almost constant, but intermittently vibrating at the other point. The intermittent vibrations in that emitter makes the pulse oximeter better and mostly properly working as compared to the other one. So these are some simple tests that you can use, apart from the fact that please look at the manufacturer and their certifications. Because some of these come out with literally nothing mentioned as to who is manufacturing and who are the certifying authorities. These are very, very important things, because we've seen a lot of major issues happening if the pulse oximeter is not working correct. Now, this is how the basic principle of pulse oximetry works. The infrared and red light has different absorption of wavelengths. The red band has an absorption more for reduced hemoglobin as compared to oxygenated hemoglobin, whereas the infrared band at about 950 has the reverse. So the light of two wavelengths illuminates hemoglobin in blood, and through the microprocessor, which is a part of a small little pulse oximeter that you see, gives us the calculation of saturation of hemoglobin. It's extremely important to understand that it measures the saturation of hemoglobin. Now, what does it really mean is, we'll see in the next slide, but there are some pulse oximeters. I'm not having any commercial interest in this product, but for example, if you look at Massimo technology, this is a superior technology as compared to the conventional pulse oximeter. So if you have one of those problems which really needs a very critical analysis, this technology should be used, because here the emitters are 5, and the 5 emitters emit lights at different wavelengths. And also this can decide your perfusion index much better than the other pulse oximeters. The only disadvantage is, as good things come with cost, this is costlier than the conventional pulse oximeter. Now, the pulse oximeter, when the light gets emitted from one end and goes to the other end, the light needs to be fragmented into varieties of zones. So absorption of pulsatile flow, which is essentially arterial, absorption of non-pulsatile flow, and venous and tissue oxygenation. All these have to be transgressed when the red light goes from the emitter to the detector. I'm slightly going fast because of want of time. So pulse oximetry is rapid, is non-invasive, and is a continuous monitoring of saturation, which is a wonderful thing. And it does come with limitations, but honestly, this is something very good. Nikhil, take the phone. So this is something which has been used day in and day out. Now, smartphones are smart and they are everywhere. So, like for example, good phones can detect a pulse oximetric saturation by using a gadget attached to the pulse oximeter. Like you can see here, one of the MESIMI probes is attached to the pulse oximeter. But remember, a lot of smartphones, Android and iPhone, have these so-called apps which measure oxygen saturation. No, they're all bogus. They don't measure the saturation. But I have actually seen this happening. These apps are some rough calculations depending on the brightness of the light which is emitted from the camera. But this is in no way kind of certified to be used as a pulse oximeter. So those apps are not the ones which you should rely on. If you have a gadget which is a pulse oximetric probe, you can attach it to say iPhone or some Android phones, and these gadgets can then reflect those readings on the phone. So these are reliable, but the apps standalone have no place in measuring saturation. Now, as I said, oxygen is bound to hemoglobin and hardly 2% is dissolved in plasma. So hemoglobin of 15 grams when fully saturated will have about 20 ml of oxygen. One last thing, extremely important, delivery of oxygen is a cardiorespiratory function. If you, just because you have saturation of 100%, if your perfusion is not adequate, then your patient will be always hypoxic. Tissue hypoxia will be almost there if you are not adequately perfused. And to go with it, if you have low saturation, it will be the worst combination. So when we talk of saturation, our focus is on lungs. But remember, heart plays an equally important role. So oxygen delivery is a cardiorespiratory function. Now, this is something extremely important, just to emphasize the fact that saturation is a percentage. So I'm trying to show you some transport buses. Fortunately, as the roads are good now, they fly very well. So the top one is carrying about 5 rows of, about 10 seats. All the seats are occupied by oxygen. So the red dots are oxygen. And all the seats are occupied means the saturation is 100%. The middle seat shows about 4 seats of hemoglobin. All of them are occupied with oxygen. All of them have this occupation means it's 100% saturated. Go down and now you have many more seats. All of them are occupied by oxygen. Saturation is again 100%. Now the driver is our free oxygen. This driver is assessed by blood gas. It drives the bus from one end to the other end and carries the passengers with it. So driver is ABG, the passengers are the saturation measured by pulse oximeter. So this is something very, very important. Like for example, someone with saturation of 100%, can this baby be hypoxemic? The answer is you ask for hemoglobin and then answer this question. If his hemoglobin is 4 grams, even if he is 100% saturated and the pulse oximeter shows 100% saturation, still the blood is containing less oxygen. The other way is true. For example, there's a newborn baby with hemoglobin of 24 grams and shows about 80% saturation. Though the saturation is 80%, mind you, it is 80% of 22 grams. So the oxygen in his blood is adequate. So you don't have to get into the NICU and get some oxygen for him because it is 22 grams hemoglobin and 80% of that will be good amount of oxygen in the blood. So please remember this saturation as a very important concept. As I've told you, VQ abnormalities are extremely important. You can see here an adequately functioning alveolus on the left side, where the blue blood is becoming red. On the other side, the blue blood remains the same. So there's a mismatch between alveolus and the pulmonary capillaries. So pulse oximeter gives you a good indication of what's happening here. But better evaluation would be by doing an ABG. Now, the involvement of, the more peripheral the lesion is, for example, the pleural involvement by and large, would not affect oxygenation as much as the central involvement would be. So some of the CT scores on COVID lack this important issue. So peripherally placed lesions just near the pleura may not be as much, or a pleural involvement may not as much affect oxygenation as the parenchymal involvement would be. Use this app. This is available free on your phone. Go onto Android Play Store, on iPhone Apple Store. Can put my name, Dev Pujari, and you see all the apps. This is a very useful app which calculates for you the content of oxygen. By and large, it should be around 10 to 12 minimum. So whatever saturation you get, feed that, right? And you will get the content. And when you look at the saturation, your focus should be the content. I explained you that one of the important factors would be hemoglobin, and this app will give you how do you measure the content. Now, this is what should you be all looking forward to. Unfortunately, this app, there are lakhs of people across the world who are using it. Literally every country is using it. Not so much in India. This is where the real crux of magnitude of respiratory distress lies. How easily oxygen goes from the alveolus to the pulmonary capillaries. Please use a app again on both of these. So this explains to you how the blood, as it goes from the arterial end to the venous end, releases about 5 ml of oxygen. It's this journey through this to the other end, which is what we look for as for transfer of oxygen to the tissues. Where it really matters is mitochondria is concerned. Again, this is also equally dependent on perfusion. So remember, saturation below 90 needs close observation, very close observation. You saw the curve, this has been taught to us right from first MBBS. I must have taught hundreds of times, but still people don't understand the usefulness of the sharp decline when the saturation goes to below 90. Absolutely critical. So less than 90 is seriously worrisome, and you should be very closely observing this patient. I'm going to rush through some of the abnormal hemoglobins, like for example, carboxyhemoglobin, which could falsely reassuring you results on normal or almost normal pulse oximetry. For adults and some juvenile diabetics, remember HbA1c greater than 7% could sometimes overestimate saturation. So diabetics, not very well controlled, or almost more than 7% of HbA1c could affect saturation. Methemoglobinemia, I'm sure you all know, have seen the saturation is almost fixed around 80. And these patients, if you have given oxygen, their PaO2 could be even 200, 300, and the patient could be still hypoxic. This is the way you diagnose. And the moment you take the blood out, you will see that, and the color of the blood can help you. I have a lot of videos, but because we don't have time, I am not able to show you, but that will easily give the diagnosis of methemoglobinemia. Some of the vital dyes, for example, indocyanine, used for some angiography in eye and other places, can also affect saturation. So friends, remember, a very interesting experiment that I did in my house. So see the pulse oximeter which I'm using, and see how it suddenly shrugs off. See what's happening. This is the interference of the working of a couple of these equipments. We would never realize that the electrical interference could happen in some of our gadgets. And this is the red light which is affecting this. Now, even the conventional light could have part of frequency of red light, which sometimes could affect. So you have to be very careful. Of course, there's a huge list of causes which could give you wrong readings, including nail polish and all that. But I just want to give you a message that if suppose you're not able to correlate the saturation, then look for some of these things. Now this is extremely important. Just about one slide on so-called happy hypoxia. Now see here, onset of symptoms and dyspnea. This is my own slide, which wonderfully explains the complex area of happy hypoxia. Now, what happens in COVID is, I call this as pulmonary vasculoplasia. See, the typical ARDS involves the tracheobronchial tree, the terminal bronchus, and the alveoli, and impedes the oxygen getting from the alveoli to the pulmonary capillaries. Now, pulmonary capillaries are around the alveoli. They are autonomically governed, but unfortunately, the receptors for breathlessness and dyspnea are not located here. They are more in the tracheobronchial tree. So, when the pulmonary vasculature is involved, you could almost die of hypoxia without getting that feeling of dyspnea or breathlessness. Because we have been teaching physiology for years, we talk of J receptors. Most of the distribution of these receptors is on the tracheobronchial tree. So this could even happen with pulmonary embolization. Some of these adults could become hypoxic, but they may not realize, they may not become breathless. So this is how, patients with COVID go through this trouble. They would prefer to be in the house because they would not like to go to the hospital for varieties of reasons. They don't feel breathless. They're otherwise comfortable. And while being in the comfort zone for too long a time, they could land up in a bad lung damage. And this is because of a different pathophysiology of COVID. So very interesting thing. COVID patients could be at home, breathing comfortably, not dyspneic, but would inhale large amount of tidal volume. It's almost like they have been on a ventilator for some time. So by the time they come to the hospital, like this has been a lot of Italian studies, where they found that they came to the hospital and a CT scan showed as if they were on a ventilator for a long time. I mean, the fellow has never seen a ventilator. Why do I see the volutrauma changes? The volutrauma happens because the fellow has been inhaling larger tidal volume and is not aware, is not breathless, is not dyspneic, is comfortable. May not be happy, but is not unhappy of this as well. And that makes things bad with COVID. Now, arterial puncture is still the gold standard, but being invasive, it still gets into a lower scale. Of course, if you want to really know everything about oxygenation, ABG is an absolute must. Now, see an interesting red line that I picked up from the Australian Journal of Anesthesia or Medical Journal of Anesthesia. The author says pulse oximeter is an imperfect device. I'm emphasizing this word, is an imperfect device with numerous potential limitations. Now you'll be surprised, a lot of people will not agree with this, but what it really wants to say is that pulse oximeter becomes less and less reliable when the saturation goes to less than 90. And that's where you want it. That's where you want the usefulness of it. So it's one of your friends who, when you really need, is not there with you. It's good with all is getting life is getting all right. Pulse oximeter is good. Okay. But when it's been bad, then that's where your ABG would be useful. And that's where you will have to be very, very sure of what the pulse oximeter is showing. So that is what, it's not a very perfect device with this less than 90. Now, there are certain other areas, like they can be used. Like I had an occasion I was referred to see a patient, an adult, with no place to keep a pulse oximeter device. This man had Hansen's, and all his fingers, all his toes, ear, nose, everything was severely affected, and he had COVID. So sometimes these limitations could be very bad, and then there are certain sites which could be used, but of course they need the kind of technology. The actual device by which you measure pulse oximetric saturation is by co-oximeter. So pulse oximeter is actually calculating it for us, is actually not actually measuring it. And whereas co-oximeter actually measures the amount of oxygen on the hemoglobin. All neurons need oximetry. Now, this is the third point is very important. Babies with coronary heart disease, of the CHDs, 25% of them need a significant intervention immediately after birth. Now, please mind this statement. Significant intervention immediately after birth. Babies with CHD as a group. Now, if they're not picked up at birth, we could pay a very severe price. So this is a very important thing. All neonates must have pulse oximetric saturation done. Of course, you all know the use of pulse oximetry in preterm babies. We know the uptime for it. We know the limit on which we should be putting it for because of the risk of ROP. So now, someone asked me, which finger is ideal? So the WhatsApp University came out with a lot of literature. So a lot of patients are asking, so middle finger or ring finger, whatever. So there have been some studies showing middle finger. Now it depends on your deep palmar arch, right artery or left, which is prominent. But by and large, no much of difference, no much of clinical significance. So the articles coming out in New England Medicine after the one we showed middle finger have shown no significant difference. So any of these fingers could be good enough for this. So I must thank Shubhda and the bright IAP team, which is as techno-savvy and as update for the time. Thank you. Thanks a lot.
Thank you, sir. Over to Dr. Mustafa. Thank you so much, sir.
Next, our chairperson is Dr. Pradeep Jaiswal, sir. He's senior pediatrician and past president of IIP. I hand over the mic to him. Pradeep Jaiswal, sir. Pradeep Jaiswal, sir.
Next speaker, Dr. Vineet Wankhede, is pediatric neurologist, and he will be speaking on interesting EEGs. So I hand it over to Dr. Wankhede to enlighten us with his talk. Thank you.
Thank you, Jaiswal sir, for that kind introduction, and thank you IIP, Shubhda madam, Mustafa sir, Bodhankar sir, and entire team of IIP for this opportunity on my interesting topic, that's EEGs, which I day out doing. So the topic is like interesting EEG. Now, what makes it interesting is like nothing can be interesting if you're not interested. So I urge all of you to have a lot of interest in, because this is a very important subject and important modality to be used precisely in specific settings, which is very productive. You all know what is the role of EEG in pediatric practice. For the diagnosis and management of seizures, assess the status epilepticus is detection and control, identification of non-convulsive status, grade the epileptic encephalopathies, determine the level of awareness, and help in the supportive evidence of etiology and prognostication. So I have only 10 minutes. I will be discussing 10 cases with brief take-home messages. So the case one, as we all clinicians, we always like to discuss cases, and so this is the best way to give the inferences. So this is a case one. This is a 9-month-old male child, full-term normal delivery, uneventful perinatal history, development normal. And now the child, then the parents are complaining there is a head drops. So the head is dropping, just like a myoclonus kind of thing. So in this setting, what is the most important modality is always an EEG, because EEG is the only guiding tool for the diagnosis. Suppose if you have a normal EEG, your diagnosis is benign infantile myoclonus or myoclonic epilepsy of infancy. If your video EEG is also normal, then that during the time of jerk, still your EEG is normal, that definitely get a diagnosis of benign infantile myoclonus. If your ictal EEG at the time of myoclonus, if you have discharge and the rest EEG is normal, your diagnosis is myoclonic epilepsy of infancy, which may need valproate treatment for some a year or two. And if your EEG is showing hips arrhythmia pattern, as in the third case, your diagnosis is West syndrome, where your treatment is entirely different, antiepileptics plus steroids. So EEG is the only guiding tool in such setting. So always do an EEG when your child, whenever the patient comes with a head drops kind of thing. So that's case one. So 7-year-old male child with a full-term normal delivery, normal perinatal history, near normal development. So little delay. Now have a recurrent episode of motor arrest. So a child is having a recurrent motor arrest. So in this setting also, the only guiding tool is an EEG, because if your EEG is showing a 3 Hz spike and wave discharge, your diagnosis is childhood absence epilepsy, where your treatment is only 2-year valproate. If your EEG is totally normal, you can think of the differential as daydreaming or something like that. If your EEG is showing a generalized burst, your diagnosis is juvenile absence epilepsy, where the duration of treatment may be little longer. So EEG is the only guiding tool if you have a recurrent motor arrest as a predominant symptom. Third case. So this is a 4-year-old child admitted with acute febrile encephalopathy. Now going inside ICU. Now the child is admitted with acute febrile encephalopathy. You have 2 episodes of seizures and you have a persistent altered sensorium. Someone made a diagnosis of viral encephalitis. CSF is not giving much clear picture, even your MRI. So EEG is a valuable tool in such cases, not only for the diagnosis purpose. If you have plates, lateralizing epileptiform discharges, you can think of HSV encephalitis. If you have triphasic wave, you have to think of metabolic encephalopathy. If you have delta brushish kind of thing, you may it's a pointer for autoimmune encephalitis. If you have biplates, again you are going for some viral encephalitis kind of thing. So important thing is it not only gives the severity, but it also tells you about clues about an etiology, so that your investigation can be directed that way. Case 4. So if you have 7-year-old female child with a normal development and sudden onset of jerks, so sudden onset of a myoclonic jerk, and these jerks are progressively worsening. So now it's definitely the 4 differentials, important differential in a 7-year-old first time. So SSP, if you are superimposed periodiform discharges, the discharges look exactly identical as if you are superimposing on this, as in the first EEG, your diagnosis is subacute sclerosing panencephalitis. If you have slow spike wave at 2 to 2.5, your diagnosis is Lennox-Gastaut syndrome. If you have a normal background with a generalized discharge, your diagnosis is idiopathic generalized epilepsy. And if you have a very bad background with a very dirty polyspike wave of generalized discharge, your diagnosis is Doozer syndrome. So it's important for a syndromic diagnosis of epilepsy and also for the deciding the further management. Now the 5th case, 3-year-old male child is developmentally normal, admitted with a traumatic brain injury and persistent encephalopathy. So this is almost like a comatose child with a traumatic brain injury. Here, you have to use EEG as a tool for assessment of severity. So if you have grade 1 encephalopathy, you will have almost normal background with slightly suppressed. If you have grade 2, you have diffuse delta kind of thing. If you have grade 3, it's like a burst suppression pattern, and grade 4 almost like a brain dead. So it's an important tool for the assessment of the severity of the encephalopathy. Case 6. So neonate with a recurrent seizures since day 3 of life, initially normal, 2 days. Sepsis workup, that's a common thing, negative. But the seizures are drug refractory. And the type of seizures is erratic myoclonus. These are all pointers for the inborn errors of metabolism. So if you have different types of EEGs, so there are 2 syndromes, which is called as Aicardi syndrome and Otara syndrome. If you in both the syndromes, you have burst suppression pattern as a finding. So the burst type of burst and the suppression, you can differentiate whether it's Aicardi or Otara. If you're Otara, you will direct the pathologist, like you will go for a CT head or MRI first. And if you're Aicardi, you will go for a metabolic evaluation first. So it's an important guiding tool for evaluation in case of neonates if you're presenting with this site of symptomatology. 7-year-old female with a full-term normal delivery, normal perinatal period, developmentally normal child, and now the first episode of unproc seizures. This is the important way the child comes to a pediatrician. So it's an important tool for the choosing an appropriate anti-seizure drugs. Now the anti-epileptic drug is called as anti-seizure drug. So if you have focal pathologies, you choose the drugs like carbamazepine or oxcarbazepine or phenytoin. If you're focal into secondary generalization, you will use the same drugs, but if the generalization is too high, you will always prefer valproate or levetiracetam. And if you have primarily generalized epilepsy, you will definitely choose a levetiracetam or valproate as a drug of choice. So it's an important tool for choosing also an appropriate anti-seizure medication. Case 8. So this is a 6-year-old male child brought with a complaint of extreme irritability and jitteriness since birth. And the seizures are again recurrent and they are refractory since last 3 days. So again, it is like a pointer towards some different cause. So EEG is showing a burst suppression pattern. So what we did, because the two things are important, this is extreme irritability and jitteriness in spite of recurrent seizures. Usually what we expect is because of recurrent seizures, a persistent encephalopathy. So in spite of recurrent seizures, if the child have extreme irritability and jitteriness, this is a pointer for pyridoxine deficiency. So I have given during an EEG, I have given the intravenous pyridoxine. And as soon as you give a pyridoxine, you will get a totally almost a normal background. So this is an important, interesting EEG, which tells you that I may be dealing with a case of pyridoxine dependent epilepsy. So here the treatment is lifeline pyridoxine, but this is an important thing which you can do if you are suspecting pyridoxine dependent epilepsy. Case 9. So 6-year-old female child with the first episode of nocturnal seizures, diagnosed as a Rolandic epilepsy. This is again an important, very common for accounts of 15% of total epilepsies. Parents opted to go for an AED and she was put on oxcarbazepine by a pediatrician. Focal seizures stopped. So always we feel that, okay, I get a control over seizures, but the scholastic performance got worsening. So if you start any anti-epileptic drug, always the scholastic performance should improve. But if you're getting a deteriorating scholastic performance or any new onset of seizures after starting a drug which is used for the focal epilepsies like carbamazepine, oxcarbazepine, phenytoin, they are lamotrigine, these are the notorious drugs for getting the epilepsy worsen. So you may have an atypical progression of epilepsy syndromes. Though this is a drug of choice for the Rolandic epilepsy, if you use this drug, and if in 15% of patients, you may get this atypical progression into a different type of syndrome. So this was a case of Rolandic epilepsy. And now if we are repeated in EEG just by doing a impaired scholastic performance and a onset of new type of jerks, which are primarily generalized like myoclonic jerks or GTC in a patient with a focal epilepsy, you should suspect these entities and you should repeat an EEG. So case 1 has a CSWS. This is called as continuous spike wave activity in sleep, or also called as status epilepticus in sleep. So this is a type of entities, and this is the way we monitor the children if you have a clinical suspicion. So case 2 has gone into a Landau-Kleffner syndrome. Now this is again a variant of like Rolandic may progress into this variant where there is acquired aphasia after starting off drug. So this is another thing. Third thing, if you have a, so this is an important take-home message that whenever you start a child on a drug specifically used for focal epilepsies, even this is a case of focal epilepsy, in 10 to 15% patient, you may get such worsening. And always you have to have a clinical suspicion like a progressing deteriorating school performance after the start of drug, onset of new type of seizures after the drug. These are the clinical pointers for whether I may be dealing with a case of this thing. But the guiding tool and the important gold standard tool is a EEG for diagnosis, whether I'm getting this worsening patterns or not. But you have to think it clinically before doing an EEG. This is the last case, a 3-year-old male child with a normal birth history, born of 3rd degree consanguineous marriage, developmental delay, recurrent seizures, initially had spasms, later has a myotonic seizures, and on examination, child has a global developmental delay with microcephaly. Now, there's a definite family history in this child, and I will not tell you the complete workup because there's hardly any time or video, but this child has an absence status on fasting EEG. First EEG was done in a fasting stage, and somewhere else it was repeated in a well-fed stage. So well-fed stage is EEG is normal, almost normal, and fasting is showing an absent status. Now, this is something which is the hallmark of GLUT1 deficiency. So we have learned so many things, but the fasting and the well-fed EEG is different in one entity that is called as GLUT1 deficiency, because there is a cerebral transport of glucose is lacking at the CSF level. And this is the last case. This is a 5-year-old male child with a febrile status epilepticus, initially controlled with 2 antiepileptics, and seizures continued thereafter. So EEG is an extremely important tool in managing the cases of status epilepticus, especially the refractory ones. So if you're started on 2 drugs and still you're getting the seizures, always do a continuous EEG monitoring to get a proper control of seizures electrographically, because this is an important thing which we all are missing. We must do an EEG and that too with the continuous EEG to get a bus suppression pattern, which is like a control of status epilepticus. So it's an important tool for managing the status epilepticus. This I wanted to highlight. And the last thing is the non-convulsive status epilepticus. If you have a persistent encephalopathy which is unexplained on any cause, it's not compatible with the MRI, then you should suspect a non-convulsive status epilepticus. You have to think of it and do an EEG, and which can be diagnosed only on the basis of EEG. So what is my take-home message to all of you? EEG is a valuable tool in the management of child presenting with seizures. Utility of any tool depends on the in-depth knowledge about it. So pediatrician may not be aware of the findings of EEG, but they must know when to order an EEG with the clarity of purpose. Just don't jump on getting an EEG done first, but always think what you're exactly want to find it out of it. So the purpose is to be very clear. EEG is not only helpful for the diagnosis and the management of epilepsy, but also an important tool for the monitoring and the prognosis. Thank you. Am I? Hello?
Thank you, Vineet sir.
Yeah.
Now I will hand over the mic to Dr. Radke sir. He is past president of IAP and a senior pediatrician. And Dr. Radke sir.
Yes, am I audible?
Yes, sir.
Yes.
So after EEG, it is now.
Please put on your video. Yes.
After EEG, now it is after EEG. Now we are going to have a talk on ECG. Dr. Abhay is with us to give talk on this. He is Dr. Abhay Bhor is MBBS from prestigious KM Hospital, Mumbai, and he has done his MD from Bombay at Sion. Besides that, he has completed his specialty, the pediatric cardiology, by MRCP-CH in 2004 and CCT in pediatric cardiology from UK in 2009. He is practicing in Nagpur since 12, and he is a pioneering pediatric cardiologist in Nagpur. He has also established interventional cardiology in Nagpur, in Heart Hospital at Amravati, and also Kasturba Hospital at Sevagram. He has got 6 publications to his credit, which includes one in prestigious journal like Lancet. So we have got 2 cardiologists who is interested in cycling and trekking to guide us on the ECG. Dr. Abhay Bhoer. Hello.
Sir.
Was I audible?
Yes, sir. Yes, sir. Dr. Bhoyer, please take over. Hello.
Dr.
Bhoyer. Dr. Bhoyer.
He is there, but he's not audible.
He is not able to speak. Dr. Bhoyer?
No, he's not audible. Madam, we can go on next session. And then...
Yeah, I think.
Hear me?
Yes, sir.
Hello?
Yes, sir. You're audible
yes,
now.
Sir. Yes.
Oh, I'm so sorry for this glitch.
I'm thankful to Team IAP for this, inviting me for this talk. This has been a really enlightening session so far. I'm just going to talk about insights into pediatric ECG. I just listening to Vinit's talk, I felt that mind chooses what it is trained to see. All Dr. Vinit's EEGs look to me like a ventricular tachycardia. So I thought, I will just try to give you some glimpses of basics of the ECG and then some interesting cases. What is heart? In terms of ECG, it is essentially a battery which is situated in your heart. This is the easiest way to understand ECG. It just generates some electrical currents, and we try to develop a link between the heart and surface of body with the help of ECG. So what heart does is it encodes some message in the form of electrical signals, and those are picked up by ECG from various angles, and those are summated to give you a graph on the ECG. So essentially, that is the crux of reading ECG. If you look at this basic slide, and if I were to show you, uh, so this is a SA node, sinus node. Electric current generates from here, goes to the AV node via atria, and then they are transmitted to the ventricles. And this is how you get a P wave due to the atrial contraction. Then there is a PR interval followed by ventricular contraction, which is QRS complex, and then there is a repolarization, which is T wave. One important aspect is this is all generated by action potential. And if you notice, the action potentials of SA node and AV node are slightly slurred. They are not as fast as atria or myocardium, and that's because these are governed by calcium current, whereas these are governed by sodium currents. So this is another basic of understanding a ECG. Now, if you look at this Einthoven's triangle, essentially he started off with 3 electrodes,
Sir,
limb
your
leads.
slides are not visible.
My slides are not visible. Oh my God, what shall I do?
Share the screen, sir.
Yeah, I am. Just a second. Just a second. Sorry. I'm sorry. Sorry. Hello. Can you see
Yes, sir.
now?
No, sir.
Can you see my slides?
No, sir. No, sir.
Hello.
No, sir. We cannot see.
You're not seeing my slides at all. Okay. Now?
No, sir. The option is to share is at the bottom. You can
Yeah,
start
I
share.
shared. Yeah.
The
I
slide
did
might
that.
not.
Okay. Let me just see. Can you see now?
No, sir.
That button is frozen actually, which I'm trying to share.
Okay, sir. You can continue.
I don't think you will be able to see my slides. Without slides.
So can you rejoin? We'll take.
Yeah, I think I will.
10
Yeah.
minutes.
I will
After 10
rejoin.
minutes, you can go, sir.
Yeah. Please. I'm sorry. Yeah.
Okay. Dr. Shubda, madam, continue.
नितीन सरांना बोलवशील बरं.
Shubda, madam, you can continue, madam. You can take the next lecture.
Okay, Dr. Bhoyer, I am seeing him on the screen.
Madam, you continue with the second lecture. He's going to rejoin.
Okay, right. So we now move on to our last but one of the most important sessions of the day for 2 reasons. One is because this year our theme has been building bridges, breaking barriers, and this is one of our attempts to build bridges with many persons in the community who are stakeholders in child care, be it parents, teachers, or the society. Secondly, we also felt that we must need to go into the scientific details with empathy and sensitivity to the social issues which the parents and the community at large commonly grapples with when they are faced with sick children. So we have this session on social pediatrics with the most brilliant minds in the field. And the first one is going to talk on a very different and subject which is rarely discussed or touched upon in any of such scientific deliberations. So I am very happy to introduce our first speaker, Dr. Brinda Sitaraman, who is a faculty from Chennai, and I invite Dr. Kamlakar Devghare and Dr. R.G. Patil, two very senior adolescent pediatricians of Nagpur. Both have been officials of Adolescent Health Academy, Dr. Patil being past president and Dr. Kamlakar is present treasurer of Adolescent Health Academy in Nagpur. Very senior and experienced persons. I request Dr. Patil and Dr. Devghare to take over, please.
Am I audible, Shubda?
Yes, yes.
Okay, fine. Good evening. Thanks to Dr. Shubda Madam, President of Academy of Pediatrics, Dr. Mustafa, and all the office bearer of Academy of Pediatrics. As all of you know, during the terminal illness and the cancer, most of the patients or adolescents, they become frustrated and they suffer from mental disorder. So even they commit suicide. So along with treatment, they need some psychotherapy. We are having a well-known speaker, Dr. Brinda Sitaraman. She is a psycho-oncologist from Bangalore, founder director of Center of Psycho-Oncology for Education and Research, Bangalore. She has a special interest in adult and pediatric psychology and preventive psycho-oncology, and she is a recipient of Occasional Excellence Award for outstanding contribution. Now it says that it's not a life or the years to be added; it's a life to the years to be added. So over to our speaker, Dr. Brinda Sitaraman, for further proceeding. Madam, we welcome you.
Are you able to see my slides?
Yes, yes, ma'am. Just make it full screen. Yeah.
I think I have.
Yes,
I think
yes.
I have. Are you able to see now?
Yes, yes, yes.
Yeah, yeah.
Okay. Good evening. Thank you for this opportunity. I think it's a very, very important aspect in overall pediatric oncology care, as it were. Are you able to see the slides? I mean, okay. For the next 10 odd minutes, the task I have is just to give you a bird's eye view of pediatric psycho-oncology. I'm saying bird's eye view because it's a very, very broad subject, and therefore, because of paucity of time, I will not be able to do justice if I go in depth into all aspects of pediatric psycho-oncology. I think if you really flip through the pages of medical history, what would meet anybody's eye is the way patient was really cared for. I think there was due respect to the human mind. And all aspect of, whatever care was made available for the patient was against the backdrop of, the holistic care, as it were, in the paradigm of the psychobiological model. But with the passage of time, there was this major shift in this belief that if you fix the body, the mind would fix for itself. And therefore, all focus was on physical medicine, and we started to break body into minute parts, and super specialties started to emerge in various aspects. And cancer medicine was not left very far behind. And much of the progress in cancer medicine, incidentally, happened because of pediatric oncology. Mega strides were made in medical therapies such as surgery, chemotherapy, radiation, bone marrow transplant, so on and so forth. All of which really pushed the survivorship, as it were, whereas in the 70s, where we had limited survivorship, today we're talking about, anywhere in the zone of 85% or so. All of which, while it is very heartening, has unfortunately come with a very heavy price. Survivorship obviously has come with a serious cost. And the cost is not only of acute side effects, but also of late side effects, such as close to the zone of nearly 70% of young adults happen to have the, experience the aftermath of aggressive cancer therapies, all of which seriously impacts their quality of life. Therefore, we are back to this past wisdom that if you really break body into parts and discount mind, it is not really holistic care. And this thought has really brought about this unique aspect of recognition that psychosocial care is as important in medical management. Thus, there was this dawn of the new era in the late 1970s. The science of psycho-oncology emerged. And all thanks to this grand lady who is known the mother of psycho-oncology, Dr. Jimmy Holland. Incidentally, a lot of people who are in cancer care would recognize Dr. Holland's contribution, who has made hallmark, inroads into cancer treatment, namely the development of chemotherapy, the cancer and leukemia group B. And Jimmy happens to be the wife of this legend, Dr. Holland. Various dining room conversations actually brought about revolution in the area of cancer care, as it were. And like I mentioned, all thanks to this revolutionary Dr. Jimmy. Psycho-oncology is a science that addresses the psychological issues and concerns of cancer patients and their families. With time, the base of this science has expanded to include anywhere from preventive oncology to palliation, end of life, and even beyond, because even after we have lost patients, families continue to come for grief and bereavement management. Oftentimes, this is a media favorite question for me, where people ask, what is the scope of psycho-oncology? And I tell them it's womb to tomb and even beyond. Pediatric psycho-oncology is a subspecialty of psycho-oncology, which addresses the psychological concerns and issues of little children, their families, and when we talk about families, the siblings are included as well. For the progress of any science, it's important to gauge in terms of the development, in terms of what the science has contributed in terms of research as well as in theory. So when you really look at what was happening in the early 60s and the late 70s, much of whatever was happening, like I mentioned, was based on observation, because at that point, cancer treatment was limited and there was very limited survivorship as well. So diagnosis was never revealed and parents were left to kind of the death of the children. Surprisingly, what was also observed during this time was that children were not to be deceived by avoidance or false reassurance. They seemed to know something more than what we as clinicians or parents believed that the children know or they do not know. It was actually after the 70s when the cancer therapy started to improve and survivorship started to improve, a lot of research attention was given to survivorship and the psychological functioning of children and their families. Project Omega was like a turning point. I would say it brought about some hallmark papers to draw home the attention of the psychological toll that the patients and their families really go through. It was at this point that mental health professionals were seriously engaged in kind of bringing about open communication with patients and their families. Informed consent became the order. Decision-making, we were involved to facilitate the treatment process and so on. It was also noticed that pain and distress experienced by these children was largely due to the past experience or the past exposure, the age of the child, the parental emotional distress itself, and the current levels of coping and so on. While bulk of studies started to show that much of these children and their families are resilient, they're able to cope and make their adjustments very well, what really started to meet the eye was the bottom of the slide. 20 to 30% of children had to endure significant clinical difficulties in terms of adjustment, anxiety, and depression, which was warranting professional psychological intervention. Therefore, bulk of these research also now started to kind of move towards theory building. As survivorship started to improve, the theory started to look at the developmental phase or the human life cycle, as it were, to understand what really are the psychological impact or the psychological toll, as it were. The simplest of all this is the Erikson psychological developmental stage, which generally shows you the normal milestones in terms of the psychological development for the child as well. When cancer strikes, what was noticed was that there is a total distortion in the psychological makeup of children based on their age and development. This insight started to kind of bring into sharp focus the impact of pediatric cancer on various developmental issues. In the preschool phase, while the child is still young, what was found long-term was the adjustment difficulties that these children endure as they grow. In the school stage itself, the isolation from peers, having to miss school and so on, also started to have a huge impact in their overall growth and development. And therefore, during adolescence and young adults, because with survivorship improving, these children live to see adulthood. There was disruption in their school and social activities, including physical intimacy, and building relationship was kind of seen to be hampered. The impact was also noticed not just on the child, but also on these hidden patients. Hidden patients are their family members, mainly parents and siblings as well. They also endure enormous amount of psychological trauma. Thus, there was a lot of insight coming through research in the late 1990s about the aftermath of cancer treatment on children. And what was noticed was across board, be it radiation, chemotherapy, or even surgical resection, seemed to have long-term side effects, which kind of hampers overall psychological growth and functioning. And the results, what really was to kind of, was really hitting, in between the eyes, as it were, was the neurocognitive difficulties that was found with whole brain radiation. And this is something that started to kind of, draw the attention of clinical, therapists. Much of the studies also started to show that open communication with the child as well as the family resulted in better adjustment and overall psychological better functioning, as it were. Therefore, while survivorship is very heartening, remission rocks, but the side effects can be rocky. Because being cancer-free does not mean being free of cancer effects. So survivorship obviously comes with a very heavy price from all angles, be it physical, psychological, neurocognitive, as well as social and occupational functioning. Overall, there is a disruption in these children. This is where very proudly I can say that psycho-oncology actually changed the landscape of cancer treatment. Much of the protocols currently available is because of wealth of information that has been kind of doled out from psycho-oncology. So therefore, major modifications started to happen in cancer therapies. I think whole brain radiation is virtually out of the window now. The protocols now really look at the quality of life issues of these children who will now emerge to be young adults. Therefore, While all this is important, it's equally important to pay attention to the psychosocial impact of cancer treatment on the child and the family. Otherwise, it has far-reaching implications on cancer treatment. Non-compliance is very well known. Poor tolerance to treatment, including survivorship. There is a lot of data to show how psychological well-being can impact overall survivorship. Having said this, mind is very fragile and it has to be handled with a lot of care. I know very often loose terminologies are used, such as counseling, talking therapies, and so on. No, I'm afraid it is not as simple as it's made out to be. Psycho-oncology is a very complex science, and therefore it needs expertise, primarily because, first of all, when you see emotional disturbance, it could be because of a disease process. It could be a metastatic process going on in the brain. It could be because of electrolyte imbalances, such as sodium and magnesium shifts. Or we know that we so liberally use steroids with young ones. Could it be steroid induced? Therefore, drug induced aspect needs to be considered as well before labeling and saying that this is purely psychological or behavioral. Therefore, the recommendation is that psychosocial screening for these young ones are a must. The screening will put up the red flag to forestall any problems in the future if we take corrective steps at the right time. But having said that, routine screening without proper psychosocial resources in terms of qualified psycho-oncologists is actually unethical, because we've opened up a whole can of worms, and if we really have no ability to heal them, then we ought not to be engaging in opening up or raking up emotional issues and concerns of the child as well as their families. Equally important in psychosocial care in pediatric setting is not only looking at children, but parents and siblings as well. Take very close note of their coping mechanisms, and which involves thorough behavioral analysis using standard tools and techniques. That is where the expertise is very important. What is recommended is also the neurocognitive evaluation, because there is convincing evidence that treatment as well as the effects of the various therapies itself can bring about neurocognitive shifts in these children, which can later lead to learning disabilities and so on. Therefore, early detection enables us to engage in rehabilitation and remediation measures. The early detection of the psychological difficulties also creates a clinical algorithm or the clinical pathway, as it were. Based on the individual needs, the levels of distress, and so on, you can create a triage in terms of what kind of psychosocial care is required for these children and their families. The good news about distress is it's treatable. You may want to use just drugs, or use various psychological intervention techniques, or including complementary therapies such as art therapy and so on. Very often it is the combination of these that really restores these children very effectively and makes them productive individuals. There are a whole lot of techniques, scientifically proven techniques, and tools available in the whole gamut of pediatric psycho-oncology space. Each one of them is a psychological technique that is scientifically proven and requires, like I mentioned, I cannot stop overstating, it requires expertise to handle even the techniques, to implement them in the pediatric space, as it were. Equally important is, to make the transitions very smooth for the child to move into an adult-focused care, to determine the readiness for this transition, building enough information for the child now who's going to move into an adult zone. And that is where this comprehensive care of adult-centered environment is very, very important. Survivorship needs are multiple, and therefore they have to be addressed at each level, including as they move into adulthood. It is equally important to pay attention to their diet, substance use, and reproductive counseling, which is very often neglected. And very, very often these young adults are in for a huge shock. And you can see there is a lot of inbuilt anger because they were not informed of, the aftermath of so many therapies that they were subjected to. Therefore, survivorship care is completely comprehensive. It cannot be done by just one single specialty. It is multi-specialty involvement that really brings about better adjustment in these young adults. Now there are guidelines put forth, and the standard for psychosocial care is made available. Like the NCCN guideline, there are very clear guidelines in terms of the kind of assessments to be made and the kind of techniques to be used to bring about overall better adjustment in children and their families. Therefore, children who go through these portals of pediatric psycho-oncology, you find them to be better restored in terms of their motivation, tolerating treatment very well, and there is enough and more data even to suggest that the survivorship is also improved. The case in point that I would like to make before I sign off this talk is that we know very well in radiation therapy, children are often kept in isolation for their treatment, and very often, because children do not cooperate, anesthesia and sedation is the order to make sure that children go through radiation treatment. I'm not going into the details of the cases that I have, for you in the form of a video, but in a nutshell to tell you that majority of these children, particularly their parents, were shying away from radiation for multiple reasons. Either the child, cannot cooperate because, she cannot deal with hunger, because the children are left to starve because of their anesthesia and so on, or mothers were afraid of neurocognitive difficulties that the children would go through, and therefore they did not want radiation for the children and so on. So therefore, we used multiple behavior therapy techniques such as play therapy, storytelling, systematic desensitization, and so on. And you will see the results for yourself. Now, before I play this video, my appeal to all participants and the organizers is, please do not record this particular video. This has come with explicit permission, no doubt, but families of these children were very particular that this video should not be in the public domain, and we must respect the privacy and confidentiality of these children and their families. So I stress on this, please do not videograph or photograph any of these videos that I'm presenting now to you. I would appreciate if the technical support at the other end would run the video for me,